non l'abbiamo pensata di farle sedere poi qui, si alternano, dire come
Sì.
volete, cioè
Io
come
penso
volete
che sia
voi.
meglio perché è più interattivo. Molto più interattivo perché poi magari c'è una discussione.
No, però l'abbiamo prevista solo per la discussione finale.
Sì, la
Ok,
discussione
allora
finale.
così perfetto,
Sì,
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 va
sì.
benissimo. Al
Sì,
termine, quando
sì,
hanno
sì,
finito
sì.
ciascuno la
Vengono su.
propria... Benissimo.
In termini di deglutito il boccone, però è stato duro, è stato duro. avevo una piattaforma per essere sentiti. E quello un po' lì, quello che
Cinque
45,
minuti,
alle
45,
45.
sì, tanto poi è una complicata. Importanti. Una
Prima il capo.
Ladies and gentlemen, good morning. Welcome here at the Prada Foundation in Milan for a new activity of the human brain. We have started about 5 years ago to enter the area of neurosciences with the Prada Foundation. And today we are here for 2 days of activities in the area of prevention of neurodegenerative diseases. I think that all of us know very well how relevant is the problem of neurodegenerative diseases, how they are increasing due to the clear connection with the aging of population. It has been estimated that the proportion of people with such conditions, Parkinson, Alzheimer, multiple sclerosis, Huntington, will reach the level of about 150 million by 2040, 2050, with an incredible burden, not only for individuals, but also for the societies. Unfortunately, we know that no one of these conditions has a cure, as a solution. So what we have to do then is at least to try to reduce this burden, trying to prevent this condition. And this is the motivation of this meeting, because there are a lot of common pathways that are driving this type of diseases. And we thought that could be quite interesting if we confrontate each other and try to see where we are in different sections of the research in the different type of pathologies. Unfortunately, Miuccia Prada could not be here. She will join us this evening. However, he just sent us this communication. This new edition of Preserving the Brain shows how necessary it is to create an even stronger dialogue between the scientific world and the public of a cultural institution like Fondazione Prada. The themes of prevention and the active role of culture in this field concern everyone, and specifically younger generation. It is therefore crucial to accompany scientific research and dissemination with awareness-raising activities and a program of concrete actions capable of influencing our behaviors, involving those who deal with neurodegenerative diseases on a daily basis, not only from a strictly medical perspective. We are pleased that this international forum has become, as we had hoped during the first edition, a recurring appointment that helps to connect research centers with each other and with a wider and more heterogeneous community. Let me thank all the institutions, all the universities and research groups which have contributed to this type of event. We have organized, as you know, in connection with the convention we have here in these 2 days, also an exhibition. And the exhibition is the result of many different young researchers, so let me express my gratitude to all of them that made possible this possibility. The reason of the exhibition is that we would like to transfer from the academia seated here to the global population some messages, because the problem of prevention is a problem of every one of us. It has been estimated that one of out of 5 of us is really during the life, sooner or later meeting this type of problem. So I mean, it's really a common problem, and in collaboration with the agency of research, in collaboration with the European Academy of Neurology, Brain Health Initiatives, we are here just to give our support and contribution. So I hope that everybody will really enjoy the activities in these 2 days, and I would like to ask now the president of the European Academy of Neurology, Professor Moro, to come and to welcome.
Thank you very much, Professor Comi. I don't know about you, but really today I'm so excited and I feel really to be privileged because we are here today together because we want to make a change in the history. We want to make a change for the community. And I hope that by the end of these 2 fantastic days of this event, you will be going outside with the urge to do something to change this massive issue that we will see in these 2 days. As Professor Comi introduced, I'm Elena Moro. I'm a professor of neurology at the University Grenoble-Alpes in Grenoble, France. And I'm here today, besides to moderate, to participate with you, also to present a little something from the Brain Health mission of the European Academy of Neurology. A pause. So can help me with help.
Imagine the existence of a magnificent device, as beautiful as the world, as fascinating as the universe, a supercomputer, but much more powerful, unique, and personalized for its owner. It is always with you and can take you wherever you want. It can bring you back to the past and create your future. It works for you day and night, always switched on. It recreates you and recharges itself while you sleep. It is getting better the more it is used. It can adapt to any environment and change your environment. It is influenced by everything that happens around you. Processes all information inside and outside your body. You can use it to smell, taste, hear, and even understand without words, see, read, create art, communicate, and build connections, feel, have fun, learn, reward, research, and think even of things that do not exist, and love. It gives meaning to everything. It creates you and the world around you. It is the home of your existence. And all it needs is healthy food, clear water, clean air, protection, exercise, and people who care to run for 80, 90, 100 years. What would you do to make this possible? Let's do it together.
So this is the idea behind this brain health mission that, how can I move okay, let's see. Okay. Under this video, the idea is really, with the brain health mission, from the European Academy of Neurology, which is an umbrella covering the 45,000 neurologists in Europe, to be holistic, to be inclusive, and to get everybody, like Professor Comi said, in this brain health mission which covers all the world and all the individuals. So I have a trouble with this. So what is this, briefly? So the first point is to make aware the community. Neurologists, they don't even have an idea. What is brain health? What is this thing? So we need really, with this umbrella, to decrease the burden of neurological disorder and to decrease the incidence, to go to the prevention. So we are following the WHO definition of brain health, which will be illustrated by our excellent speaker in later. So we will have an epidemiologist talking about the burden in Europe and in the world of neurological diseases. You will be surprised to see how close is it and how bad is it if we don't do anything to stop it. So the aims is really to what is brain health, what is the basic understanding of this, and how can we optimize brain health. We have to support and disseminate with these events. We have to stimulate the public health policies and strategies to go through it. And as I said, work together. We can't do anything alone. We really need to have all the community, neurologists, psychologists, neuroscientists, everybody, politicians involved in this issue. Again. So there are several items that we try to foster, the global international agenda, supporting also their nation, Italy is one of them, having a brain health plan. So Norway, Switzerland, we want to help the community to have this strategic plan, fostering research, promoting education, and raising, as I said, the public awareness. We have done several activities, and we really want to work together to disseminate the awareness first, and then action that we can do together. So I will go through some that I don't want to bother you too much. So we have to cover the whole lifespan, starting from the kids. We don't only teach them how to brush their teeth. We have to teach them what is brain health and how can we make a difference since the beginning. So we went to the school in Austria. We went also in Helsinki, in Finland, to see how can we transmit basic concept and teach the kids since the beginning. So this is, for example, when we went to Helsinki to do this kind of activity. And then we have also established a training, an advocacy training for neurology to teach neurology, how to be advocate, how to go to the politician and to bring them this concept to be active at political level. You know that the European presidency change every 6 months in Brussels with the Queen. We had an event to stimulate politicians for brain health strategies. We went also to Italy for the G7, and we will see. And also, you know that we had the United Nations meeting in New York, and we went also there to be visible. It's not only the heart, it's the brain is moving also the heart. We have to stimulate the people, the community to take care of this area. And also we went to the European Health Forum in Gasten, where politicians, minister of health, they also go for new strategies to implement. And I'm going the wrong direction. And lastly, the G7, we try really to put in the Ministry of Health agenda the brain health, because there are other problems, we understand, unfortunately, especially today, but brain is the most important. We will hear over these 2 days, and at the end, we will be all convinced that brain health is the most important thing to promote at any level. And this is the last event in Italy, and we hope to be also next year in Calgary for the G7. So having said that, I'm going in the wrong direction, as you can see with this mouse. This is the call. As Professor Comi said, we have to work together. This is our strength. Everybody together to promote this brain health for everybody. And I think this event fits perfectly. We really want to thank Professor Comi, Mrs. Prada, and the Foundation for organizing this, because, as I said, these are things that really make changes in the life of the community. So this is what is my introduction. So we have several partners. So, and everybody is welcome to this partnership. So thank you very much.
Thank you so much, Dr. Moro. We now start our daily activity, please.
So having said that, I hope that you are energized and say, yes, yes, let's go with that. You have the program. Is a fantastic program covering, I think, very nicely the most important items of this area. And we start with the frame. What is the burden? What does it mean, a burden of neurological diseases? So we will have epidemiologists talking about that. For example, we will start with Dr. Lascuca. She is the epidemiologist who studied and they still work in the United States. She will give us really an idea of the burden worldwide. Then we will have the WHO idea and perspective. WHO is doing amazing work and is pushing really together with us, all the community, this idea and the prevention. And then we will have a talk about what we can do really to prevent. What are the modifiable and non-modifiable risk factors? So you see the menu is very rich. We will start with Amy Lastuca. She is, as I said, an epidemiologist working in the Washington University. So please, Amy.
Thank you so much. It's really an honor to be here speaking with all of you today. I work at the Institute for Health Metrics and Evaluation at the University of Washington. And I'm going to share with you our work on the burden of neurodegenerative disorders. So as Professor Comi mentioned, this is a really urgent area to focus on because we're expecting so much growth in neurodegenerative disorders. As of right now, there are already more than 72 million people experiencing one of these disorders. And as our population ages, is projected to grow dramatically. This chart here shows our projections for dementia, which is the largest of these disorders. And the cases are going to more than triple by 2050 if the current trends continue. And also Parkinson's is growing even more rapidly than dementia, so I'll be talking about that as well. Just to give a quick outline, I'm going to kind of quickly go over our methods that we use to estimate the health loss from these disorders, and then talk about neurodegenerative disorders in the context of neurological health loss more broadly. Then I'll talk about age and sex differences and kind of trends over time with these different disorders, briefly kind of touch on our work on risk factors, and then share a little bit of our recent work on the economic burden. So this is a screenshot from our website. It's called GBD Compare. GBD stands for the Global Burden of Disease. And that is kind of our flagship study where we estimate health loss for all health conditions. And this is showing you the health loss for people age 70 plus, and the red box is highlighting the neurodegenerative disorders. So it's kind of a visual representation of how much health loss these disorders cause. And to talk about our methods a little bit, when I say health loss, we often use this metric called DALY, or Disability Adjusted Life Year. And it's a sum of two different metrics that we estimate. There's YLL's years of life lost, And then there's also YLDs, or years lived with disability. So this figure showing you, this is representing someone's life, and like those yellow bars would be times where they had some kind of health condition or health loss, and it could be something sporadic, and they might recover, and we would add all the yellow together. That would be their years lived with disability, and then the blue is the years of life lost, so when they died relative to their expected lifespan. So for neurodegenerative disorders, we model dementia, Parkinson's disease, multiple sclerosis, motor neuron disease, and then we also have kind of a residual category that covers other conditions, with Huntington's being the largest of those. And we gather data from all different sources. We're using surveys, vital registration data, claims data. And we harmonize these data, put them into regression models, and then we can estimate the prevalence of these conditions by age and sex for every country over time. So to kind of zoom out a little bit and talk about all neurological health loss, I'm showing in red the neurodegenerative disorders that we model, and those are kind of primary neurological disorders. But we also look at neurological health loss from injuries, infectious diseases, nervous system cancers, neurodevelopmental disorders such as autism spectrum, congenital disorders, and neonatal disorders. And when we're talking about that wider frame of all neurological health loss, these are actually the leading cause of health loss if you kind of combine all of those conditions into one cause. And in fact, 43% of the world, so almost half of the world, has some health loss from one of these conditions. And you can see a very strong age pattern. So by the time someone is 95 plus, that's the last bar on the right. For females, the females are in red, it's almost 40% are experiencing some kind of health loss. So focusing back on neurodegenerative disorders, more than 10% of the DALYs of those disorders, of all neurological health loss, is from neurodegenerative disorders. And as you get to the older ages, that becomes, the effect of neurodegenerative diseases is more and more prevalent. So it's almost half by the time you're looking at people age 80 plus are experiencing health loss from a neurodegenerative disorder specifically. And dementia, of course, is a very common condition, and that's the fourth most common contributor to health loss among all neurological conditions. So here's just a visual showing how the burden is spread across the world. We can see it's, not evenly distributed. We do see more cases in high-income countries and also in higher latitudes. And if we look over time, this chart is showing for the past 30 years, the number of cases of neurodegenerative disorders have gone up quite a bit. But the chart on the right is actually showing the same numbers but age standardized. So you can see that a lot of the growth is actually coming from the population age structure changing, and it's only 9% growth over 1990 to 2020 when you look at age standardized data. However, this number does mask a lot of variability, with Parkinson's, for example, growing much faster than this rate. And you can see again the distribution with age. So on the right, you can see the prevalence, it goes up very dramatically with age. The chart on the left is showing just number of cases with age, so that does peak around in the 70s or 80s, just because there are fewer absolute number of cases at those older ages. And then within the four conditions that we're modeling, the age structure does vary quite a bit. So you can see for multiple sclerosis and motor neuron disease, it does affect people at younger ages, whereas dementia has a very strong age trend. And when you look at these in aggregate, the dementia trends are really what's driving the patterns that you see, because they're so much more common. If you can see the axis number, dementia, it goes up to 30,000, whereas motor neuron disease, only goes up to 10, so orders of magnitude different. And then also there are differences by sex as well for all of these conditions. Dementia and MS are more common for females, whereas motor neuron disease and Parkinson's are seen more often in males. And in this chart, I'm showing kind of YLLs versus YLDs, or the life lost versus the years lived with disability. And you can see that the excess death patterns are quite different for these different disorders. With multiple sclerosis, people survive for a long time with that condition. So you have about half of the health loss coming from life loss versus half coming from years lived with disability. And on the other end of the spectrum, you have motor neuron disease, which is fatal very quickly. So you can see the ratio of years of life lost to years lived with disability is actually 17 to 1. So there's a very high excess death burden, even though the number of cases is small. And then we do model some risk factors in our work as well. And so this chart shows you the impact of 3 of the risk factors for dementia. Green is smoking, blue is high fasting plasma glucose, and then purple is high BMI, or body mass index. So you can see that if we were able to eliminate these risk factors, we would reduce the burden by quite a bit. It's over 30% of cases are caused by one of these risk factors. And then I'll just switch topics a little bit and talk briefly about the economic burden of dementia. So we have measured 2 categories of costs for dementia. We have direct spending, so that's including doctor visits and nursing home care, pharmaceuticals. And then we also measure the indirect cost of informal or unpaid care. So that's a cost that's not, there's not a perfect way to measure that cost because there's no money actually changing hands, but we do want to place a value on all the time the caregivers are spending. So the way we do that is we use the average wages for each country, and we assign that as the value for each hour of care that's provided. And what we found is, the total cost as of right now is over 600 billion, and that's projected to increase quite a bit over time. This chart on the far right actually shows you a relationship between GDP of a country and then how many hours of caregiving are provided. This is talking about unpaid or informal care. So you can see that in richer countries, people are providing fewer hours of unpaid care. So they're substituting with paid care in some form. But then the chart to the left of that shows GDP as it relates to the cost. So because, as I said, we use the wages of that country to estimate the value of care, even though there's fewer hours being provided in wealthier countries, the cost is still increasing with GDP. And you can see the bar chart on the left, this shows you how these costs are distributed over different countries. So in high-income countries, you have quite high costs for both direct and indirect costs of dementia care. Whereas if you go over to low-income countries, almost all of the cost is due to unpaid care. So there's almost no money being spent for direct medical costs for dementia. And then here's a forecast. So we projected this out to 2050, and we found that these costs would rise to over $2 trillion by that time. And I show on the right, this is the data for Italy. So you can see in the red, that's the direct cost. It's going up. And actually, indirect costs will go down slightly, but the overall cost will still be increasing. And we also looked at, for the direct spending, how much of the total healthcare budget is spent on dementia. Right now, it's about 3%, but we project that that'll go up to almost 10% by 2050 if current trends continue. So to summarize, we have right now over 74 million people living with a neurodegenerative disorder. So it's quite a high burden, and the number of cases and the associated costs are going to continue to increase as populations age, and we still don't have cures for any of these disorders. And dementia is the most common, and that's driving a lot of the trends, but we also see really fast growth in Parkinson's, and we see a lot of excess mortality with motor neuron disease. And that's it. Thank you.
Amy, thank you so much. I think it was really a perfect introduction for everybody to understand the spectrum of this, I will say, new pandemic, I can say, and you scared us. You know that you scared us with this data also. We decided to have the discussion at the end because I think with the three speakers will be much more interactive and comprehensive. And so the next speaker is Catherine Serre. I think she's from the background, she's a psychologist, but she's working for the WHO in Geneva, Switzerland, and she is really involved in helping the community in understanding the brain health prevention, especially in dementia. So please, the stage is for you.
Thank you, Professor Moro. Good morning to all of you. Thanks for coming, and thanks to the Prada Foundation for organizing this event. Like Elena said, I'm going to try and present WHO's Brain Health Program to you. We're involved in many different areas. But I thought it's good to start first with presenting our vision or our idea of what brain health even is. It's not as fascinating as your video, I should say, though. So in a publication that is our position paper on optimizing brain health across the life course that we released in 2022, we tried to come up with a working definition of what brain health is. So we're understanding it as a state of brain functioning across multiple domains that you saw really brilliantly in the video. So it's about cognitive function, sensory, behavioral, socio-emotional, motor function. And all of these abilities allow a person to realize their full potential over the life course. And the important part here is irrespective of the presence or absence of a disorder. What that then means is that theoretical and practical, we can optimize brain health and brain function for everyone. So there is a multitude of factors that throughout life impact our brain functioning and our brain structure. And by promoting the brain's ability to grow, to heal, to build new connections, to recover or compensate for any injuries or insults, we can optimize or promote brain health for individuals and for society more broadly. But as you will hear throughout the conference and also see in the fantastic posters in the exhibition, is there are many threats to our brains. They start with our genetics, but they also include infections, metabolic risk factors, traumatic injuries, the use of substances like tobacco and alcohol, our nutrition, inadequate sleep, of levels of physical activity, as well as air pollution or other or pollutants in water or food. So if we want to comprehensively address all these risk factors, it really means that this is a global effort, and it's not just the health sector that is responsible for this. At WHO, we tried to summarize how these different factors might work and ultimately influence brain function and brain structure in what we call our framework for optimizing brain health across the life course. So you see on the left the different brain health determinants that can act at the individual or at the societal level. You can group them into categories. Some of them look very familiar because they're very much related to social determinants of health. So it's conditions or things like access to quality services, physical health conditions, the environment, safety, security, learning, social connection. I'll come back to those clusters in a bit. But so the idea is that if we're addressing, or these factors continuously interact and influence our brain on a daily basis, and by trying to address or optimize those brain health determinants, we have an influence on our brain function and brain structure, and that in turn will then not only reduce the likelihood or the risk for developing neurological conditions such as dementia, but also have positive health benefits for mental health, physical health, and society more broadly. So here is in a more detailed a snapshot of what the individual brain health determinants might be and how we have clustered them into these groups, but you could also put them into other buckets. But again, the important thing here is to show how varied they are and how multiple risk factors or protective factors might actually influence a person at any given point in time. So I'd mentioned there are physical health conditions. They start well before we're born with the maternal health and the intrauterine environment. They're the genetics and epigenetic factors, nutrition, infections, non-communicable diseases. I've mentioned some of them before. In the area of healthy environments, think of the exposure to chemicals, radiation, but also workplace and potential exposure to those toxicants in the workplace, and water quality. Climate is a very big component at the moment. Crucial for our brain development and our brain health is also learning and social connection with others. So starting early with early life learning opportunities, good education, and then opportunities for lifelong learning through our work environments, and of course social networks. In the area of safety and security, we know that facing hardship financially or also physically, living through abuse or physical harm will change brain structure and cause a risk. And the same is true, for instance, during humanitarian crises or emergencies. And all of that, the last bucket is access to quality services, and that really means that once you have a condition, there are many things that we can still do to optimize brain function, but it requires a team or workforce of interdisciplinary specialties and access to treatment medicines and supporting the family. Now, what are WHO's mandates in the area of brain health? We do have two World Health Assembly action plans. One is more broader, more recently adopted, and that's the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders. We also have a Global Dementia Action Plan. They both focus on very similar areas. They have a policy component. They try to strengthen services. But importantly for this meeting and conference here is they both also have dedicated sections and strong signals for the importance of promoting brain health and trying to prevent conditions. I'm sure we'll hear about dementia risk factors later on, but they often share or they're often shared with other conditions. So these two global instruments also make a lot of effort in trying to tie them into global actions related to non-communicable diseases, or NCDs for short. So what are the areas of work that we're trying to address? Brain health, we're taking a life course approach. So we're starting with maternal mental health, neurodevelopment, and child and adolescent mental and brain health. We have disease-specific programs for epilepsy, for instance, but then also dementia, which is the team that I lead. But there's also technical guidance coming out in for other neurological conditions such as Parkinson's and multiple sclerosis. And then in addition to these vertical areas, we also have horizontal packages which target service delivery or access to medicine, which are not necessarily specific to a condition, where we really need to address this across the band. And we're strengthening countries' monitoring and research abilities. Now, when it comes to service delivery, specifically, you'll hear my colleagues at WHO and me often talk about, we need integration. What does that actually mean? Integration for brain health or neurological disorders is really trying to see them holistically, all the different neurological conditions. And in the first instance, that was also what drove our work together with IHME on publishing the global burden or health loss for all neurological conditions. We're focusing on the integration across the care continuum, so really starting with prevention and promotion to diagnosis, care and treatment, as well as then rehabilitation and palliative care. But integration also means seeing the person holistically and recognizing that the person comes with other conditions, non-communicable diseases, infectious diseases, mental health, and there are synergies to be used and the person to be treated holistically. The life course I've mentioned before. What is a big problem is that children, for instance, growing up with neurodevelopmental conditions, falling between the cracks once they reach adulthood. And so ensuring that there is a continuity across life course, and also recognizing that things that we live through or experience early in life will have an impact on our health and brain health later in life is crucial. And then the important for us is also the integration and working together with the health and social care. And we do all of this ideally or using universal healthcare or primary healthcare as the platform, because this way we will reach more of the population. So because this is very theoretical, I want to give you at least some examples of our current work or how we do this. And again, it helps if you think of the different areas or mandates that WHO has. So in the first place, it's leadership and advocacy. It's working with member states in driving policy dialogue, in getting the topic on the agenda. We're not doing this in isolation. Other associations work on this or support this work really heavily. But so this engagement with ministries and governments is really, really important. Developing an investment case. Why should we invest in brain health is crucial. And at the moment, we're spending a lot of time also advocating for continued action for dementia, given the action plan is going to expire next year. Then the next big responsibility that we have is on generating norms and standards or technical tools and products. So documents that are free to use and ready to implement. You've seen the implementation, the IGAP implementation toolkit already on Elena's slide. Recently also published a framework for access to medicines for neurological disorders. But I'll go and show you on the next few slides an update on our risk reduction guidelines for dementia and also work on blood-based biomarkers. We do work with countries directly upon their request. We help them plan or services. We help them in developing policies or do perform trainings. We also engage in monitoring, not just because we as the Secretariat do need to report back to World Health Assembly and our member states on how we're progressing on our global targets, but also to help countries keeping track of their actions and identifying where there are or might be gaps in their responses to dementia, but also other neurological or neurodegenerative diseases. And we usually every now and then summarize those results and publish them in reports. And last but not least, we're engaging in partnerships, and I think this is also a common or shared goal with Prada Foundation and with the scientific community in coming together and trying to solve these problems jointly. So just very quickly, because we will talk about risk reduction throughout the 2 days, we've just started the process of updating our 2019 guidelines for dementia risk reduction. At the time, they focused on 14 recommendations for 19 risk factors. So those were lifestyle or behavior interventions, treatments for specific health conditions, or specific dementia-specific interventions such as cognitive stimulation. And now to reflect all the recent evidence, we started the update process, and we will also look into potentially adding new risk factor interventions in the next edition. We're just next week, we'll be launching our what is called a preferred product characteristic. It's not a WHO guideline, but it provides guidance to specifically industry partners here. And what's the aim of this? So the PPC for short gives the key characteristics for blood-based biomarkers that can be used in the diagnosis of Alzheimer's disease, with a specific aim to ensure that once these come to the market, they are not only of the highest clinical performance, and we can rely on their results, but we can also distribute and provide them equitable across the globe. I've mentioned our responsibility for monitoring and keeping track of where the world goes. So we do this for dementia with the Global Dementia Observatory, or GDO for short, and are currently surveying the member states on their responses so that we can report back in May next year to where we stand. We're at the moment covering about half the world and continue to collect information. But what we also want to do is not only provide the policymakers with a chart of how they're doing or where there might be gaps in their dementia response, we also want to give them or provide them with some solutions. And that's what our knowledge exchange platform is for. And that is really a repository of peer-reviewed good practice resources that can address any action point mentioned in the Global Action Plan. And the last document I want to just briefly bring to your attention, because it taps into our area of building networks, partnerships, but also improving research for neurodegenerative diseases or brain health more broadly, is the blueprint for dementia research, which identified the main gaps or key priorities, areas or actions that we need to address, and you see them at the top of the slide. But then it also makes recommendations for what are the drivers of research. What do we need to change on a structural or system level to empower research and to enable science to make the advances that we want or hope for. And if you want to join, we're building a network of different partners around the globe. If you want to join or interested, you can scan the QR code here. So really, in summary, taking brain health forward, what does that mean? We need the intersectoral actions to raise awareness of why this is so important. We need all disciplines involved, as Elena had also said. This is not just health, this is all societal sectors. We do need to advocate and invest in research for brain health, and not just finding a cure, but also understanding what we can do to address the determinants, the risk factors for our brain. And then lastly, one area that I'm also responsible for in our unit is trying to make brain health measurable. We talk about brain health, but there's so many different metrics that we can use, and trying to come up with ideally one measure that we use across the life course, that would be ideal. And with that, I'll thank you very much for your attention. Thanks.
So, Catherine, thank you so much for what you presented, and really we're so grateful to the WHO for the amazing, outstanding work they are doing for all the community, and especially in this area of neurodegenerative disorders. So I'm sure that we have a lot of questions for you later in the discussion. And the third speaker of this first session is Monique Brettler, because it's a Dutch name, so it's not easy for an Italian origin speaker, speaking person to pronounce properly this last name. So she is the director of the Population Health Science at the DZNE. She's a physician of background, but really been involved in the population health science for years. And she has been the visionary person of the Rotterdam study. So your stage now, Monique, to tell us about a little more the risk factors. They're not all the same. So can you please tell us a little more about that?
Yeah, thank you very much, Elena. Thank you, Giancarlo, for bringing us all together for this extremely important topics, and hopefully very interesting and exciting days. And good morning, everybody. Modifiable and non-modifiable risk factors in the prevention of neurodegenerative diseases. Well, I think it's important that we agree on some concepts here, because risk factors do not mean the same to everybody. Prevention. Why should we even focus on prevention? I think it's very important that we also agree here on the reasons. I think we do, but it may not be bad to highlight this. And then also, that's what I will focus mostly on, is what is needed for prevention. What is our path to prevention? So what is a risk factor? A risk factor, from an epidemiological perspective, is just any factor that is related with a disease or with the probability of developing that disease, an association. And it may either increase or decrease the likelihood of an adverse outcome. Oftentimes it's considered as, oh, it increases the risk, but that need not be the case, right? Think of blood pressure. If it's higher, you have a higher risk of cardiovascular diseases. If it's lower, you have a lower risk. So it's really this association that matters. We want to understand these associations, insight in underlying mechanisms. Also important that the risk factor need not at all be causally related with the disease, right? It may be an early marker. If we, thinking of brain health, of risk of dementia, we know that there may already be signs in the brain that are very predictive of the disease, that are associated with the risk of the disease, that mark the risk of disease, but that are not causes, merely they are consequences. Still they are risk factors, still they are extremely important to identify. And why? Because if we also need prediction markers, and I get to that, these are of course by definition risk factors, right? If they are not associated with the risk of the disease, they cannot predict. But so it's not causal necessarily, still can be very important, but we know what is needed when. Why should we focus on prevention? Well, trained as a physician, I took the oath of Hippocrates, and then of course we also know that if you know Hippocrates, that prevention is better than cure, but actually it became even, and I've worked on this for my whole career, but it became even more personal, I would say, in the last couple of years. This is my father. He died 7 weeks ago at the age of 94. He had dementia. And until he was in his, I think, around 90, this photograph is taken around that time, he was actually doing fine. He would even jump on his bike around, you know, walk along the beach. But the last years of his life were really tough on him, tough on us, right? He really suffered. And at no moment during these years of his disease was either he or we longing for a treatment to prolong that trajectory. What we wanted is that he had never even gotten into that situation, right? And that is important. Towards the end of life, if he had not gotten there, if he had lived just a few years longer healthy, that would have made a major difference. Of course, it differs. Depending on every patient is different with dementia. If you suffer from dementia early on in life, like predicted in, personalized in the movie Still Alice by Julian Moore, of course, then you have maybe completely different responsibilities and tasks in life, and it may be important to prolong. But I think it's very important to realize that almost for everybody, and I think you will agree here in the audience, it's better to be healthy than ill or dead. And that is a quote from the late Sir Geoffrey Rose, and he said, "This is the beginning and the end of the real argument for preventive medicine." And it is sufficient. We don't need more than that. We just want to be healthy. When we think of prevention, and especially of aging-related diseases, prevention may be either really preventing it, right? Like vaccination against an infectious disease may really totally stop it, but it may also be actually delaying the clinical onset of symptoms, especially diseases that develop over decades. If we can stretch out that trajectory towards clinical symptomatology, actually we are doing a great job, because people will stay healthy, or at least appreciate their life as healthy. Or, I don't know whether you're familiar with these Dutch tiles of wisdom, where actually it's a bit of, maybe standard proverbs and expressions. I made up this one to summarize this idea. Who cares about getting dementia in heaven or hell? So prevention, what is needed for prevention? Here I think it's important to realize what brings out disease. And for most of the, again, common aging-related diseases, the cause of the disease is multi-causal, develops over the entire life course. It's an interplay between our genes, our internal environment, the behavior, the more external environment, and this constant interaction and how that modifies and modulates over the life course is what in the end results in health or disease. And putting it in a different graph, what you actually see here in the middle, this pointer is not that easy to handle, but so of course a person starts out with their own genes, but it's really the behavior and also the larger environment that determines how these genes are being transcribed, how they are being translated into proteins, how they bring out the biological processes underlying our health status. And I don't have time to go into all of these different factors, but it's important that you capture this idea that it's really a very multi-causal process. There are this is actually great news, because that means that there are a lot of places where we can tweak and try to intervene a little bit on this resulting outcome. And if we focus on dementia and we put it on a life course perspective, this is actually this idea that, of course, our genes and all these in this case, causal risk factors, because they have an effect on the course of the disease, play out throughout life. This may be the genes, it may be the environmental lifestyle factors, it's the interaction, the epigenetic changes that we have. And during this entire period of still normal cognitive functioning, we have a tremendous window of opportunity to intervene. And only at the end symptoms will occur, and the idea is that we push this further back, this area, so we effectively prevent disease. So this is, I thought this was worth another trial, how to prevent disease, because actually it's a very simple recipe, right? First, we have to find the causes, and then we have to identify who is at risk for that specific cause, because of course it does not help much to change a cause that you're not at risk of. And then we have to only develop and implement effective interventions targeted towards these specific causes and the people at risk. And that means that we probably have many different interventions targeting at different people, or combinations of interventions. Personalized prevention, not necessarily individualized, but personalized. What do we know about risk factors? And I think you're all familiar here with these nice overviews in the Lancet, from the Lancet Commission. The first one in 2017, then there was one in 2020, then there was an update earlier this year. Basically, taking stock of what has been done on dementia risk factor research over the last decades. So I think it's a large amount of work, but it's basically just an inventory what was done there. And I think there are some really important parts of these papers. I think the main message for me is that it emphasizes this immense potential to prevent dementia through lifelong adaptation of lifestyle and environmental factors. And as said, this is based on solid evidence, right? Because they really weighted, like, what is the evidence of all these papers? Do we have these associations? Huh? And I think it also is very important in supporting this message, like, hey, we should strive more to dementia prevention because there's potential. The quote of 45% in the latest paper, whether it's true or not, I mean, that is much, much, much more than any clinical trial at the moment aims to achieve by disease-modifying therapies. But I think there are also some very fundamental criticisms of at least of this, the work of the Lancet Commission, and maybe not so much of their work, but more of how it is being interpreted. And I think the main, or one of the main, is that association, of course, is not cause, right? In the week after all these Nobel Prizes that were handed out, I would like to show you this graph. You may have seen this. This is from an older publication in the BMC, in the Christmas journal, where they basically associated the chocolate consumption per head of the population in various countries with the number of Nobel laureates. And maybe not surprising given the good quality of Swiss chocolate, they really are on top of that bill. But I would recommend here the Italian colleagues, I think Italy is only somewhere here, right? Don't think that if you increase your chocolate consumption, you will automatically get a Nobel Prize. Association is not cause. And for many of these factors that were listed, we do not yet understand the really underlying mechanisms, whether it's cause, whether it's consequence, how that interplays. Maybe it's both, you know? And even more important, although it may be rather comprehensive given the current state of the literature, it's still a very simple compilation of published data, and it does not at all take into account the complexity and interaction of the many factors involved. It is not as if you can just treat one and then reduce the risk, right? Sorry to bring this message, but life is a bit more complicated than that. I think, and that is my message, and I hope it will resonate also in the discussions with you over the next 2 days, I think we really can do better, and we must do more, and we must do better. And that is then both in in deciphering these specific causal mechanisms and in identifying the people at risk and work on this idea of risk prediction and risk stratification. Important in this respect, I think, is a focus on aging. Previous speaker already nicely mentioned that if you think of brain health or other health, that there is really a huge overlap in these non-communicative diseases. A lot of these health style factors actually are beneficial for most of our aging-related disease outcomes. And so why should we focus on aging if we want to prevent disease? Well, precisely for that reason. Aging is the greatest risk factor for all these chronic diseases. And this is more on the cell biology level, but you may be well aware of all these hallmark papers that have come out in recent years where people focus on what are the hallmarks of aging, what are the hallmarks of neurodegenerative diseases. There's a huge overlap in the underlying mechanisms in the end. And if you turn it around and say what are hallmarks of health, it's actually typically a better balance of some of these mechanisms that deteriorate with aging. And I think if we would get a better handle on those, we actually may also come with more specific, targeted preventive interventions and recommendations. So one way to achieve that, and that is the approach that we take, and I would like to briefly introduce this new study that I set up in Germany, the Rhineland study, with a goal to really understand resilience, aging and disease as joint effects of environmental, behavioral and epigenetic factors and genetic factors, and with the aim of contributing to the prevention of disease and promotion of healthy aging, not only healthy brain aging, healthy aging in general. And this is a map of Bonn. We basically have a study. It's a prospective study, community-based. We will include more than 20,000 people. They come from these two areas in Bonn, although it's a single center study. It's adult age 30 years and over, no upper age limit. People will be regularly examined for decades because these diseases take decades to develop, and we emphasize deep phenotyping. And I hope that you can appreciate this. This just gives you a bit of the where we are at the moment. We have at the moment included more than 12,500 people. The first 4,000 or 5,000 people we already have longitudinal follow-up, and we also have additional blood sampling here during the COVID survey, and we will continue following those. And the deep phenotyping is really focusing on clinical measures, on exposome measures, behavior, but also, for example, on very detailed imaging. Everybody undergoes a 1-hour MR scan to assess brain features, retinal imaging. And we do a lot of molecular profiling. At the moment, for most of these people, we have these multi-omics layers of genomic data, epigenomic data, transcriptome data, metabolomic, lipidomic, proteomic data, because we really think that by unraveling these molecular profiles, we may get insights that will help us understand the etiology of diseases, prediction and risk stratification, but also indeed this physiology and pathophysiology of aging. And just to give one brief example of how we go on with this, the old adagio, right? You are as young as you feel. Well, molecularly, that is very, very true, because if we, for example, think of these epigenetic changes that occur with aging, we can derive these epigenetic clocks, right? Markers across the genome that are associated with increased age, and some people just are younger epigenetically than others are. That's only taking into account a relatively small number of epigenetic sites. Well, we tried to use this methylation data to dive deeper into what is a healthy diet and how does it impact health. Because there are so many different healthy diets that all claim to be good. And my first, and that's also a personal question, is which one is better, right? Because they all have these claims. And interestingly, we looked at this, and I don't know whether you're familiar with this upset plot. So we looked at different healthy diets. These are listed here. This is the number of people. And then here you see the combination of profiles. So this is looking at the people, the top 25% of people who adhered to a specific diet. And you see that there was actually very little overlap in the sense that the people who would be in the top 25% of all these healthy diets, which I expected to be quite large, healthy diet is healthy diet, was actually really small. Most people are pretty unique. But the good thing is that all these healthy diets, regardless of the specific diet, were actually associated with a younger epigenetic age. So they're good for you, no matter what you do. That's a good message, right? Eat healthy, good for you. But we wanted to understand more. So we also looked at these epigenetic changes across the genome. And if you then again look at these different diets, again what you see, this is the overlap in genes that are changed, and there's actually really not that much overlap. It seems to be very different across the different diets. So we looked at the pathways, because these changes are only part of the play, right? We have to see how does that affect the body, which pathways are involved. And then, and I think that's very interesting, then we see that indeed suddenly a lot of these healthy diets, even though they target different genes, converge on the same biological pathways. And this, of course, gives us important clues as to what might be at stake here. And indeed, some of the obvious candidates come up here, like the immune system, like some other mechanisms. But what is also interesting, equally interesting, is that there are also diet-specific pathways that come up. So on the one hand, we have more common shared mechanisms that we now may focus on that could be beneficial for, or that we could try to influence to benefit health, but we also have specific dietary patterns that may actually provide insight into more specific mechanisms. Almost coming to the end, I think there's a lesson that we can learn from the Framingham Heart Study. I think everybody here knows the Framingham Heart Study. This is actually the iconic epidemiological study that started in the middle of last century in Framingham, Massachusetts, small city near Boston. And it's iconic. Not only most of these large population studies that we currently have are somehow modeled after the Framingham Heart Study, but I think it also had an extremely important impact indeed on cardiovascular health. So they proudly have this nameplate at their city borders where they say, Framingham, the town that changed America's heart. Because what is important what they did? Actually, in the middle of last century, high blood pressure was just blood pressure, right? But they associated high blood pressure with cardiovascular risk. And that went so far that they said, well, if we lower the blood pressure, we may be able to prevent some of this cardiovascular disease. This concept that you find a risk factor, blood pressure, high blood pressure, and that you then can intervene on that and then have an effect on disease. So hypertension is now considered a disease. The industry and all the very effective treatments that have been developed since to lower high blood pressure, and later on high lipid levels, et cetera, many more of those risk factors, really had an impact on cardiovascular risk. And I think this is a lesson learned. If we go to this slide of how to prevent dementia or how to prevent disease, I think it might make a lot of sense that we do not only identify causes and people at risk. I think we should also invent new diseases, disease status for which we can then develop targeted intervention. And why is this so important? Well, one of the problems with prevention is that there is actually very little to gain, right? If people behave well, they will not know that suddenly they prevent their disease. So it's very hard to motivate people to adapt healthy behavior. Big pharma, big driver of innovation, have very little motivation to get on board if they cannot have sellable or cannot develop sellable drugs. I think if we can invent these new disease conditions, then we actually can, of course, continue having all these recommendations for a healthy lifestyle. No way that I would want to take away from that. But we can do more, further, and also develop targeted and effective interventions. So, wrapping up, I think that prevention of dementia is possible. Maybe not to 100%, but to a very, very, very large extent. And indeed, we have already effective recommendations that we can make. This health, well, we heard them before. I think we should only become more ambitious in making sure that they are also adhered to. 50% of the people with hypertension are still not treated or undertreated, for example. But main claim to action, we need to be more ambitious. Not focus only on finding risk factors, but on treatable conditions that are associated with the outcome. More focused on identifying biomarkers so we can really target our interventions to the people at risk beyond just making generic recommendations. And I think in that whole context, it's very important to recognize the role of aging mechanisms and also collaborate with the basic science ongoing in that area to really develop novel ways to prevent not only neurodegenerative diseases, but also other diseases. And with that, I think we can really focus our research much more on primary prevention, which in the end should be our goal, I would think. And what is needed beyond all this other recommendations, of course, is also more money in that direction, but maybe that is also something that we can discuss about later during these 2 days. Thank you very much.
Thank you very much, Monique, for this very comprehensive but also juicy, if I can follow some of your line of your talk. And I'm really sure that if you come on the stage, we can start the discussion, which will be probably very rich because you started with a lot of concept. And I'm sure that some questions are raising from the audience. So while we are thinking, maybe we'll need a coffee to to wake up, but I may start. First of all, can I make an observation? We are 4 women here, so very interesting, I think. Also because I noticed from your data, right? So you really divided also gender, sex, right, in your analysis of the data, which is, I would say dramatic because the cost is increasing. And why do you think there is this? Besides the etiology that we know, is only because we know that Parkinson is more frequent in men and women, and in dementia in women, that there is this diversity, or do you think there are other factors in the cost that you put in your slide?
Oh, thank you. Yeah, I don't think the cost varies that much by sex, but we honestly don't have good data on that. The one thing I will say about cost is when we look at the caregiver, so the indirect cost, we did break that out by sex, and we do see that most caregivers are women, and we did use, sex-specific wages to measure that cost. But yeah, we see very heavy reliance on women, especially in lower income countries. It can be up to 80% of caregivers are women.
It's very interesting. Maybe if we keep in this, your study, is quite interesting because it's aging, right? I know that there are several other cohorts, but did you find already some differences between sex and gender in your community that you might share?
Actually, we find a lot of differences between men and women, and that applies to, if you look at the cardiovascular system, it applies to when you look at the immune system. Of course, it also applies to behavior and environmental exposures. So I think this concept of, is the risk of Alzheimer or dementia higher in men and women? I'm not that convinced that it is. Definitely the prevalence is higher in women, but women get older and live longer, right? So you will have more women with dementia. And I think that it also depends on what the specific underlying causes are. In older studies, we saw that the age-specific risk incidence was very similar between men and women up till the age of 85. And then it started to diverge because basically, there was a selective survival in the women. If you look at, for example, vascular factors, they still are more common in men. So I think this is one of the examples where I think it is maybe more interesting to focus on specific mechanisms, also to focus on sex-specific mechanisms, because they do differ, rather than just on the overall number.
Thank you very much. And while there is some question, okay, now we don't see anything here. This is the reason also. Please, if you can help, because I really don't see anybody raising the hand.
Thank you. Bogdan Dragansky from Switzerland. I have a very simple question to all three of you about numbers. First of all, to you, how reliable are the numbers when we're talking about Alzheimer's disease? We know from clinics, diagnosis is not that easy there are criteria, of course, but there are certain countries, and for you, I have a fellow from Myanmar. She says they don't do fluid biomarkers, and in the capital they have 3 MRIs, and the cost of a brain MRI equals to her salary as a neurologist. And then at the end, about you, how representative are such large-scale epidemiological studies? We know the ICON UK Biobank, maybe in the Rotterdam study, they're representative just 5% of the general population. What are we doing right and what are we doing wrong?
Yeah, thank you. That's a great question. I think there's always room for improvement with dementia numbers. There's definitely underdiagnosis in many places. One thing I can say specifically about our modeling is we actually got some really good data from Italy linking kind of medical claims data and death certificate data. And we've seen this increase in coding of dementia as a cause of death over time. So then we have been able to use that to adjust a lot of numbers in other locations upward as well to account for that. So we definitely do a lot of work to try and capture all of that, but I do believe there's probably more to be done, especially in areas where dementia is not being diagnosed as regularly.
Yeah, maybe to follow on from this, the dementia diagnosis is tricky, and I recognize that especially in low resource settings, the realities are quite different from what we might be used to from clinical trial centers in the US or in Europe, in the UK. That's exactly one of the reasons why we came out with the PPC on blood-based biomarkers, because once we do have any biomarker that can be used for diagnostics outside the research setting, we do need to make sure that it is usable, it is friendly and recognizes all the limitations that we do have. Hence the focus on blood rather than imaging, because it will be easier to scale. But then still, like we need the infrastructure at local level to process those. So that's why they're quite strict and maybe very different from what we currently see is being done in clinical trials. But then the other point that I also want to highlight, it is extremely important that we're not only rely on those biomarkers, but also improve or bring clinical assessment tools that we don't necessarily have in some parts of the world, that we adapt, we validate them so that we can trust and also reduce or strengthen the workforce and their ability to detect dementia early at the lowest level possible, because we know we don't have enough specialists, and we will never have enough specialists in any country.
Yeah, maybe to comment on your question regarding representativeness. I think representativeness is important if you, for example, want to plan healthcare facilities, right? Then you have to know that you really know what is needed in a specific population. When it comes to understanding biology, I think it's much more important to have very high quality data and know what you are measuring, right? I have a slide that I don't show now, but that I typically use if I also have more of a basic research institute or politicians, where I show zebrafish and worms and mice and whatever. And I say, if we really think that these model systems can tell us something about aging or what is going on in disease, dementia, whatever, then I'm sure that we can also learn from looking at people if we want to learn about people. This is not to say that we should not take into account the factors that may differ between populations, but that is something that you don't capture by being representative. That is something that you capture by knowing what you measure and what you don't. And what you don't measure, you cannot derive any strong conclusions about, but that is why we have to collaborate with others who may have the data to fill in that gaps. I think we are really looking at a worldwide effort here. So that may be the, and if I may briefly, because I think your point of the less availability of, for example, in Myanmar, yes, at the moment we don't have the solution, but I think that some of the efforts that we and others are working on to find new biomarkers, and especially blood-based biomarkers, that is not going into the direction of having more fancy, expensive measurements. That would go in the direction of having actually a simple blood drop simple test that you might do on a piece of paper, so it's also not climate dependent, etc., right? We aren't there yet, but I actually think that these developments may be real in, well, 5 to 10 years from now.
Alberto Ascherio from Harvard University in Boston. So 2 small comments. So first, thank you for the great presentation. I think we may be a bit over-optimistic when we say that 40–45% of the case of dementia could be prevented by non-risk factor. Because are we really preventing or just delaying the onset? And I think we want to comment on this. It would be interesting transforming the metric and see how many years or months of dementia-free life we are adding rather than preventing 45% of the cases. And the other small comment, I was surprised to see how infection are conspicuously absent in all this review and exposome, everything that has been shown. But I will give a presentation tomorrow, so thank you for the invitation to talk about this topic. But I think being optimistic, there may be possibly, still no conclusive, but there may be some possibility of doing something in that area. Thank you.
May I comment to that? I think your point of the 45%, that's very well taken, right? That is why I was actually saying, let's push it back, and then there is still underlying pathology, but we don't have the symptomatology. So I think also, and that is maybe not prevention in the sense of totally eradicating, but it definitely it would work. The infections, immune system, 20 minutes is not a lot if you have to cover everything. There is, of course, a lot of research ongoing, and especially also when it comes to the interest in some of those underlying mechanisms of the role of the immune system, right? And I think actually most of these hallmarks of aging converge somehow on the immune systems, and then specific infections may either trigger the immune system or have that interaction. Would be great to hear your talk tomorrow, but the fact that we did not spell it out was maybe because you will speak on it tomorrow and not because it's not taken seriously.
Excellent, Hans. I don't know, maybe we start with Professor Comi here, but I see the other hands up.
About this magic 45% reduction, we can be optimistic, we can be pessimistic. But my comment, and I would like also to listen to your comment, one of the reasons to be optimistic is that we are moving from the definition of disease based on phenomenology to the definition of disease based on biology. And this is a fundamental step for all neurologists like me. In the past, all the studies we did, we used to classify just dementia. which was terrible because we combined together many different type of pathophysiological mechanism, even different genetic. So I'm optimistic because now in all the diseases, we use now the biological definition, so that may reveal much more focused intervention, even for the prevention. And I think the example is the role of the infection, for example, in MS. The way we reclassify the MS, we discover new diseases with a completely different type of mechanism and different type of intervention. So, and this could be really the turning point. What is your view?
Well, I fully agree, Giancarlo. And I think what you said, also what Alberto said, is actually not contradictory, right? If you think of some of the studies that showed that were done a decade ago or so, or 15 years ago, looking at the trends in incidence of dementia across Western countries, right? We also did such a study. We actually saw that the age-specific risk was down by 25%. And that was, I think, based on, for example, the risk reduction that we have seen over the last decades, the preceding decades, in cardiovascular disease, right? So people are already healthier. And I think that was also nicely depicted in the first slide. People live longer, and the number of healthy life years added outnumber the years added in disease. And this concept of prevention is that we want to, well, make that balance even better, right? But we are already doing a quite good job. And if we are more ambitious, I'm pretty sure we can do more. But then it depends on how you define prevention, right? 45% never ever get it, or 45% may get it much later, and the total burden of disease gets reduced.
I would say we are moderately optimistic. Please, on the right.
Great session. Thank you very much, Peter Hartung, Düsseldorf. I'd like to pose a question to Dr. Latuska. In your assessment and projection of the burden of dementia that's coming up, have you factored in and how the economic consequences of the emerging new disease-modifying therapies?
Yeah, thank you for that question. We didn't have a lot of data yet on the direct cost of those new drugs. We did forecast a few different scenarios for costs, and we did include one scenario where the use of nursing homes declines somewhat, because there's some emerging evidence that people could stay at home longer with these disease-modifying treatments. So under that scenario, we saw the costs were, I think, about 10% lower than our baseline scenario, but they still do increase over time. But it'll be really interesting to see as we have longer term data to see if it extends lifespans or, you know, how that plays out. So I'm looking forward to updating in the future.
Thank you so much. And other question, yes.
Hi, I'm Elena from San Raffaele Hospital. Thank you very much for the talks. I feel like I want to address something that stuck into my mind from the last talk, when you challenged us with create new diseases. I don't know if I'm the only one, but I was like, okay. And I think it's interesting because it's really more just a comment and a reflection, but we talk, when we gather together and we discuss diseases and treatments, it's all fine too. But when we discuss prevention, it's kind of counterintuitive to think about creating new diseases. And I know it was a challenge, but how in the long term this could be the real way to go. And perhaps even with the WHO support, you know, in terms of, if we're talking about prevention, we should talk about healthy lifestyles. And if we create more disease, I wonder how in the long term it's going to affect positive psychology of people. shouldn't we bridge the gap between our work and education, really? And that's prevention. So not creating new diseases, but creating health.
Well, thank you for taking up on the provocation, because I think this is very important indeed, right? So, and maybe we should not label it diseases, but treatable conditions. And I think if everybody was able to keep everything under control by just living a healthy life, yeah, let's go for that. But it's not working, right? And why is it not working? Maybe because not everybody is equally motivated, but maybe also because not everybody has the perfect genes to be able to do that, right? We have different chances and different risk factor profiles. So I think that educating people and supporting them is very important, but I think we should not be naive or have some false sense of morality like, oh, we cannot do something to prevent, because basically that is what medicine is all about and has been all about, and is what is underlying that we now live on average 40 years longer than 2 centuries ago, right? Nobody has a problem by screening newborns to see if they have any metabolic disorder and then put them on the right diet to make sure that they don't get a disease later on, right? Nobody has a problem, well, some people have a problem, but most people, fortunately not, to vaccinate against diseases that we otherwise know may come with negative burdens. That is, of course, medical interventions to a certain extent, right? But we are so used to them that we don't find it a problem. Hypertension, to a certain extent, can be addressed by lifestyle interventions. Not completely, and not in everybody. So I think it's very good to advise people to keep a healthy diet, to be physically active, to lower their salt intake, what have you, but maybe also take that drug to not get the disease. So I think treatable conditions could really help us in sort of making prevention less an issue of the burden to the participant, but something that we care about as society and we help people with, right? Because now it becomes almost this guilt thing. Oh, if you don't behave perfect, or if behaving perfect doesn't work for you, then who is to blame? And I think we can do, again, better there. But maybe we work a bit on the wording, because disease is a bad label.
Elena, can I
Yes,
add to this? Yes. I think one of the concrete issues that we've been battling with dementia specifically is, or if you think of Alzheimer's disease, that the cause and effect, or the start of the pathology building up and the symptoms being measurable or becoming prominent to the outside world, or even the person, are so long. So unlike hypertension, that we can treat more or less and see the effects more or less immediately or in a short term, for dementia prevention or risk reduction to work, we'd have to wait a very long time. So it's a harder sell to begin with for people to change their lifestyles, but also for medication to roll out, right? So I thought it was an interesting, while thought-provoking idea of creating a new disease, but I think it's at least creating more awareness about the disease or the underlying processes, and how what we do will have it's a long-term investment. It's a hard sell, but we do need to sell it if we want to reduce the numbers long-term.
Love to comment on this, because I think it's actually interesting. You say with lowering hypertension, we see the effect immediately. But the point is that hypertension, nobody feels their blood pressure, right? So it's actually, this shows that you bought completely into the idea that hypertension is a disease that we should intervene on, because we don't lower the blood pressure just for the sake of lowering the blood pressure. We lower the blood pressure for the sake of not getting cerebrovascular events, of not getting cardiovascular events. The participants who effectively lower their blood pressure, they will never know if that is the reason that they don't get it, but on a population level, it works perfectly, right? So I think, thank you for supporting my claim.
And I do have to quickly come back, but then I'll promise I give you the mic back. The other difference that we have with hypertension is with hypertension, we've commonly agreed on a way to measure it. We've defined these are the measures in which what we consider healthy blood pressure, what we want to control, and that's the big difference with brain health, with dementia. There's so many different outcomes that we can measure or try to visualize and measure the effects of treatment. So yeah, if we
hence the challenge and the path forward, because that was of course not the case last century when some people claimed high blood pressure matters. So I think what we basically see is that and that is when we look at the field of cardiovascular disease, the field of cancer, we are just decades behind, but we have the tools and we can learn from how they approach that to a certain extent. And
if I may,
sorry, I will stop here.
Complexity of the discussion. I will say that we had a new disease. The COVID was a new disease, by the way. We don't want another similar. But I think we should also add to the picture the immigration. So we are new population coming that can alter the genetic pathways. We are eating plastic. There's a climate change. I think that to find a healthy food is very difficult to find. So it will be it's a very complicated picture. So I have a question for you. I mean, if Catherine, so this magic toolkit that the WHO has given us, right? Can you tell us a little more in 2 minutes of how we can manage, how can we find this toolkit? What is your vision, how we can use it?
You mean the iGap toolkit? Yes. So that's a product that was released in July, I think, by my colleagues. It's really a document that's meant to help policymakers, but also civil society clinicians on the ground in making iGap, which is the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders, quite a mouthful, implementable. So it has guidance and examples of what can be done to take this dry policy document into more bite-sized, if I can say, steps for everyone to find things to do. The iGap toolkit captures all the what are strategic objectives, they're called in iGap, and the actions that are recommended for member states, civil society, and WHO. And I really, recommend all of you to have a look. I do have a few slides with QR codes where you can scan and access it directly, as well as other accompanying products. WHO is known for producing documents, but unless they're actually used on the ground, they're falling behind their use. So we also appreciate taking opportunities like this to share and disseminate these more widely. And we needed for the iGap also the support from partners like yourself in sharing their ideas, their case studies, their examples of what's already being done to make iGap a reality.
Thank you very much, Catherine. We have, I think, the last question.
Okay, great. Christine Yaffe from UCSF in San Francisco. I want to be a little provocative, but I also want to bring something up because I think it's going to inform the next day and a half, 2 days. Biomarkers. So we all agree biomarkers will be very helpful for improving accuracy of diagnosis, certainly getting at some of the health equity issues. They might be tractable if you want to look at prevention, so fantastic. But what about the issue of what's a disease? So, I think we're struggling with this very much in the States. If you have positive biomarkers and you're asymptomatic, is that a disease? And should that be counted or not? I think it's something we should all talk about because it's going to come up for Parkinson's, it's going to come up for all kinds of other neurodegenerative diseases. And is this a good thing or bad thing? Probably both, but I think it would be really helpful to talk a bit about this.
Thank you very much. I think, yes, we have other session that will specifically address this development and the biomarkers is a huge, really, area everywhere. So I think we can close this session with some key messages. There is if it's a brief, very quick question, yes.
From Paris, France. Thank you very much for the nice talks. I think that during the last talks, we've mostly talked about individual prevention, so prevention at an individual level in persons at risk. But there's also the possibility of doing prevention at the population level, so by changing laws, by thinking. And so I would be interested in hearing about your thoughts about how do you see things? What would be more useful? Population interventions, which be accessible for everyone, individual preventions. So what do you think about these two approaches to prevention?
Can I answer this question maybe in a year's time from now? Because we're trying to also get a handle on this exactly with the update of our dementia risk reduction guidelines, with dementia as a specific outcome. But exactly to your point, what's the balance between the effectiveness of individual level interventions, population level? Where should countries invest their money? So yeah, right now I don't have the answer yet, but I'm hoping that within a year's time or so we'll have more clarity.
I can give an answer, and that is a very basic epidemiologic answer. I think it's and. So we have to have the high-risk strategy that is targeting the people, and we have to have the population strategy, because we all know that the majority of cases, patients may arise from people at very low risk, right, who may not be motivated to change behavior, and that is where policy interventions can help. So it will be and maybe some and more.
Okay, so again, holistic, inclusive approach. So at the end, I think of this session, some key messages. I think we have really learned on the huge impact of a neurodegenerative disorder on the community, and so all this massive, expensive and burden that they urge the community to act. I think we have been very happy to identify with some brain health determinants, and that we can maybe act and modify something with some plans. Now we have some plans that we can apply, and then this holistic approach that we have used also to identify say potential risks that can be modified. We know that somebody that probably will not able to do anything, but we keep the enthusiasm and the moderate optimism that we can really make a change in the next few years. So having said that, thank you very much to all the speakers. We have a break, right? Is outside, and we will come back at 11.
yeah, yeah. Yeah, 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 yeah. Yeah, 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 yeah. Facciamo così. Yeah, 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 Test, 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 test. Yeah, 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 Ça. Test, test, test. Ta ta ta. Ta 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 ta. Ta 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 ta. Ta 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 ta. Ta 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 ta. Ta 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 ta. E sa. Yeah, 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 yeah. Tac. Test, test, Quanti metri ci saranno da qua? Là?
La 2 partirà da tavolo. 2 partirà da tavolo? Sì, perché ci sarà il moderatore, credo. Cioè credo, dipende dove si mette, però...
Voi avete contato i metri che ci sono da qua?
Guarda, vorrei essere così illuminato.
Sa. Test 1, 1, Sì, sa, test delay, test delay.
o vado a chiederlo a lei.
Please take a seat so we start again. Okay, I think we can start again. Welcome back. Well, first of all, I want to congratulate my dear friend Giancarlo for organizing a so beautiful and interesting meeting. And I want also to underscore that the attendance is not only here in presence, but there is a streaming with people attending from all over the world. And my duty is to moderate this session regarding pollution, the role of pollution for human brain health. Is a somehow neglected topic, really. Also, there are many evidences of the role of pollution in favoring neurodegenerative disorders, and is one of the 14 risk factors pointed out by the Lancet Commission, is somehow neglected by clinicians. And there is also the wrong idea that there is little we can do about it. It's just a matter of government and organization. Instead, each of us could do something personally and also as scientists to communicate the risky effect of this factor. We live here in Milan, which is one of the most polluted city all over the world. So our behavior should also take account of this important risk factor for our health, not only brain health, but general health. We have three important speakers which are talking about the role of pollution in multiple sclerosis, in Parkinson's disease, and in Alzheimer's disease. So I'm happy to introduce the first speaker, who is Lars Alfredsson. He's professor of epidemiology at Karolinska Institute and studied recently the role of pollution, mainly in multiple sclerosis, and has a huge scientific production, so we are eager to listen to your presentation. 20 minutes, and then there will be a final general discussion.
Thank you very much for the introduction, and I want first to express my gratitude for this good and very well thought conference, bringing different branches together. I think that's awful. That is not awful, that's awesome. So I will look on pollution, but I will broaden the concept a little bit. Let me see, there you go. By looking on different airborne lung exposures, because there are a similar pattern, which I think you will realize after my talk. So I will review what is known about smoking, environmental tobacco smoke, organic solvents, and also air pollution, and the relationship with risk of developing MS. And I will also ask the question whether these exposures interact with the two most important MS-associated risk genes. So let us start with smoking. Smoking has been found to be associated with an increased risk of multiple sclerosis of around 50% for ever smokers, a bit higher for current smokers. In a lot of, I would say, more than these two reviews, but they find the same, about the same magnitude of the risk increase. And there has been also observations that there is a dose-response relationship between pack years of smoking and MS risk, and that also both duration and intensity of smoking influence the risk of MS. And most importantly is also that the risk of developing MS decrease after smoking cessation. All these things speaks in favor of a causal relationship. I will illustrate a little bit on this topic by talking about the results from two Swedish studies. First one is epidemiologic investigation of multiple sclerosis, AIMS, and the other is genes and environment in multiple sclerosis, GEMS. Both are population-based case control studies with aim to study gene-environment interaction in relation to MS risk, and altogether they comprise about 9,000 cases and 12,000 controls. All cases fulfill the McDonald criteria, and the controls were randomly selected, matched by age, sex, and residential area from the population register, which is continuously updated. All participants answered an extensive questionnaire, and the blood sample was taken for genetic and immunological information. To illustrate the dose-response relationship, we see this figure here with odds ratio on the y-axis and number of pack years on the x-axis. And we can see that if you have smoked 16 pack years or more, then you have nearly twice the risk to develop multiple sclerosis. And here is an illustration of the results for duration of smoking and intensity. We have intensity up here and the duration in years. and compared to never smokers, we see that if you smoke for rather not so long, less than 5 years, but you smoke rather much, then you have an increased risk. And more importantly, perhaps, is that even if you smoke few numbers of cigarettes per day, but do that for a long time, you have a very increased risk to develop MS. And this opens up also for that other lung exposures may be harmful for the risk to develop MS. As I said, the risk to develop MS decreases after smoking cessation. So after 10 years after quitting smoking, you are down to the baseline risk again. And one interesting information is regarding snuff use. Snuff share the nicotine with cigarette smoke, but not other things. And snuff use, which is used much in Sweden, snuff use decrease the risk of developing MS, and that speaks in favor that it is likely not the nicotine that is harmful, it's rather the other substances in the cigarette smoke that are harmful. So, and what about gene-environment interaction? Well, it is known, as you all know, that MS is depends on both genes and environment, but there has been rather few studies with data on both genetics and environmental factors. So, but why is it important to study interactions? Well, if two causal factors interact, then they take part in the same causal pathway towards disease, and vice versa. Another way to put it is that there are persons in the population that would not have had the disease if they not were exposed to both interacting factors, so they need both. There are different measures of interaction, and here are the three most used, and I will preferably use the first one here, attributable proportion due to interaction, which describes the proportion of cases among those with the two interacting factors, those double exposed, the proportion of cases that are due to the interaction per se. So if the attributable proportion is 30%, then 30% of the cases among the double exposed are due to the interaction per se. So let's then look upon the interaction between smoking and the two main MS risk genes, the HLA-B115, with an odds ratio of around 3.5, and presence of HLA-AU2, which is a protective allele. But when studying interaction, you have to do it among risk factors, so then you have switch sign to look on absence of this protective allele, and then it confers an odds ratio of 1.7. So here is the first result regarding gene-environment interaction between smoking and these genes. And here we have different combinations of these two genetic risk factors. So here are those with the least risk, and here are those with the highest genetic risk. And as you can see, among never smokers, the risk steadily increase here with higher genetic risk. Looking on smokers, there is an obvious interaction going on here, and smokers with the highest genetic risk have nearly 20 times the risk to develop MS compared to those persons that never smoked and have low genetic risk. This finding has later been confirmed by combining 4 Nordic materials, and we see that there is indeed statistically significant interaction between both smoking and the HLA-B15, as well as between smoking and absence of HLA-AU2. So let's then focus on passive smoking or environmental tobacco smoke. There has been one study where they pooled 4 studies that had not been so many studies on this topic, but they found an odds ratio 1.24. After that, there has been one result published where they found that the odds ratio among women was 1.4 and among men 1.2, so that aligns well with what was found before. We have looked upon this in our AIM study as well, and here all persons are never smokers in this table, and then we have asked them whether they are exposed to passive smoking at home, one question, or at work, another question. And then we have combined those, and we have duration in years here. And here we have the adjusted odds ratios we have adjusted for a number of potential confounding factors. And indeed, we see that there is a significant interaction, no significant association here between environmental tobacco smoke and increased risk for MS. And that is also a significant dose-response relationship. And those having more than 20 years of duration have a very high risk compared to never smokers. And what about the interaction between passive smoking and these genetic risk factors? Here we have combined our material with an American material, the Kaiser Permanent Northern California case control study, where we see similar patterns. And once again, we see when we calculate the interaction, we see significant interactions between passive smoking with both DRB115 as well as with absence of AO2. So, organic solvents, another airborne lung exposure, and here I talk about occupational exposure to organic solvents. Here we see the results of a review here, a meta-analysis, which found that the summary measure was an odds ratio of about 1.5, and that the more recent systematic review has found about the same. And when we did a look on that in our AIMS case control study, we also found that the adjusted odds ratio was 1.5. We were also able to look on dose response relationship, and we could see that there was significant trends for both with the duration of exposure as well as with the intensity of exposures. Then, looking on the interaction between these genetic risk factors, here we also have to take smoking into consideration, of course, so we have different combinations of smoking and exposure to organic solvents here. And obviously there is something going on here, and those ever smokers exposed to organic solvents have a very high risk if they have the highest genetic risk compared to this comparison group here. And we calculated the interaction between these two genetic risk factors among smokers per se, and then among never smokers separately, and we found that they interacted both among smokers and among non-smokers with these genetic risk factors. So we see once again the same pattern here of gene-environment interaction. So, and other lung irritants, we have ambient air pollution. And actually, the studies of these risks, this exposure and MS risk have been mainly uninformative. There have been 2 cohorts with very good outcome and confounded data, but with a limited number of cases. Others have been register-based studies with a large number of cases, but with very limited individual confounder information. So the conclusions has been hampered by this, I would say. So we have in Sweden set out to study the association between exposure to combustion-related air pollution and multiple sclerosis risk. And we did that by performing 2 population-based control studies. First, we did a register-based study comprising all cases in Sweden during a certain time, which were about 22,000, and then comparing with 100,000 controls. And the AIMS and GEM studies are embedded in this register study, and there we can adjust for genetics and lifestyle confounding factors. And they together comprise more than 6,000 cases and 8,000 controls. So for all participants' residential history between 1990 and 2018 was provided by the Swedish tax agency in form of geographical coordinates. And then the Swedish weather authorities have developed a model where they can model for each geographical coordinate. They can give us the combustion-related air pollution levels in form of nitrogen oxygen levels at their home then. And the spatial resolution of the modeling was quite good. It was 100 times 100 meter for road traffic, 200 times 200 for residential wood combustion, and 5 times 500 meter for other large point sources. And here is an illustration how it looks like. Here is the country of Sweden, nearly at least, and the more red or yellow, the more is the level of the NOx. And here we see the big cities. We have Stockholm here, we have Gothenburg and Malmö. So we see the roads here really. And the key findings were that combustion-related air pollution as measured by high nitrogen oxide levels 3 years before index was associated with the risk of developing MS in a dose-dependent manner. And this was seen both in the register study as well as in the AIMS-GEMS studies. And to illustrate this a bit with numbers, we see here the quantiles of NOx levels. And comparing with these lowest level, we see in the adjusted odds ratios here. We have adjusted for a number of potential confounding factors here and even more, but it was these that turned out to be confounders. And we see that there is a steady increase in odds ratio here and a significant trend. We see it for women and we see it for men. We then performed an analysis where we looked on ever smokers and never smokers separately, and what we can see here that especially among never smokers, the combustion-related air pollution really does matter with high increases here in the upper quintiles here. I was a bit surprised because in Sweden there are the levels are relatively low, but still we see this. And also we see an interaction here illustrated by the DRB 115.1 and air pollution. So in conclusion, it seems like different sources of lung irritation contribute to the development of MS, especially among subjects with a genetic susceptibility. And hypothetically, this is due to non-specific lung irritation with activations of CNS-specific autoreactive T cell with a pro-inflammatory bias. But not mutually exclusive to this theory is the possibility that lung irritation introduces post-translational modifications of proteins in the lungs that are cross-reactive with CNS antigens, which we have seen in rheumatoid arthritis, for instance. And we are just now investigating this in detail together with Stanford. So thank you for your attention, and here are some colleagues that have contributed to this work. Thank you.
Thank you, and we'll have the discussion at the end. Now we introduce another theme regarding Parkinson's disease. It has been known since many years that environmental pollutants, pesticides may influence this disease, and this will be very well described by our next speaker, who is Professor Caroline Tanner. She's professor of neurology and vice chair of clinical research in the Department of Neurology at the Weil Institute for Neuroscience, University of California in San Francisco. And she specifically studied association between exposure to pesticide and the risk of Parkinson's disease. So please.
Thank you. So first of all, I'd like to thank the organizers for the opportunity to be here and participate in this really exciting conference. It's a great honor. These are my disclosures, which have nothing to do with my talk today. And before I talk about pollution, which will be the focus of my talk, I wanted to have a few just framing ideas. First of all, in 1817, James Parkinson's described a motor syndrome of bradykinesia, rigidity, and tremor. Now, this was the height of the Industrial Revolution in Great Britain and arguably maybe the beginning of an era of human pollution that hadn't previously been witnessed, and our contribution of pollution to the environment. So very relevant to the topic today. Since that time, we've come to recognize that Parkinson's is not just a motor syndrome. There are many, many other features that are key factors of the disease. And more than that, if this is the time of diagnosis right here, the motor syndrome, prior to that, for years or decades, people may experience rapid eye movement sleep behavior disorder, constipation, depression, anxiety, loss of sense of smell, hyposmia. And this is important partly because it's important when we're thinking of causes and prevention to recognize these early features of disease that are not just the motor syndrome, but also because this could give us a window to a way to prevent or mitigate with these relatively earlier features, some of which, if they're monosymptomatic, like constipation or hyposmia, may not be nearly as bad as the progression of Parkinson's as it proceeds. A few evolving concepts which also lead to new opportunities I also want to mention just to frame this, our thinking throughout the conference. First of all, we've heard already others mentioning biomarkers. In Parkinson's, misfolded alpha-synuclein now can be detected for the last few years in spinal fluid, in skin. We have a poster that shows it being detected in blood for 90% of people with the clinical syndrome of Parkinsonism, so most people, but also people with those early features, REM sleep behavior disorder, people with just hyposmia, and also people with Lewy body dementia, often considered to be a sort of a different disorder, or pure autonomic failure, also have this misfolded alpha-synuclein that can be detected. So it suggests there may be a shared etiology, or these may even be phenotypically representing an underlying common pathophysiology. Another separate point, co-pathology is increasingly, I think, a factor that we need to be thinking about, and there may be biomarkers for this co-pathology that we can apply in life, but right now at post-mortem, we recognize that many people with Parkinson's have Alzheimer's associated or tau pathology, and these may be the people with more rapid progression, more malignant disease, more dementia. Also, at least some people with Alzheimer's have synuclein pathology. So are there common etiologic factors that cross the neurodegenerative disorders? And is it increasingly important for us to look at multiple biomarkers when we're thinking about causes and ways that we can then mitigate those causes, risk stratification, and approaches to prevention? We've already heard the global burden of disease is increasing. It makes it imperative for preventive strategies that include primary prevention, but also secondary prevention, identifying and then preventing symptom onset, so biomarker identification, and tertiary prevention, meaning even when someone has disease, there may be interventions that we can use to slow progression and reduce the burden of disease. So to do this, knowing the cause of Parkinson's would be helpful. While we don't absolutely know that today. My colleagues and I undertook to study this many years ago in a cohort of veteran twins. We looked for concordance in male twins with and without Parkinson's, and found that concordance was very similar in monozygotic and dizygotic twins. We followed them up 20 years later, pretty much at the end of the lives of most of these men, and had the same findings. So apart from young onset, it seems that in the typical older age and onset Parkinson's, environment is an important contributor to the cause of disease. So this is an important factor for us to consider in thinking about mitigation. And taking a page from the World Bank Group, pollution is the largest environmental cause of disease and premature death. In Parkinson's, we focus primarily on air, land, and water pollution, but I'll point out that there are other types of pollution, plastic, noise, light, thermal, that increasingly may also be important for us to observe in relationship to disease risk. Pesticides have been associated with Parkinson's for decades now. Most studies use that broad category pesticide, and that's very difficult to apply beyond a certain point because there are so many different compounds. They may have very different mechanisms, so identifying individual agents is very important. So my colleagues and I undertook to do this in 2 studies that have the same basic mechanisms. So we took job task-based histories and had a blinded rater who was an industrial hygienist familiar with processes to look at occupation, crops, typical pesticide use in those areas throughout the lifespan of people. One was in a prospective cohort, the Agricultural Health Study in the United States, farmers and their wives in 2 states in the US, and the other was a case control study that was nested in clinics in the US with community controls. We used experts to determine diagnosis, and in both cases, we found that paraquat, the herbicide, was associated with more than a 2-fold increased risk of Parkinson's disease. There's biologic plausibility. Paraquat does things in the laboratory and animal models that are consistent with our understanding of pathogenesis of Parkinson's, so fibrillary aggregation of alpha-synuclein, mitochondrial dysfunction, oxidative stress, injury to the substantia nigra, as well as other factors. So this is a distribution of paraquat use in the United States in 2018. Interestingly, not much has been reported since then, and it's been a point of a lot of focus of controversy. And this shows the increase from 2010 to 2018 in use of paraquat. So it's banned in the EU, UK, China, but in the US, in Australia, and other countries around the world, use is increasing, so remaining a very important point for our focus. 2,4-dichlorphenoxyacetic acid, or 2,4-D, has been associated with a 2-fold increased risk of Parkinson's. It was used as an herbicide in a number of combinations by the US military in the Vietnam theater. We also found this in the case control study I just described in civilian populations based on their occupational exposure to be associated with more than a 2-fold risk of Parkinson's disease. So 2,4-D is another example. It's an herbicide that's been used since 1945, more than 1,500 products, and importantly, environmentally persistent, groundwater, soil, it's in the oceans, and it's used extensively on lawns, golf courses, farms, so very extensive use of this herbicide, and yet almost nothing is known about human or animal toxicology. So this is a partial, I think it's close to complete, but maybe not, list of pesticides that in one way, in one study or another, have been linked with Parkinson's. You can see it's really extensive. And I think it brings home another point. While we often focus in the laboratory and also in our human studies on one factor, in fact, the human experience is we are exposed to combinations, not just of pesticides, but of other pollutants and other positive factors as well, healthy lifestyle, as we've heard about, factors that may help to prevent the onset of disease, even if you're exposed. And we have our own substrate of genes, as well as the microbiome, another area that may affect our ability to prevent against exposure or metabolize exposure to toxicants. So a lot to learn that we haven't yet been able to apply very extensively. The green map shows the pesticide use per hectare of cropland in 2019, with the dark areas being the higher levels of exposure. This is DALYs caused by Parkinson's by country, with the dark being the higher level of disability. And this shows the deaths caused by Parkinson's by country, again, the dark showing the higher levels of disability. So it's an ecological observation, but I think the take home is at least intriguing that there seemed to be a great confluence and concordance of dark areas associated with greater disability and death for Parkinson's and more pesticide exposure, making it certainly the idea that this is a global issue that we should all be paying attention to. And this shows the use of pesticides per hectare cropland from 1990 to 2019. Notice the lines are all going up. Some of them are sort of level, but nothing's going down. And there are certain areas like South America, Asia, Oceania, that have really fairly steep increases in pesticide use. So again, this is not a problem that's going away. Chlorinated solvents, trichloroethylene, was identified in a small factory in Kentucky by a neurologist who just happened to notice that a number of the people in his clinic were working in the same place and realized that they worked in a vapor degreasing vat that was using trichloroethylene. We then followed that up in our discordant male twin pairs and used that lifetime occupational history with a blinded industrial hygienist rating exposure to minimize any aspects of recall bias. And what we found was that both trichloroethylene and perchloroethylene, or PERC, were associated with significantly increased odds of disease in the twin pair who were discordant. So the twin with Parkinson's was the one with the chlorinated solvent exposure. Not going forward. I can get it to go back, but not forward. Whoa. Okay, so trichloroethylene also has biologic plausibility. It causes nigral injury. Both of those chlorinated solvents are metabolized to the same active compound called TACLO, which resembles the neurotoxicant MPTP, which is sort of where this whole story started. I don't have time to talk about that today. So certainly seems possible that these are related to disease risk. Whoops. Okay. We were able to assemble a group of 7 individuals who had personal exposure to trichloroethylene of various types, residence, occupation, and were willing to be sort of named and identified in a little case report. One of these was the basketball player Brian Grant, who had Parkinson's onset at a young age. And interestingly, he was a child living at Marine Base Camp Lejeune in North Carolina when his father was in the service there. And the Marine Base Camp Lejeune had decades of contaminated water with trichloroethylene and perchloroethylene, and more than 70 times greater than the US EPA maximum contaminant level. So we were able to investigate Marines who served at Camp Lejeune and Marines who served at Camp Pendleton and explore the relationship of residents at one of these places and risk of Parkinson's, and found about a 70% increased chance of Parkinson's in the Lejeune residents compared to those who lived at Pendleton, where the water was not contaminated. And note, these are really still young populations, so who knows what happens as they age. We also were able to look at some of the prodromal features associated with Parkinsonism, so olfactory impairment, anxiety, depression, also higher in those who served at Lejeune compared to Pendleton. And we used the Movement Disorder Society prodromal risk score, which was also higher in the Lejeune residents. So suggesting that that process that I showed you at the very beginning of progressing from REM sleep behavior disorder, hyposmia, other features to motor Parkinsonism is also associated with this chlorinated solvent exposure. When we looked at people who had Parkinson's and had exposure to chlorinated solvents, we also noted that those people appeared to have more rapid progression to some of the more serious milestones that we identified, such as falls, fractures, and psychosis. So you can see here in the red line, those with the higher solvent exposure who had Parkinson's had a much more rapid progression to the bad milestones compared to those who did not have high solvent exposure. So trichloroethylene is a solvent that has been used in multiple industries since the 20s, still used extensively, environmentally persistent, and present in the US in about 33% of the water supplies. So that's a very important statistic because most people may not know that they're having exposure to trichloroethylene. It's not monitored. And another important factor, it's a volatile organic compound, which means if there's a spill in the soil, it can evaporate and concentrate in homes or offices and be present in the building in a concentrated form as another source of exposure. And this is just an example of how that may happen. This is a group of attorneys in Rochester, New York, who worked in a building that was next to a contaminated site due to a dry cleaner spill that hadn't been cleaned up. There were attorneys in that building compared to attorneys in another building across town without the exposure. The exposed attorneys had Parkinson's, multiple system atrophy, or TCE-associated cancer, about 25% of them, compared to only 7% in that comparison attorney group. So again, suggesting this could be an example of Parkinsonism due to this exposure to TCE concentrated in the building. This is a map of countries that have published studies of groundwater contaminants showing the distribution of TCE contamination around the world. So it's not just a US problem, this is a worldwide problem and something important, I think, for us to keep in our minds. You can be exposed to persistent pollutants even if you don't live next to a contaminated site or work in an occupation with exposure. For example, the way that the ocean currents go and the winds blow around the globe can concentrate pollutants in certain areas, for example, the Arctic. So we studied Alaska natives to understand whether we could see any association between environmental pollutants and Parkinson's. And what we found was that the organic chlorine, hexachlorobenzene, polychlorinated bipheноls, and DDE were all higher in the bloods of people with Parkinson's who lived in the Arctic compared to those without Parkinson's, suggesting that there may be an exposure to persistent pollutants even in these natives who had no occupational work with those. Air pollution we've heard about already in other contexts, but these are two recent papers, not from my group, but very important, I think. One is showing in US Medicare beneficiaries an increased risk of Parkinson's. This is from Brad Vassette's group, associated with higher concentrations of particulate matter 2.5. And then a second one that just came out from Rodolfo Savica and his colleagues at the Mayo Clinic looking at Olmsted County, Minnesota, and they found the same association of higher PM 2.5 and increased Parkinson's risk, but they also were able to look at the cases, and what they found is that the people with higher exposures and Parkinson's disease had a more malignant disease and were at greater risk of dyskinesia. So again, suggesting that exposure isn't just a risk factor for disease, but that if you have disease and you have exposure, you don't do as well. This is a map that we plotted a few years ago looking at incidence of Parkinson's in North America, around the US actually, and the dark areas are higher incidence, more than 450,000 cases and per 100,000, and the green areas are lower risk. And what you can see is quite a variation, possibly related to variation in environmental pollutants. But we know that many are exposed and not everyone who's exposed gets disease. So obviously the importance is that there are combinations of genes and environment, including pollutants and lifestyle factors. So this is an example of a gene-environment interaction in Parkinson's. The glutathione S transferase gene is a detoxifying enzyme, produces a detoxifying enzyme. If that is absent, you have a very slight increased risk of Parkinson's. if you have that and you're exposed to paraquat, or if you're exposed to paraquat in the absence of the null GST1, you have a somewhat higher risk, as we've heard, about twofold increased risk. But if you have the absent GST1 and you are exposed to paraquat, your risk is now about 11-fold, so dramatically increased risk of disease. Head injury, we know, is associated with increased Parkinson's risk, about 3-fold overall. But if you have head injury and you have paraquat exposure, your risk is about 4-fold increase, possibly because these both have similar synergistic mechanisms causing oxidative stress. They trigger inflammation. Maybe head injury even disrupts the blood-brain barrier, although in these cases, the injury occurred well before the paraquat exposure. And there is some biologic plausibility for that. So it leads to this idea that complex combinations are really going to be the important determinant in any one individual. So from an individual perspective, this precision medicine idea of risk stratification and, you know, time of exposure and the temporality are going to be very important. In a population perspective, we could step back and say, these are many things that we need to address and try to mitigate. But complex models will be important for our future work, both in populations and in laboratory studies. So just a schematic, there are many genes I couldn't talk about today that are associated with Parkinson's, accounting probably for maybe 20%, maybe 30% max of disease risk. Even most of these genes that are strongly associated with Parkinson's are incompletely penetrant. So environmental factors are also probably important. And then we've covered most of the environmental factors today that have been strongly associated with disease. I haven't been able to talk about the factors that decrease risk, so also important, and especially from the perspective of prevention. All of these have similar mechanisms in the laboratory, so important that we sort of feel like we're on the right track. And just a little note of hope at the very end. Is primary prevention possible? These are a couple of examples from the Ag Health study that I just mentioned to you. First of all, applicators who were exposed to paraquat and followed a healthy diet were not at an increased risk of disease, while those who followed an unhealthy diet, so the healthy diet was sort of Mediterranean-like, the unhealthy diet and used paraquat were at a more than 4-fold increased risk of disease. So one good example. The second, if people use personal protective equipment and were exposed to paraquat, they also didn't have an increased risk of disease. And if they didn't, they had a 4-fold increased risk of disease. So it suggests that there are things we can do, even in a very practical way, that may make strides in terms of preventing Parkinson's and associated disorders. So I thank you very much for your attention. I acknowledge my colleagues and the many volunteers, research participants, and our sponsors. Thank you.
Thank you. Thank you. Very clear, very suggestive. Okay, let's move to the last talk regarding Alzheimer's disease. And we know already that pollution is a very known risk factor for this disease. And the talk will be given by Professor Karin Jane Aste, who is fellow in the School of Psychology at the University of New South Wales in Sydney, and Senior Principal Research Scientist at Neuroscience Research Australia. She investigated mainly the topic of cognitive resilience in aging and the risk of the dementia, and she's member of the World Dementia Council. So she will talk about pollution and the risk of dementia. Please.
Thank you. And I'd just like to thank the Prada Foundation for the invitation to speak today and to attend this wonderful event. So yes, I'm talking about pollution and Alzheimer's disease. I just wanted to put the talk in the context which many speakers before have already done for me, and that is that I'm talking about one risk factor. Alzheimer's disease causes about 65% of dementia, but a lot of the research in this field looks at all-cause dementia or cognitive decline. So there's really a continuum, and we'll be looking at all of those in order to understand the impact of air pollution on risk of Alzheimer's disease and dementia. And of course, there's a number of interactions. I won't be able to have time to go into all the interactions, but again, wanted to emphasize, like previous speakers, that this is a complex area. So I'm going to talk about life course impacts of passive smoking and smoking first, then I'll look at ambient air pollution, the sources of particulate matter, wildfire smoke, or bushfire smoke as we say in Australia, and then move on to looking at the impact of some policy interventions to reduce air pollution and talk about inequality. So first of all, I wanted to talk about passive smoking because I think it's a neglected area in the field of dementia risk reduction. So globally, it's estimated that 35% of non-smoking adults and 40% of children are exposed to secondhand smoke. But research on this is really limited. And there's one very important study that was published in 2017 in China. It was a longitudinal study by Pan and colleagues, and they examined the association between household secondhand smoke exposure and cognitive function in women who did not smoke. They had 2 waves of data from the China Health and Retirement longitudinal study, and what they were able to show is that longer exposure to secondhand smoke was associated with greater cognitive decline over 2 years. Remember, these women didn't smoke, but memory decline was also greater in those who were illiterate, lived in rural areas and reported depressive symptoms. So again, risk is occurring in the context of multiple other risk factors. So we looked at this in a narrative review in 2013. There were only 15 articles, and we're interested in the effect of passive smoking on cognitive development in young children and prenatally. So overall, the finding of this systematic review was that secondhand smoke exposure was linked to poorer cognitive function, prenatal exposure negatively impacted neurodevelopmental outcomes in young children, and postnatal secondhand smoke exposure was associated with poor academic achievement and neurocognitive performance, and it was also associated with an increased risk in neurodevelopmental delay. So really, passive smoking is an under-recognised risk factor for dementia or cognitive decline or poorer cognitive health and then late life dementia. And what's really important, I think, is that it really impacts vulnerable groups. So secondhand smoke disproportionately affects those with limited control over their environment. So young children or people who are in particular environments where they can't move out of that environment because of their occupational or social status. There's a research gap here. While smoking is known, and smoking is a very well-studied risk factor, the research is really overlooking secondhand smoke. And so we, a few years ago, really had a call to action and say we need to do more to look into this. Now I want to talk about smoking. So it's been known for a long while that smoking increases the risk of late life dementia. We conducted one systematic review of many, showing that it increases the risk of any dementia, Alzheimer's disease and vascular dementia, and cognitive decline. So all of these interrelated outcomes. And it's now been shown that midlife exposure, so initially the finding for smoking was it was late life exposure increased risk of late life dementia. We didn't have enough evidence to know whether or not if you smoked in middle age, that also increased your risk of dementia in late life or Alzheimer's disease in late life. The evidence has now accumulated, and so in the latest Lancet Commission report, smoking has been added to midlife as a risk factor. That's because the evidence has accumulated, not because anything's actually changed. So smoking is a well-established risk factor for dementia and Alzheimer's disease. The good thing about smoking in terms of looking at risk reversal is this is a risk factor where we are starting to see emerging evidence that smoking cessation is associated with a reduced risk of dementia. So there's been a few studies showing, and I'm just going to give you an example from Korea. This was a study of over 780,000 participants with 6.3 years of follow-up. They had a mean age of 52. And in this study, the quitters, so people who gave up smoking, had a reduced risk of all-cause dementia, Alzheimer's disease and vascular dementia compared to people who persisted with smoking or people who increased their smoking. We've also seen results like this in other studies. A randomised controlled trial conducted in Australia where smoking was a secondary outcome showed benefits in terms of reduced brain atrophy and less cognitive decline, and that was in older adults over the age of 70. I'm now going to talk about other types of air pollution, so more ambient air pollution in relation to cognition across the life course, and then we'll talk about dementia. So in this systematic review, we looked at 31 studies published from 2006 to 2015 from 3 continents, the Americas, Asia and Europe. And like many other studies, we showed that air pollution was associated with cognitive function. So this was not looking at dementia, it was looking at cognitive function through the life course. So early childhood, adolescence, young adulthood, right through the life course. There are associations in the literature on this. Another systematic review we conducted in 2019 focused specifically on dementia and Alzheimer's disease. In this systematic review, we looked at 13 papers that had reported data from a number of countries with follow-up from 1 to 15 years. Most of the research has been conducted on PM2.5, so they're tiny particles that is believed enter the bloodstream and can even cross the blood-brain barrier. And the findings from that systematic review that there was a consistent association between exposure to air pollutants, particularly the PM2.5 and NO2, and an increased risk of dementia. And then the results said that high levels of air pollution were shown to potentially exacerbate cognitive decline, the risk of Alzheimer's disease, so less strong findings for Alzheimer's disease specifically. And this is backed up by other research using other methodologies. So we like to see triangulation with different sorts of methods. So this was a study looking at where the authors pulled the data from 4 large cohort studies. So they had over 12 million participants, 4 huge cohorts. And they also found that exposure to PM2.5 was positively associated with higher risk of Alzheimer's disease. They found an effect with 10 micrograms per metre cubed, led to an increase in hazard ratio of 4.82 with quite a wide confidence interval. The Lancet Commission also reported on air pollution and included that in one of the 14 risk factors in the 2024 report. They used a different metric, so they're using 1 microgram per cubic metre, and so the hazard ratio in the Lancet Commission is 1.1. It accounts for about 2 to 3% of population attributable risk, and that's really because air pollution is so prevalent, so 70% of the world's population is exposed. It actually makes it really difficult to do research because you can't get a control group if everybody's exposed. So there are a lot of methodological issues in this field, which I don't have time to discuss. So just more evidence on air pollution and Alzheimer's disease, specifically in the incidence of Alzheimer's disease from the United States. In this study, they used a different methodology again, looking at medical record linkage, combining Medicare data sets with air pollution exposure, geographical data. And this study from the United States with a huge sample, they looked at data from 2 million dementia cases with 800,000 cases of Alzheimer's disease. And they also found an increased risk of Alzheimer's disease associated with exposure to air pollution. And that was for the PM2.5 again, the NO2, but not for ozone. There was no significant association. Just a reminder that this effect of air pollution is happening in the context of a whole lot of other processes, both biological and other risk factors, other genetic risk factors, lifestyle risk factors, and so it's a very complex causal model, and it seems like this is a theme coming through this morning from a number of the speakers. And then there's research looking at the actual neuropathology of affected by Alzheimer's disease. There's been animal studies, there's been autopsy studies, and a review of the in vitro, in vivo, and clinical studies on the effect of the PM2.5 exposure and Alzheimer's disease pathology has shown mechanisms such as an increased inflammation, increased oxidative stress, neuronal damage, and elevated AD biomarkers such as amyloid beta and hyperphosphorated tau, all associated with exposure to air pollution. And I mean, some of this early work was conducted in Mexico City in autopsy studies where they even had teenagers coming to autopsy who'd been exposed to very heavy levels of air pollution, and there was Alzheimer's pathology in the brains of those teenagers. So this has been going for a long while, so I'm just reporting a systematic review of the neuropathological correlates. So I think it's fair to conclude that long-term and high-dose PM2.5 exposure is linked to neurocognitive disorders and structural brain changes, highlighting the need for further research. But I guess one of the questions is there a source of PM2.5 that's more problematic? So PM2.5 is the size of the particle, but there's different sources. It could be from traffic, it could be from wildfires, it could be from industry. We need to know more, and I guess this is where the research, I'm talking at a very general level with lots of aggregated findings. We really need to unpack that and look at the mechanisms and more specific data on sources. So this study from Zhang and colleagues, it's one study looking at the sources of particulate matter in the United States. They looked at long-term exposure and total and source-specific PM2.5 and linked that with incident dementia in older adults. They had over 27,000 participants, so it was a very big, robust study. And they were able to examine 9 sources of pollution in the cohort. And what they found was really interesting. The most robust associations for PM2.5 were from agriculture and wildfires. So I thought that was really interesting. I was expecting it to be from traffic and that sort of air pollution, but it was actually agricultural air pollution and wildfires. They did find associations with road traffic and coal combustion and other industry as well. So now I want to talk about wildfire smoke and brain health. In Australia, we talk about bushfires, not wildfires, but in North America, I know the term is wildfire. It's a very big topic for Australians. We have a big problem with wildfires. We had dreadful fires in 2019, 2020. I was living in Sydney, a city of 6 million people, and the smoke was so thick you could hardly breathe. I was in the east part of the Sydney, and we had fires to the north and the west. And, you know, millions of people exposed to very intense, very heavy air pollution, and that went on for several weeks. So it is a really big problem with climate change and more of us being exposed. It's been linked now to different types of poorer outcomes in cognition and also neuropathological changes. It's thought that bushfire particulate matter may be more toxic than other types of matter because it may enter the brain through the olfactory routes, leading to inflammation and oxidative stress. And it's thought to be harmful to different cell types. But a lot of this is sort of speculative research and editorials, and there's a lot of calls for action at the moment about doing more research into wildfire and bushfire smoke exposure and cognition. Because it's a fairly new area of research, we don't have many long-term studies that have looked at incident Alzheimer's disease and dementia in relation to wildfire exposure. There have been some studies that are looking at contemporary cognitive function and the impact of bushfire exposure. You know, a short period after the fire, is cognition affected? And this is one of those studies where they had a small study of 75 participants, and they compared those who were directly exposed, those who were indirectly exposed, and those who were not exposed. They assessed them on cognitive tests after the exposure, so after the bushfire was finished or the wildfire was finished, and what they found was there were significant cognitive deficits, especially in interference processing tasks in people who had been directly exposed to bushfires. And they also did some EEG studies, and they were able to show that there were different changes in the evoked potentials in the frontoparietal area, suggesting a compensatory increase in cognitive effort in response to trauma. And what this study raises is that we have a lot of different things going on with wildfire smoke exposure. People are often traumatised, so you've got mental health and trauma responses as well as cognitive impacts of wildfire exposure. The thing is, we know that depression and trauma are also risk factors for Alzheimer's disease and dementia, so we're starting to again have a lot of interacting risk factors associated that's going to be occurring with climate change and wildfires in particular, and that's not to mention the impact of heat and extreme heat on cognition, which is another emerging environmental risk factor. Now, I now want to talk about policy intervention. So there has been some successful policy intervention in the area of air pollution. There was one study in China. China introduced the Clean Air Act in 2014, but not all the cantons implemented the Clean Air Act, and this study by Yao and colleagues was able to compare cognitive change longitudinally using the mini mental state examination in the cantons that had reduced air pollution compared to those that hadn't, and they found that there was more cognitive decline in the areas where the Clean Air Act was not implemented. Other researchers have looked at the benefits of policies for air pollution reduction, and they're overwhelmingly convincing. This was not done in relation to brain health because, again, this is a fairly new area in brain health, but in other areas of health, there's been things like even within a week seeing reduced mortality and heart disease and heart attacks just from implementing risk reduction or removal of things like smoking exposure through smoking bans or closing down factories and reducing air pollution. So there's overwhelming evidence that policy intervention works in this area, and this is a population level intervention. I can't not mention brain health equity because there's a lot of evidence that exposure to air pollution is also linked in with other social determinants of health. and particularly for young children. There's been a model developed for brain health equity in exposure to air pollution, showing how that the probability of living in an area that's polluted is linked to socioeconomic status and lower levels of education, poorer nutrition, etc. All of these things are interacting, but this equally applies over the whole life course, and could be just applied to a life course approach to brain health, expanding on this model for children and brain health equity in air pollution exposure. So there has been one study in the United States that has looked at this issue of brain health equity and exposure to air pollution, and looked at racial and ethnic and income inequalities in terms of who was exposed. And the findings of that study were that for all years and pollutants, the highest national average exposure was found in racial and ethnic minority groups. And that the exposure disparities remained across income levels in urban and rural areas and in all states, and for multiple pollutants. That was in 2020. So just to conclude, air pollution impacts neurocognitive development negatively throughout the life course, and it increases the risk of Alzheimer's disease, cognitive decline in later life, and all-cause dementia. Exposure to air pollution is very much interlinked, though, with a whole lot of other socio-demographic factors and social determinants of health, as well as then interacting with other biological and lifestyle risk factors. Interventions to reduce exposure to air pollution have been associated with health benefits in many health conditions, and we've seen that one policy intervention in China where reducing air pollution led to cognitive benefits. So I think there's a need for a call to action for global and national strategies to reduce air pollution to promote brain health. And I must say that I was looking online here in Milan, and I saw that in the EU, the health ministers about 2 days ago have agreed to support policies around reducing air pollution in Europe, which is really fantastic. Thank you.
Thank you. Now please sit here, all the three speakers, because it's open discussion. And first of all, let me tell you that all your talks were very interesting and provocative, and give us a lot of suggestions how to move as scientists and to act to improve this situation, which is really bad all over the world. And but before we open the discussion, I would like to underscore the mechanism of these different effects. We have different type of pollutants, smoke, environment, pesticides, which may act through different mechanisms. How do you think there is, and these different mechanisms could lead to a particular neurodegenerative disorder? For instance, pesticides are more involved in development of Parkinson's disease, whereas maybe PMI could be more involved in Alzheimer's disease. Do you think there are always specific mechanisms, or there could be a common mechanism underlying the damage, which could be shared between different disorders? This is open to all of you. For instance, neuroinflammation could be a common general mechanism leading to damage to neurons and so on. Who wants to start?
Yeah, because I think the same. And I actually tried to highlight that just for a minute in my talk. So I do think that there's increasing evidence that there are likely shared mechanisms, and there may be some complex combination of your inherent, inborn biology, what happens to you during life, what different exposures you have at different points in time, and then, the more proximate ones that we've been measuring recently, which are really only within a couple of decades usually of the onset of disease, and that those determine which neurodegenerative process you may manifest, or you may not manifest one at all. I think inflammation is an important common theme, and it seems that inflammatory processes are drivers of the underlying etiology in any of these neurodegenerative conditions. And many of the things we've talked about do trigger inflammation. And so I think that may be one common theme that would be something we could address globally.
I'm glad you agree. Please.
So not being a basic scientist, looking at it from an epidemiological perspective, I think it's likely to be both specific and general shared factors. We do know that pesticide exposure is associated with an increased risk of Alzheimer's disease, so it's not just linked to Parkinson's. But I think that obviously the genetic risk factor is interacting with the exposure in order to determine, as you say, which specific neurological disorder occurs in specific individuals. So I think probably some of the general things like neuroinflammation leading to general neurodegeneration may be shared, and then the specifics will depend on your genetic makeup.
Yeah, I will agree with what you say, that there are some persons that are especially vulnerable, and I think common theme here is the inflammation in the lungs, I will say, I believe, but then it may take other, what kind of disease you get may depends on your genetics. But there are much more to be understood, what is happening really to generate the disease. I don't know. We have much to understand there.
Yeah, please, Giancarlo.
Well, I'm wondering if there is a risk for dementia or for the type of dementia, because, of course, mental functions are very delicate. They have a quite complexity. The fact that the risk for vascular dementia and for Alzheimer were very similar does suggest that this more than a specific pathology is targeting the complexity. And the question is there any study that, for example, compares the risk of frontotemporal dementia and the risk of Alzheimer's disease, just to try to disentangle these two possibilities?
So in the epidemiological literature that looks at risk factors, we rarely have enough cases of frontotemporal dementia to look at risk factors. Maybe in something like the UK Biobank we could. And the other problem is that a lot of the epidemiological literature is using fairly, what we now would consider outdated methods of diagnosis, so clinical diagnosis done in a research setting, not using biomarkers or even or imaging. So I'm not aware, maybe other people here are aware of big enough studies. Maybe UK Biobank could do that, but the studies that I'm aware of wouldn't have that data. It's a really good point.
Other questions? Unfortunately, I don't see much with this. Please, here.
Thank you for nice talks. Diego Centonce from Rome, Italy. My question has to do with the possible role of, if you can foresee somehow the possibility in the future that lung microbiota would be recognized as an important factor for inflammation and the resulting brain damage, as gut microbiota is now well recognized. So there is some evidence, but still we need more data just to try to give an overview of what is happening after breathing pollutions and so on.
Would like to answer?
I would say yes. I think that's really important. I haven't thought that much about lung. That's important. Nose is another one that we think about a lot in Parkinson's because of the early olfactory pathology that you can see in olfactory bulb. So I think microbiome is an area that we really need to focus on understanding, and at least theoretically is another area that could be manipulated in a way that may be preventive in people who are prone to disease or possible exposures.
By the way, we spoke about environmental pollution or smoke, but we didn't talk too much about pollution in food. So microplastics and all the drugs which are present, or antibiotics which are present in food may influence intestinal microbiota. And there are many studies about that, I believe. Any other questions? Here? Elena Mora, please, here.
So thank you very much. Excellent talks and nice discussion. So I go back to your question, because these diseases have been here, as you said, before the onset of this pollution. So at this point, right, we really have to understand the mechanism, why this pollution is acting. And probably if we invest a little more research in understanding where do they start to increase the frequency of this disease, because the disease is the same, I think, right? They're all there with the same clinical phenotype, probably. It doesn't change the pollution, the phenotype. It changes more the frequency, right? The prevalence of the disease. So probably we need to investigate really in the mechanism. What do they do that we can prevent, right, a little bit?
Yeah, we agree. Yes, very important.
Just one comment on that I agree with, important to investigate mechanisms, but at least a few of the things that I mentioned also suggest that pollution worsens disease progression, so at least has some effect on phenotype in terms of increasing, more malignant forms or more speed of progression. Very, very difficult to study that, so that there's not much work on it, but also relevant, I think, for us to tell our patients, right?
Giancarlo?
I address a question to Dr. Hutterson. So you mentioned that you may have an interaction also of smoking and pollution. Did they have an additive effect? Because you said that you corrected the part by the smoking habits, but the question is, if a person has been both exposed to a high pollution area and on the top of that was also a smoker, did you see some further increase of the risk?
Yes, we saw some signs of that, but we did not reported on that actually. But you have to be sure of the correctness of the smoking data if you're going to have look on the dose levels and so on. So, but there were signs of that, yes.
Other questions? Well, I keep the important suggestion of Elena regarding our role to study this effect of pollution, how it is important. Our responsibility as scientists to try at least to ameliorate this situation. I was surprised, for instance, that in the United States still there are pesticides in use. There are regions where there are contamination of water, and this study have been done already. So there is no tentative to avoid this situation, and no clear position of scientific societies or institutions to avoid this. I'm glad that the European Academy of Neurology took the campaign of brain health, and there were recently also in Italy meetings for the G7 which focused on this theme, but I still think that we have a big responsibility to foster the reaction to this situation. I don't know if you want to say something more, Elena, about the role of European Neurological Society or also Italian Neurological Society in this theme.
each country have to implement this plan. Those they are available, their country they're starting. In Italy, you mentioned they have a lot of initiative in the lifespan. But I think this the idea of the pollution, one of the important factor in increasing or generating whatever we don't know yet, as you said, is have to be stressed. So, and I have to stress the fact that France is recognizing as a working factor. If you are an agricultural person and you get Parkinson's disease, is recognized as disease caused by these pesticides. And is, to my knowledge, is the only country recognizing this important role of pesticide. So you have to be recognized by other countries. So, so the insurance company will be more careful, and also the one who are producing these products.
In Europe, can you tell us something about the United States, if there is something or not, or Australia?
So yeah, you may want to mention Australia, but it's a complicated dynamic. I'll say that. And so there has been a lot of advocacy specifically around paraquat, maybe others, but the paraquat is ongoing for the reasons you just mentioned, that there is quite a bit of evidence. There is advocacy, there's a petition to be signed, there are, things that are being put forth by patient groups. There are meetings that are, in progress, talking to regulatory bodies who review material and make judgments about whether or not a particular compound is safe and what kinds of restrictions should be put on its use. So far, that particular compound has been reviewed a number of times in the last few years, and each time the regulatory body has decided it's safe for use and not enough evidence to suggest that it's been damaged. Would damage human health. So people keep asking them to review it again. We'll see.
Australia?
Yeah.
Well, we have regular, quite tightly tested water. All our water supply is regularly tested. And we recently found out that an area in New South Wales, the Blue Mountains, I don't know if anyone knows Australia well enough to know where that is, but the water supply in that region was contaminated with pesticides, and that has been a major media issue with people stopping drinking tap water for the first time, because we've always felt that the drinking water in Australia was safe to drink. So there's increasing public awareness, but there's areas where we're behind. So things that are still legal in Australia, some pesticides which are banned in Europe, for example. So it's kind of mixed, I'd say. Yep.
So it's a very important topic. So our role, I think, is very important. And thanks God, in Italy, I don't know, 20 years ago, we had a law who banned smoking in public places. I remember when I was a child sitting in a movie theater or in a bar, there was always full of fog of smokers. Now the situation is completely different, but still there are countries where smoking is not banned in public places. So this is another very important topic. Any other questions? Well, if not, I thank all speakers. Yes, yeah, sure.
On the PM regarding wildfires, why should they be more dangerous?
Wildfire. I think it's a combination of the type of toxins in the wildfire, but it also occurs with periods of extreme heat. And there's evidence now that extreme heat is bad for cognition. There's been big population-based studies linking periods of high exposure to high heat with faster cognitive decline in aging. And it's also associated with a lot of stress and trauma. So you've got three converging risk factors with wildfires.
And anyway, fire we have in the fireplace at home is more dangerous than heating with normal heating,
yes.
right?
I mean, yes, the pollution from wood fire burning is also a risk factor. So, and this is a good reason to move to things like renewable energy and electric cars. It's another, which hasn't, the health benefits of those changes often have been overlooked.
They are not acknowledged by
Yes.
countries, so
Yeah.
So there should be more regulation about that all over the world, I believe. Please, microphones there, and then you.
Alana Katsan from New York. Just in reference to the comment about the different regulatory environment in the US as compared to in Europe and why certain substances are banned, for me, this is not surprising at all. This is a very big problem in the United States, not only in terms of environmental pollutants, but also in terms of foods, for example, and regulations of plastics and all of these things. The US, I think, is very behind the rest of the world. And I think it's because the environment in the US has become so heavily politicized, and the lobbies for all of these industries are so powerful that things are done and then undone and done and then undone, and everything is related to the fluctuations in terms of who's in power in the government, and it shouldn't be this way. But for example, the Environmental Protection Agency, the EPA, the extent of their power can be decided, and it fluctuates with time. It shouldn't be that way, but that is the way it is. And so I do think that it is our duty to advocate for our population, but I think there are some very important differences in the way that information is received in the US. I think there's also a certain lack of respect for science and scientists in the US that you don't see as much in other places in the world. So it's a challenge.
You agree? Yeah. I agree. You agree completely. You had another question?
No, a question, just a comment. We actually did a separate analysis for wood fires at home, and we saw an increased risk for MS as well.
For MS?
Yes.
Okay. So,
just a comment.
We need to share this information to media. Please.
Hello. Yes. So this is Sergio Baranzini from University of California in San Francisco. I also wanted to follow up on what Ilana Katsan just said about food and additives. And unfortunately, in the U.S., the states have a lot of will in terms of how to regulate those things. So that there is at the national level, but then also the states those decisions are largely given to states. And in some states, most of them will be in a very tight political situation where decisions are not easily made. But for example, I think 10 days ago, California banned 6 food dyes that are currently prohibited in the European Union. I can't remember all of them, but blue, red 40, yellow 5, and yellow 6. Those are widely used food dyes in the US. In fact, the common candy Skittles, those colored sugary chewies, they are all using those, and they're banned in the European Union. And they're still widely sold in the US. So California banned those now. So because there's been linked sufficient evidence, at least for California, to and for the European Union to consider those dangerous for health. They've been linked to multiple malignancies. So again, it's a political. Unfortunately, it's a political decision that in the U.S. is not consistent throughout geography and throughout time.
Yeah.
I could make one more comment.
Sure.
The other thing about U.S. regulation and evaluation of compounds for safety for use or not is that many of these regulations were set up decades ago, and it was really focused on things like, maternal and child health or cancer prevention. Very little thought about the central nervous system, a little bit about the peripheral nervous system. So the tests that a company has to sort of pass to be able to use a compound are ones that we wouldn't think of as mechanistically relevant in terms of the diseases we're thinking about. So that's another limitation that we face in addition to all the other things people have
So
mentioned.
we may say that at least for this topic, European Union is better than
Way
United
better,
States.
yeah, absolutely.
Also
yeah.
politically, we are not
Yeah.
always in agreement for this regulation.
Yeah.
We need to use the European guidelines, thanks
Exactly.
God.
Yeah.
That. Any other comments? Sure.
I guess just a general comment is that the people that we're studying in our cohort studies with incident dementia have had a different exposure to environmental risk factors. And so a lot of the newer environmental toxins might be affecting the children and adolescents now and their brain health in the future. So, you know, we've got these waves of changes of what we're using in terms of plastics and food additives and that, and we're always sort of behind in our research. So we're always looking at cohorts who've been had different exposures to the ones coming through. So I think that's another thing to bear in mind with some of these emerging risks.
Any last burning questions, topics to be raised? Well, you almost finished our time. I have just 1 minute to tell everybody that following this meeting here this week, we'll have next week a similar meeting. It's called Brain Health and Prevention of Cognitive Decline. It's an international meeting endorsed by the European Academy of Neurology, the Italian Neurological Society, which will be held here in Milan, in Milano Bicocca University. So if you want to follow again these topics, you can see the program on the website of the meeting is www.neuromeet2024.it. So you're welcome also if you're interested. Thank you everybody, to the speaker, wonderful talks, and for your discussion and your attendance. Thank you.
Good afternoon, everyone. So we're gonna start session 3 and food. So food is important, right? So there's a lot of food, Japanese food and Western food and Mediterranean food. Some food is very good and some food is, someone said bad, but that causes our health. So for example, 30 years ago, when I was a residency, multiple sclerosis, MS was virtually very, very rare in my country. And then I still remember my mentor said, MS is a disease seen primarily in Western countries, not in Japan. However, though, today we have more than 20,000 MS and then MNMO patients in Japan. I know still number is very low compared to the US, but it becomes very common in my country. 30 years ago, vascular dementia is very, leading cause of the dementia in Japan. But now, Alzheimer's disease has become the predominant form. So I know there's a lot of factors, air pollution, environmental factors affect the prevalence, but probably lifestyle changes significantly impact the prevalence of these diseases, including food, and then subsequently, microbiome, gut microbiome will be changed by the food. So this session, we have 3 distinguished speakers. The first speaker is Ilana Katz-Sand from Mount Sinai from New York. She's gonna talk about the food and the neurodegenerative diseases. So she probably primarily focus on the multiple sclerosis. And the second speaker, Elina Elan from Weizmann Institute of Science, and also he's a dual head, National German Cancer Center. So he talked about host microbiome interaction in health and disease. He has a lot of publication recently, so I have to cover his face. And then third speaker is Professor Gonzalo Torres. So his study is primarily dopamine transporter and then serotonin system in brain, but he recently developed his research into the Parkinson's disease and the microbiome. Probably he's gonna talk about this topic today. Thank you very much. So first speaker, please.
So first of all, thank you so much to Professor Comi and to the organizers for inviting me here to speak with you all today. I'm excited to talk to you about diet and neurodegeneration. I'm a neurologist focusing mostly on MS and diet, but I'm really excited to talk to you today more broadly about neurodegenerative disorders. So we'll start with just a little bit of background, and we touched on this in the discussion in terms of themes of underlying pathology of the different neurodegenerative disorders. We'll get into some of the mechanisms that I think relate diet to neurodegeneration and allow us to think of diet as a potential neuroprotective factor. We'll get into very briefly some of the ecological evidence for this connection between diet and neurodegeneration and kind of how this field got started. And then we'll delve into some of the dietary patterns of interest, and we'll apply those through epidemiological, observational, and as of late, some interventional studies. I did want to start out by noting that this is a huge, huge topic. And there are several very important areas that we're really not going to go over today. So we won't go into an exhaustive discussion about individual dietary components. Instead, we're going to focus on patterns since people eat whole diets. We are not going to review the very extensive and really wonderful animal model literature that has gotten us up to these human studies. Instead, today we're going to focus on the work done in humans. And diet as symptomatic therapy for neurodegenerative diseases. We've made a lot more progress in terms of thinking about symptomatic therapies than we have in the disease modifying area, but we're going to focus today on diet as a disease modifier. And then malnutrition in advanced disorders. This is also a very important topic, but no time to cover that today, but I'd be really happy to discuss any of these with any of you offline afterwards. Okay. So in the last discussion, we talked about the fact that there are certain themes that unite these disorders. We are, of course, still learning about the specifics of the pathologies in terms of the differences between these disorders, but I think there are a few themes that we can think about and come back to as we go through our discussion on diet. So the themes that we'll talk about today in terms of mechanisms are thinking about chronic neuroinflammation, oxidative stress, and then mitochondrial dysfunction is a huge one, right? So we know that these are things that we see in all of the disorders that we study. Mitochondrial dysfunction over time leads to chronic energy failure and cell death. And so I think we can think about, as we go through mechanisms of diet and then looking into clinical studies, how can diet impact these different mechanisms? So I think we can kind of put the effects of diet into two main buckets. One is the indirect effects that are mediated by comorbidities that we know to be associated with worse outcomes. So for example, obesity, diabetes, hypertension, having an adverse cholesterol profile. We know that all of these are serious risk factors for all of the neurodegenerative disorders we've been talking about, and that these are also associated with worse prognoses in people who are diagnosed with these disorders. So that's, of course, diet is related to all of those factors, and I think can and should be used to prevent and manage comorbidities. But I think potentially even more interesting are the effects that are directly related to diet, and that encompasses both the direct effects of dietary metabolites as well as effects that are mediated through the gut microbiota in terms of effects on microbial composition and then induction of metabolite production by gut microbiota. So breaking this down a little bit further, I would argue that we should think of our foods the same way that we think of pharmaceuticals, and this is what we should be thinking of when we think about the foods that we eat. Foods have distinct components and have these molecular structures that enable the foods that we ingest and all of their metabolites to bind to receptors, the same way that we should think about the drugs that we take and have our patients take. We should be thinking about our foods in this way. Diet also has a huge influence on the composition of the gut microbiota, as well as the metabolites that the microbiota produce in response to food intake. And when you put these things together, this is where we end up. So both the foods and the microbiota are going to have a heavy influence locally in terms of what's happening in the gut, right? So the immune cells that grow up in the gut are going to go out into the body and have diverse effects. In addition, these metabolites come out of the gut, right? And they diffuse through the body. Things like short-chain fatty acids are able to act as HDAC inhibitors, bind to G-protein coupled receptors. Tryptophan metabolites we know can cross the blood-brain barrier and have really important effects in the brain. And so this is, I think, a nice way for us to think about how our foods can have these distant impacts in the brain. So I just wanted to briefly think about how this field started. So we just heard about how populations change and dietary habits change, and this, of course, leads to changes in the prevalence of these disorders. And so some of the earliest work you can see here, if you haven't read Dr. Swank's primary papers back from the 1950s, I would encourage you to pull them and take a look. It's very interesting, and there are all these really nice hand-drawn figures. And of course, we do things differently now, and we do research differently now. But I think the ideas are really important. So we can do these studies, ecological studies that help us in terms of, I think, generating ideas and thinking about populations when we have a subset of a population that migrates to a different area that has different dietary habits, and we can look to see if the prevalence of certain disorders are the same or different compared to the original population. And then, of course, we can do the same thing when it comes to a population where dietary habits change, and that's exactly what Dr. Swank was advocating, mostly in response to industrialization and big changes in dietary habits in terms of animal product consumption. Okay, so we'll spend the rest of our time looking at a few different patterns of interest. So there are a lot of dietary patterns that are under investigation in both the prevention and treatment of neurodegenerative disorders. The list is actually much longer than this. We're going to focus in on just a few of these today. So first, we'll take a look at ketogenic diet. So in terms of mechanism, the idea behind ketogenic diet is that we can shift metabolism and use fatty acids as the primary energy source instead of using glucose. And so here I just briefly wanted to touch on proposed mechanisms for neuroprotection. So we can see here ketogenesis and hepatic mitochondria and astrocytic mitochondria. We can see here medium chain triglycerides crossing the blood-brain barrier. And where this ends us is better, more efficient ATP production is the idea, as well as an increase in mitochondrial biogenesis. And of course, both of those things can be really helpful in terms of neuroprotection. This is just a list from a recent review. And of course, the point is not to show you the individual details of all of these studies, but just to say that people are studying ketogenic diets. Most of the work that's been done, you can see the duration of these studies for the most part is pretty short, and the studies are pretty small. So we haven't yet had a lot of work in this area, and most of it's been done in terms of symptomatic therapy, since that's all you can study in a study of such short duration or with such a small n. But I think the mechanism is interesting, and it's definitely something that is being further studied. A related topic is calorie restriction. And related to that, of course, intermittent fasting or time-restricted feeding. The idea here is that you can induce metabolic switching, being that instead of just having a diet that puts you in ketosis all the time by having this ketogenic diet, the idea here is to switch between fuel sources. But basically at times of fasting, when glycogen stores are depleted, and this can happen with fasting, it also can happen with exercise, we see that you'll see a lot of similarities in the pathways here. Actually, it's the same stuff here. And what we end up with is reduced oxidative stress, enhanced bioenergetics, mitochondrial biogenesis. So all of the things related to the themes we talked about at the beginning here. In addition to these patterns also having, I didn't talk too much about decreasing chronic neuroinflammation, reducing oxidative stress, but basically this is where they all come together at the end here, is improving mitochondrial biogenesis. So this was a recent paper that I thought was worth bringing up because you can see just in the title, the idea here was that we can learn from studying one neurodegenerative disease, we can think about preventing another. And so this was a very small study, but just 10 people who were diagnosed with a relapsing form of MS were randomized either to follow or not follow intermittent caloric restriction, intermittent fasting using a 5-2 pattern. And after 12 weeks, what they noted was that there were regional improvements in brain volumes and cortical thickness, but they decided that this was actually informative not only for the MS population that they were studying, but also in the prevention of AD, because the regions that were affected are regions that are traditionally more affected in AD than what we see in MS. And so they thought, this is interesting stuff that we could definitely extrapolate. They also noted reduced neuroinflammation, which they were able to calculate by looking at cellularity. So this is a piece that was, I don't know if people saw this, that was run in the New York Times a few months ago and has actually been rerun a few times since then. But so we all know that eating less can help you live longer, right? There's been lots and lots of studies in aging, ecological studies looking at populations that have high numbers of centenarians, for example. We know that restricting calories over time helps, and that intermittent fasting is one way that you can do that. The reason I put this here and the reason I thought this piece was so interesting was actually looking through the comments sections and seeing what people had to say about it. So there were some people who were excited that this was, that this is out there and it's something that they do, but there were actually far more comments saying this is crazy and you're gonna be miserable your whole life and who knows if it's ever gonna do anything for you. And I think that that's actually an important point when we think about further studying the ketogenic diets and further studying these, especially chronic caloric restriction, is these are really hard things for people to do. And if they're hard for us to do in research, even for a short period of time, I think it's hard to expect that this is going to be something that we can implement on a population level as a preventive strategy. So I think that's something that's really important to keep in mind as we think about really what we can learn from those studies. I think we can learn a lot from them from a mechanistic standpoint, but in terms of like widespread applicability in a clinical setting or preventive setting, I think it's going to be a hard sell. So now I'll tell you why our group has chosen to focus our efforts, and I think a lot of others have done this, of course, in other fields, on Mediterranean-style patterns. So obviously, general health benefits are very well established at this point. There have been a number of trials over the years in terms of prevention of cardiometabolic comorbidities that we had talked about and cardiovascular cerebrovascular disease. These patterns combine the limited available information that we do have about particular dietary components that seem to be really important. So we're here in Italy, beloved olive oil, which in our work is seems to be one of the biggest drivers of the links between Mediterranean diet and decrease in MS-related disability. And we can see here the different pathways that are affected by olive oil as an example, but of course there are a lot of other components to the Mediterranean pattern, and it seems to be the whole thing rather than one thing in isolation. The other nice thing about this pattern is that there are indices, which we'll talk about in a moment, that can be used for observational studies, unlike some of the patterns that we just talked about. And then I think the biggest reason I really like this pattern is I think it's very reasonable to aim for long-term adherence. I think it is possible with education and resources being implemented to help people that we can make this into something that's more of a lifestyle change and not, a quote diet. I think a diet is something people think of as something that they do for a short period of time and then they go back to their old habits. But if we can actually help people understand that they need to have a different relationship with food and kind of see things differently, and we provide them the resources to do that, and I'll get into that kind of toward the end, I think it's possible, and we've done this in our clinic. This is a very budget-friendly pattern. There are many ways to do this. It doesn't all have to be really expensive foods. And this is something that the entire household can do. It's something that's healthy for everybody. And as a mother of 4 children, I think I have the credibility to be able to say that there are choices for everyone to eat and that everyone can enjoy. So MIND is a particular pattern. It's a particular subset. It's a Mediterranean DASH intervention for neurodegenerative delay. It was developed by our colleagues at Rush. And the idea here is, the thing that makes this slightly different from some of the other Mediterranean diet scales is that there are particular pullouts for things like green leafy vegetables. You'll see there has its own line in addition to other vegetables. And then the fruit line here is not all fruits, but is actually berries. And reasoning behind that you can see in the panel here. For example, there are thoughts that polyphenols, particular flavonoids, have neuroprotective properties. And so here you can see you end up with a score of 0 to 15, and this is something that can be applied through use of a food frequency questionnaire to any data set. Okay, so getting into some of the disorders we've been talking about today, Mediterranean patterns are associated with reduced risk of cognitive decline in AD. This is something we've known for quite some time. It was actually a little bit nostalgic for me to pull this paper here from Annals from 2006, published by Dr. Skarmeas, because I was finishing up medical school at the time, and I remember this at Columbia under Dr. Skarmeas, Dr. Mayu, and so I remember when this paper was first published, and so that was kind of funny for me to pull it out for this talk. But basically what you can see here is that when people are divided into tertiles, meaning those with who are in the highest tertile have a diet that is more aligned with the Mediterranean pattern than those in the lowest tertile of scores, a hazard ratio of 0.6. So that's pretty strong, right? And that was using their YCAP cohort in Washington Heights of over 2,000 community participants who were not demented when they started and were prospectively followed over about 4 years in that study. And of course, there's now been long-term follow-up out of that cohort as well. And then in the other panel here, we can see MIND specifically, that this pattern, you can see this is a very similar structure. And again, using tertiles, highest tertile hazard ratio of 0.47. So again, a pretty strong effect. Imaging studies really support the protective effect of this Mediterranean pattern in older adults. So this is a study from the same group as that initial one that I had showed you, where a subset of that YCAP cohort agreed to undergo imaging over time. And here you can see main finding that I wanted to point out is that those who had a diet that is in the highest tertile had very significantly increased brain volumes compared to those who were in the lower tertiles. Okay, so what about interventions? I think interventions are tough. Because as we've been talking about today, well, there are many, many issues. First of all, it's not like taking a pharmaceutical where you can have the person bring in the pill bottle and you can see exactly what they did, right? People are people. We're talking about human behaviors. These trials are very difficult to design. They're difficult to conduct. But also, I think a big part of the issue is we're talking about what is happening to people in a relatively short period of time, right? As we've been talking about today, exposures in midlife matter. And so I think it's hard to take a population of, for example, older adults and expect then in a short clinical trial, right? Usually our clinical trials are 2 years, 3 years, and expect that over that period of time, we're going to be able to show something that's really significant. But we try. I'm sure people are familiar with results of the Predimed trial. Predimed Navarro was a subset from one site, but over 500 participants at that site. And what they were able to show was that people who were randomized to the groups were that they followed a Mediterranean diet, either plus nuts or plus extra virgin olive oil, fared better in terms of cognitive scoring compared to controls at the end of the study. This was after 6 years of follow-up. Unfortunately, they hadn't included these cognitive assessments at baseline because it wasn't an initial planned part of the study, so they were only able to look in cross-section at the end. But I think given that the randomization scheme all seemed to work, and it makes sense to me that, that this is significant. I think these results are important. People may be familiar with this trial that was published last year. I had been anxiously awaiting these results, and I think on first pass, a little bit disappointing because this was an interventional study of a MIND diet for prevention of cognitive decline in older people. To get into the study, people had to have a BMI of at least 25 and be eating a diet that was classified as, quote, suboptimal based on a Mediterranean diet score, and they were followed for 3 years. What you can see here is that both groups improved. So I think part of the issue here is that the control diet was not people just continuing their usual diet. The participants were actually counseled on eating a healthier diet. They just weren't given specific guidance on MIND. And they were also encouraged to calorie restrict. And so both groups lost weight. Both groups improved their MIND diet score. The MIND intervention group improved more. But actually, in the research that our group has done, what we found is that you actually only really need to get your MIND score up a little bit to show a difference. And so the fact that there was no big difference between these two groups after 3 years is really not super surprising to me in that setting. Okay. In terms of PD, I see I'm running out of time. I'm going to go a little faster. In terms of PD, alignment of dietary habits with Mediterranean pattern protects from PD and delays onset. This gets into the discussion we had earlier in terms of protection and prevention, and are we really preventing the disease entirely? Are we just delaying it? I think if we're able to delay it to a point where a person is not experiencing symptoms in life, or where the symptoms are so far delayed that we've gotten that person into a very old age instead of experiencing these symptoms earlier in life, I think that's very valuable. And so here we can see Dr. Ascario's group in terms of likelihood of having prodromal features of PD, very reduced in people whose diets highly align with Mediterranean pattern, and similar findings in terms of MIND. In particular, in this study, the investigators showed a 17-year delay in onset of symptoms in women who were following a MIND diet. They showed different results in men, and it was more like 8 years, and Mediterranean seemed a better fit. But I think those are really important numbers. Similarly, we see reduced disease progression in people with Parkinsonism, and this is a study that looked over 5 years of observation. Professor Alfredson's group published last year on the inverse association between Mediterranean diet and risk of MS, and we can see here that the odds ratio for people who were in the highest group in terms of having a Mediterranean versus classified as Mediterranean versus a Western style diet, 0.54. Again, very impressive numbers. What about in people who have established MS? So this is work that we published last year looking at Mediterranean diet alignment in our MS cohort. This is a cohort of over 500 patients with all MS phenotypes. And what we see here is that those who have higher Mediterranean diet scores had lower MS-related disability as assessed by the multiple sclerosis functional composite. And the nice thing about our cohort is that we do this very deep phenotyping because these are our patients. We are able to collect a lot of health-related information on them, including a very comprehensive socioeconomic status index that looks at neighborhood deprivation as well as personal and parental education levels. And so we're really able to pull out a lot of the other factors and isolate the diet. And we found diet to be actually the most important health-related predictor in the model. Same thing goes for cognition in MS. The findings were very similar, actually stronger for cognition. Something that I think is really important in terms of thinking about mechanisms and neurodegeneration is the fact that we saw much stronger relationships in our patients who were classified as having progressive versus relapsing disease. And what you can see here is that when we get out to third and fourth quartile of diet, you can see that the gap between the patients who are classified as relapsing versus the gap versus those who are classified as progressive gets much smaller. So clearly, there seems to be a benefit here in terms of protecting people from disability. We had also previously published work on imaging supporting these hypotheses. So this was from a cohort of ours, about 185 patients with very early MS within, on average, about 2 years from diagnosis. And what we found here was a clear link between their mind diet score and thalamic volume, which is the earliest area of the brain to atrophy in people with MS. So we thought that was very interesting, and that was in people who were in their 30s. In our clinic cohort, this is now over 800 patients. We recently looked at third ventricle width and found, again, a very nice relationship and a much stronger relationship in those with progressive disease as compared to relapsing, again, suggesting a neurodegenerative benefit and mechanism there. And then just lastly, we previously ran a pilot study of a modified Mediterranean dietary intervention in women with MS, in just 36 women. And even though the sample size was very small, we found that in our intervention group after 6 months, we recently reran our blood samples and found a decreased neurofilament light chain after the intervention, only in those in the intervention group and not seen in the controls. So I think the hardest part of all of this is probably implementation. We definitely have a lot more research to do in terms of learning and clinical trials and things like that. But in terms of implementation, clinical practice, how do we integrate all of this into what we do for people who are already diagnosed with a neurodegenerative disease? How do we best motivate people? What resources do we need to help people make these changes? Who delivers the care in the United States? Who pays for the care? I think in other countries that's more clear. We are very fortunate at our institution. I co-direct a patient wellness program that we developed about 5 years ago, where patients who come through our program see our dietitian, they see our PT, they get exercise recommendations, they see our social worker who assesses their social and emotional health. We have behavioral health counseling available through one of our neuropsychologists. And we have a roundtable every week that I join, and we get to kind of discuss a multidisciplinary, really comprehensive and holistic approach to patient care. But this is something that I had to fight very hard to get, and I'm constantly working on new avenues for supporting this and trying to make it financially sustainable. So it's not easy to do. I'd be happy to talk to anyone who's interested in developing something similar at their institution. But I think the bigger issue here is prevention and public health campaign, all the things we've been talking about today. Education, we need to take on the big food industry in the US. We talked earlier about the lobbies and how challenging it is even just for regulations, forget about actual promotion of health, and then improving access to healthy food and food security, I think all really important. So just to conclude, I think the underlying pathology of these diseases are diverse, but there are shared features, particularly relating to chronic neuroinflammation and mitochondrial dysfunction that can be influenced by diet. Diet both contributes to reduction of cardiometabolic comorbidities as well as a more direct relationship through gut microbiota and direct impact of those dietary metabolites. I hope we've established here that dietary habits are linked to the development of neurodegenerative disorders and can play a role in shaping the prognosis of people who are diagnosed with them already. So we need continued research, particularly more interventional studies, including long-term ones that don't fit neatly into conventional funding mechanisms. And then we need to work on incorporating dietary counseling into clinical practice and beyond. I work with a lot of really wonderful people in New York and everywhere on this diet work. And I always end my talk with a picture of who I have supporting me at home and really the future. So thank you so much for your attention.
Thank you, Dr. Katsu-san. Okay, so next speaker is Professor Elena Breno.
Good afternoon, and I'm very happy to be here. Thank you for inviting me. In the next 20 minutes or so, I'll be speaking to you about the microbiome. Now, my groups and myself, both at the Weizmann Institute of Science in Israel and at the German Cancer Research Center in Heidelberg, Germany, have been studying the microbiome since the establishment of the field over a decade and a half ago. And this constitutes a huge, diverse, and poorly understood microbial ecosystem that resides within each of our bodies from the moment we are born until the moment we die. And in this last decade and a half, I think the field has increasingly been able to prove that the microbiome may impact every physiological process in our body and also many multifactorial disease processes. Now, they say that one picture is worth 1,000 words, so I chose to show you a scanning electron microscopy picture taken from the healthy gut, the healthy terminal ileum. You can see these bumps, these hills that represent the lining epithelial layer covering our healthy gut, and above them you can see what looks like a carpet of shoelaces. This is your microbiome. And you can already appreciate how extensive it is, trillions of microbes, thousands of different families, and how intimately it is associated with the underlying human cellular milieu. Now, if you've been reading literature related to this field, I think it's very easy to appreciate that the microbiome has been associated or linked to almost any multifactorial disease out there, including diseases close to your heart in the central nervous system. Now, in speaking about these potential causative roles of the microbiome in influencing neurodegenerative disease, I think we need to shortly highlight three hallmark concepts that we and others have discovered in these 15 years of research. The first is that people feature a very unique microbiome. If I were to sequence each and every one of you here in this room deeply enough, we will all have a unique microbiome fingerprint, which was very scary at the beginning because as scientists and physicians, we like to reduce our numbers to common denominators, but we've learned to harness this individual variability to explain in complex situations how different people featuring identical risk factors for a given disease may develop different symptoms and complications based on their unique microbiome fingerprints. The second hallmark concept relates to the view of the microbiome as a signaling hub that integrates into it many signals that come from the human body. The human genome impacts the microbiome, the human immune system impacts the microbiome, but also a large variety of factors that constitute the lifestyle that surrounds us, diet, hygiene, and so on and so forth. The microbiome receives all of these signals, integrates them, and communicates them to the host. And we see one of our missions in life to decode the alphabet of the language by which we and our microbes communicate during health and what goes wrong in this communication network that may lead to a risk of development of disease. And the third hallmark concept, which was only discovered a few years ago, was that the microbiome, in addition to its local impact, for example, in the gut, can also impact remote cells and organs in the human body through the secretion of thousands of bioactive small molecules, which we call metabolites, which in contrast to the microbes can swim out of where the microbes live, for example, the gut, and they can reach any cell and organ in the body. And this can start to explain to you how a microbiome that resides in the gut, for example, can impact processes that take care in the central nervous system. Now, using all of these concepts, what we try to do is to contribute towards a better mechanistic understanding of host microbiome interactions in a variety of physiological and pathophysiological contexts, towards what we hope would be new principles that may lead to the identification and development of new precision microbiome-mediated disease treatments. How do we do this? We use a variety of tools. For example, very advanced omics tools to characterize these very complex ecosystems using shotgun metagenomic sequencing for their genome, mass spec to characterize these thousands of new chemistry moieties that are interesting within our bodies, and lately even culturing many of these previously unculturable bugs. And in addition, we try to develop methods to counteract maybe the biggest challenge of this maturing field, which is the transition from correlation and association into proof of causation and molecular mechanism. For example, by the use of germ-free mice. These are sterile mice that we house in these expensive and isolated containers, and these mice don't have any microbiome on their own, so we can see what happens in the absence of a microbiome or transfer into them configurations from humans featuring different diseases, and we can model the human disease in the mouse setting. Now, in speaking about microbiome-associated treatment, I think it's also fair to say that in 2024, we're still, you're still going to be running into many, I would say very gently, not sufficiently evidence-based microbiome-associated treatments, such as prebiotics, these fiber-based nutritional recommendations, fecal microbiome transplantation, which is the transfer of a healthy person's microbiome into a sick person's microbiome, which has been exceedingly proven to be successful in several hospital-acquired infections, but is much more complex, I would say gently, when we deal with more complex diseases, and probiotics, which is an explosive matter, and I will not go into it, so just not to get too emotional about it. But the encouraging thing is that with the explosive microbiome research that is expanding globally, we are slowly able to contribute towards new data-driven, science-based, reproducible microbiome exploitations of the huge person-specific data that is stored within it towards new treatments. And of the many different things that we have developed and are engaged with, in the next few minutes, I'll give you one example from neurodegenerative disease, which relates to the identification and utilization of these small molecules that are secreted by the microbiome, which may be developed into new forms of treatment. So the neurodegenerative disease that we dared first to start and study, being non-neurologists, is ALS, amyotrophic lateral sclerosis, which you probably know much better than me, is a devastating neurodegenerative disease impacting people of all ages. And the reason we've chose this disease and not any of the other common diseases, which I'll briefly mention at the end, is that it's a little bit simpler. We like, with this complexity of the microbiome, to start simple as much as possible. And also, if you read into all the epidemiological ALS data that is out there, you would find that in addition to probable genetic predispositions, there is a huge lifestyle or environmental modulation of this disease. So some people would develop a very rapid disease and die within a year. In average, people all die within 5 years, but some people, such as Stephen Hawking, would live for decades. And we always, when we see this variability in a given disease, we kind of blame the environment. And when we think about the environment, the microbiome could be a contributing hub. So we started in mice, and we started with mice that feature a mutation in a protein called SOD1, which is the most common familial ALS type of disease. And these mice spontaneously develop motor neuron disease until they die. Now, if you were to look at the blue graph, and here I'm just exemplifying two modes of measurement of motor strength, of motor capacity in these mice. The higher the score, the stronger the mice. The lower the score, the sicker the mice. And you can see in these blue graphs that in both readouts that these genetically predisposed ALS mice gradually develop motor neuron disease. They become weaker until they die. Now, in this experiment, we did something very simple. We took the same exact mice and we treated them with broad-spectrum antibiotics that depleted their gut microbiome. So we're talking about an identical mouse with the same genetic predisposition, just depleted of their microbiome. This is the red group. And you can see that these mice develop a much more severe disease as compared to the non-microbiome depleted mice, which told us that maybe something in the microbiome is modulating in the mouse setting disease severity and disease progress. We did the same with germ-free mice. The results were exactly the same. And then we did what we do for a living, which is dive deep into the microbiome, using all of these multi-omic technologies, characterize the microbiome and its changes along disease course. And to make a very long story short, we developed, or we discovered in our facility 11 different commensal species that were interestingly changing in their capacities and composition along disease course. So these were our suspects. And then what we did, we fished them one by one, and we tested them for their disease-modifying activity. Now, 10 of the 11 microbes seem to be making disease more severe. The 11th only species that we found in our vivarium seemed to be associated with a milder disease course. It was deficient in very sick mice. So this was obviously the most interesting species for us. The bug was called Akkermansia mucinifila. It's a very metabolically active commensal. And since we pride ourselves on trying to progress the field from correlation to causation, what we did is we took these mice that are deficient in this hopefully beneficial bug, and we supplemented the bug back into their gut, back into wild type levels to see what it does to disease course. So in this example of one of many experiments, you can see now in red the regular ALS-prone mice. You can see again how using both of the readouts that I'm exemplifying here, these mice gradually and spontaneously develop motor neuron disease, become weak and recurrent until they die. Now you supplement Akkermansia back into these mice. These are the black groups, and now you can see the disease is attenuated. It's not that you cure disease, but you very significantly attenuate the symptoms and the rate of mortality in these mice, meaning that something in Akkermansia is modifying disease in these mice in our vivarium towards a milder disease. So in order to dive even deeper into potential mechanisms, we now took a very deep dive into which are the metabolites, these small molecules that the Akkermansia strain in our vivarium could secrete that potentially could explain why these mice develop an attenuated disease, with the rationale again that in contrast to the bug itself that only lives in the gut, the molecules that it secretes can swim in influx into the sterile body of the mouse, where they can reach through the BBB into the central nervous system, where they can impact disease course. To make a very painful story short, we identified 27 such differentially abundant molecules. We tested them one by one, and one of the molecules called nicotinamide seemed to be the most interesting in attenuated disease course in these mice. And again, we did what we're very simple people. We took this molecule that was deficient in regular colonized SOD1 transgenic mice. We supplemented now the molecule, not the bug, back into physiological wild-type levels, and we wanted to see what happens when the molecule is no longer deficient together with the bug that is making it. Now you can see, again in red, these control ALS-prone mice developing this progressive motor neuron disease, and in green, you can see the same mice after supplementation of nicotinamide back into physiological level, corroborating the phenotype that you've seen before with the bug that makes this molecule and generating a milder disease course. And of course, we went and tried to explain how this molecule impacts the central nervous system, which is unfortunately too long for and too boring for this 20-minute talk. We finished by looking into humans to scrape the surface and see whether some of the concepts that we've discovered here may potentially hold true in humans. We've assembled a cohort of ALS patients and users control their family members, their healthy family members, which is a drill that we often like to do in microbiomes human research, because household family members share many of the lifestyle factors that the diseased individuals also share, such as diet and so on and so forth. And we're looking for the differentiators among this very uniform population. And when we looked into the systemic metabolomic profile in their peripheral blood, we found many tens of small molecules that were differentially abundant between patients and control. Interestingly, nicotinamide, the molecule for mice, was one of the most notable ones. It was missing and deficient in ALS patients as compared to control, both in their systemic blood and in a subset of these patients, we were able to sample their CSF and to prove that nicotinamide was also reduced in its abundance in the CSF of patients versus control. And now there are a number of clinical trials undergoing around the world trying to see whether supplementation of this molecule or several of the other molecules, which I'm not mentioning, may alleviate some of the symptoms of this deadly and cureless disease. Just to show you that we didn't stop there, we wanted to learn more and to generalize our findings from this familial ALS model into more sporadic forms of ALS. So in this case, we collaborated with the New Gain lab at the University of Calgary and used a different mouse model of a different form of, this time sporadic ALS, driven by a mutation in the protein TDP-43. This is a molecule that may lead to motor neuron disease and also frontomedial dementia. I hope I'm saying it correctly. And indeed, these mice develop a 30% reduction in their motor neurons and symptoms that go along with it. Interestingly, in our hands, what we found was that this model is characterized by a very marked genetic dimorphism. So males in blue developed a much more severe disease as compared to females, which is also something that you see with human ALS. You can see that they die earlier. On the right, you can see that their latency to fall, representing again their motor neuron capacity, is reduced in males at an earlier time point as compared to females. Even more interesting was that when we castrated the males, trying to kind of reason that maybe the hormones of the males were responsible, we didn't see any difference. So it was something about males versus females, but not directly related to the sex hormones in these males. So we asked ourselves, being microbiome researchers, maybe this is the microbiome, given the fact that there is plenty of literature recently suggesting that males and females, if you go deeply and comprehensively enough, feature very marked differences in their microbiome. So we did the same drill. We re-derived the TDP43 transgenic mice into the germ-free setting. Now we had the same genetic mouse, the same predisposition by this mutated gene, but without any microbiome in these mice. And what we saw, quite to our amazement, was that in contrast to colonized mice that seem to have this genetic-driven sexual dimorphism, you can see again in blue, in light blue, the males that developed disease severity more or quicker than the females in pink. But once you deplete them of the microbiome, you do this in the germ-free setting, these mice die much faster, and now you lose this male-female difference. So something in the microbiome also in this model does something that to us was fascinating. To make sure that this is not a germ-free thing, because germ-free mice don't have microbiome from their development, so they're screwed in many different immune aspects. We repeated these experiments with the administration of wide-spectrum antibiotics in a more real-life setting. Again, in contrast to colonized mice, mice that were treated with antibiotic and depleted for the microbiome developed a much more severe disease and a complete loss of this sexual dimorphism. And this was not just manifesting as mortality. A panel and a battery of motor neuron tests were performed in them. Here you see an example. And again, the depletion of the microbiome resulted in a much more severe deterioration of the motor neuron function in these mice, both in males and in females. Obviously, as you may guess, we sequenced the hell out of these mice, both to try and figure out differences between microbes in genetically predisposed ALS mice to their littermate wild-type controls, but also in this case between males and females, because we saw this difference, and this could lead us to more subtle differences that may be even more interesting. So just to show you, this is an ongoing work, just to show you some of our most recent results comparing males and females with TDP43 mutation. You can see a short list of different species of commensals appearing in these mice, and one of them is the same Akkermansia that we've talked about in this other SOD model. And again, this Akkermansia was depleted, at least to some extent, in the females that feature a milder disease, which begs the question whether similar mechanisms could explain the differences in this model. I don't know. As I said, there are multiple metabolites that are secreted by this commensal that could be interesting and important, and we're trying to figure it out. So just to summarize this example, I think that with the maturing and more mechanistic microbiome work that is emerging from our now decade-and-a-half-old field, we are increasingly able to reach at molecular mechanisms, which to me is the most important thing. And this eventually leads to identification of new therapeutic targets and the exploitation of the huge data that is stored within the microbiome with its inherent variability towards new treatments of diseases such as the diseases you're interested in. I've just given you an example of one mode of treatment that we're studying, but we're studying personalized nutrition and precision probiotics and many other exciting experimental platforms that are developed to intervene in the microbiome towards such a preventive or therapeutic application. And you can copy-paste the same thought process and the same conceptual design and do the same in more complex neurodegenerative disease. We are starting to slowly and carefully dive into these other more common ones, which, as you know, are very complex, and we're very apprehensive of biases that are easily encountered in doing microbiome work in Alzheimer and Parkinson. But we hope to contribute towards new discovery in the next few years. I'll finish by thanking the many amazing students and postdocs that have been joining me in this journey in the Weizmann Institute of Science in Israel for the past 15 years, coming from all over the world. All of our collaborators from around the world, without whom we wouldn't be able to do anything, and the funding agencies that are making all of this work possible. And for the past 5 years, I've also been lucky to establish a microbiome and cancer division at the DKFZ in Heidelberg, an amazing group of people there as well. And what we do there is try to apply the many new technologies that we've developed at the Weizmann in studying how the microbiome may impact cancer development, progression, and response to treatment. And I'll thank them as well, and I think I'll stop here. Thanks.
Thank you, Professor Elena. A very interesting story. So last speaker is Gonzalo Torres from La Royale University.
Good afternoon. I also would like to thank the Prada Foundation, Professor Comi, and the organizing committee for inviting me to give this talk about this very exciting topic, microbiome and Parkinson's disease. Both topics were already introduced, so my talk is going to be a lot easier. Oops. So Parkinson's disease, we heard already. It's sorry. The second most prevalent neurodegenerative disorder, 6 million people worldwide, affects 1% of individuals over 65 years of age. We heard this morning, is the fastest growing neurodegenerative disorder, and it's been considered traditionally as a brain disorder because of the motor symptoms, bradykinesia, tremors, and rigidity, which these symptoms worsen as the disease progresses. The motor symptoms are characterized by these two pathological hallmarks in PD, which is the loss of dopamine neurons in the substantia nigra in the brain, and also and also that are parallel with the formation of these intracellular inclusions called Lewy bodies, which are protein aggregates, many proteins, particularly one alpha-synuclein that is expressed in these motor areas. So the loss of dopamine explains the motor symptoms, and my lab for many years has been studying dopamine and how the brain deals with dopamine regulation. And until recently, when we realized that to understand brain dopamine and diseases that are affected by brain dopamine, including Parkinson's disease, we had to look outside the brain. And one of the areas that is really interesting is the gut microbiota. And this is because not all the symptoms that you see in Parkinson's disease can be explained by the loss of dopamine. There are many non-motor symptoms associated with PD, lack of a sense of smell, sleep problems, and particularly GI problems, especially constipation that occur sometimes decades before you see the motor symptoms associated with PD. In fact, individuals that present constipation, they have a higher risk to develop PD later on in their lifetime. So this basically this observation led to this idea that perhaps neurodegenerative disorders, including Parkinson's disease, might have, I don't want to say an origin, but an influence outside the brain. GI disorders like constipation and gut dysbiosis occur before the onset of motor symptoms. Alpha-synuclein, this protein that forms these protein aggregates, Lewy bodies in the brain, it's also found in the periphery. It's also found in the gut of people with Parkinson's disease. And preclinical studies have shown that the alpha-synuclein aggregates can travel to the brain from the gut. And dysbiosis of gut microbiota and microbial metabolites in Parkinson patients have been observed, including loss of bacteria that are associated with anti-inflammatory properties. So all this led to the current sort of a proposal that there might be sort of two models to explain neurodegenerative disorders or Parkinson's disease. The body first Parkinson's disease that would start perhaps in the periphery, in the gut, in this sort of a microbiota new community that we just learned about, and then travels to the brain to develop the motor symptoms. The more traditional and accepted model is that Parkinson's disease starts in the brain by the loss of dopamine neurons, and somehow this affects the periphery. And at least in preclinical models, there are evidence that supports both models. So again, we already talked about the gut microbiota, so I don't need to introduce, except to say that it's in a diverse and active community of microorganisms that include not only bacteria, but also viruses, yeast, and other microorganisms. The largest community resides in the gut with trillions of species. It has initially been assigned a role in terms of nutrient absorption, development of the immune function and metabolism. It's incredibly diverse in a dynamic community that is affected by age, environment, but it's a key determinant of human health and disease. It's been implicated in almost every physiological function in the body, and probably every disease condition is affected by the gut microbiota. So therefore, there is significant potential, not only for clinical diagnosis, but also for therapeutic intervention. So how does the gut and the brain communicate with each other? We heard before this talk, it's really complex, that there are three main pathways. One is a neural pathway through the vagus nerve, and also the enteric nervous system that is considered a second brain that covers the gut. Also, the immune system is another way by which the gut and the brain communicate to each other. And the last one is through metabolites, short-chain fatty acids, tryptophan metabolites that are produced by bacteria and then travel through the blood to reach organs and then produce biological effects. So in the case of PD, there is plenty of evidence that there is a connection between the gut microbiota and the disorder. I already mentioned some of these lines of evidence. Gut microbiota is altered in patients with PD that has been very consistent over the past few years, not only in clinical cases, but also in animal models of PD. These disturbances occur way before the onset of the motor symptoms in PD. Alpha-synuclein, as I mentioned, is not only expressed in the brain, also in the gut, and you see the aggregates in the gut, and they have the ability to travel to the brain. Dysbiosis of gut microbiota and microbial metabolites in PD, including loss of bacteria associated with anti-inflammatory properties. And the more exciting sort of data, recent data, is still preliminary. The fecal microbiota transfers from healthy donors to patients with PD in some pilot sort of studies and clinical trials are really showing some promising results and improving the motor deficit that you see, and the non-motor symptoms as well that you see in patients. So I think that is going to be is a very exciting and interesting sort of a new avenue in terms of therapeutics for Parkinson's disease. So what is the mechanism? Because that's sort of my motivation. How that these microbes in the gut influence, and some people even think that control, brain function. So, and whether they are the cause of the effect in terms of this relationship between the gut and the brain, we decided to ask a very simple question, which is sort of what is the connection of the gut and the brain, and what is the role that the gut microbiota play in modulating the susceptibility of dopaminergic neurons and motor deficits in an animal model I don't want to say Parkinson's disease because it's not really Parkinson's disease, but it's dopamine loss. So in an animal model in which we degenerate dopamine neurons, and we can do that several ways, but one of them is pharmacologically with a toxin, what would be the effect of altering the microbiota? And the way that we are doing this experiment, basically, it's degenerating dopamine neurons with a toxin that is specific to dopamine neurons, 6-hydroxydopamine, and then we ask what happens when we alter the gut microbiota with antibiotics. Same experiments that were just presented a few minutes ago. So I'm just going to go briefly. We can selectively and locally kill dopamine neurons in the brain of a rodent, a rat. And what it does, it recapitulates some of the symptoms that you see, at least the motor deficits that you see in patients with Parkinson's disease. So this model has been used to look at basically neuroprotective therapies or strategies that prevent neuronal loss and dopamine loss. So we can look at motor deficits, we can look at the loss of dopamine neurons, and we can also look at neuroinflammation, which it recapitulates some of the phenotype in this animal model. So in this particular study, we have 4 groups: animals that receive only saline instead of 6-hydroxydopamine, or water instead of antibiotics. Then the second group receives antibiotics, and these are sort of antibiotics that stay in the gut. They don't go into the system, so we have local effect in terms of the effect on the gut microbiota. Then we have another group with only the effect of 6-hydroxydopamine to degenerate the dopamine neurons, and then the combination of 6-hydroxydopamine in animals that have received antibiotics. And this is the time course. We treat the animals for a couple of weeks before we induce the degeneration of dopamine neurons, and we can follow this for several weeks to look at motor deficits, to look at neuroinflammation, to look at dopamine loss. So there are no effects in water consumption with the effect of antibiotics or body weight. But there is a dramatic decrease in the content of bacteria in the gut as expected with this cocktail of antibiotics, as well as the diversity of the gut microbiota changes. And I'm going to get back to this because I'm sort of still learning in terms of what it means and all these different changes in the tons of species of bacteria that are represented here. So that's the effect of the antibiotics. And now we look at the motor deficit. This is one phenotype and one sort of approach that we use to look at, of many, to look at motor deficits is the cylinder test. We ask the rat to basically touch the cylinder, the wall of the cylinder, with 2 paws. In a normal situation, both paws are equally touch the cylinder, and this is in the water saline group, and antibiotics alone don't have any effect, as expected. When we inject the toxin and kill dopamine neurons, then we see a dramatic effect, and only in the number of touches by the contralateral paw of the animal. Again, as expected. What happens when we treat the animals with antibiotics? We see a neuroprotection. We see a protective effect. We were expecting actually the opposite, but we see a protective effect of antibiotics on the motor deficits associated with the effect of the 6-hydroxydopamine. It was very interesting. We were not expecting to see, but I think it was very exciting, and it gave us an opportunity to look at the potential mechanism. Dopamine cell loss can be quantified by either tyrosine hydroxylase staining, which is the enzyme that makes dopamine, or dopamine content by HPLC. This is tyrosine hydroxylase, and is decreased in 6-hydroxydopamine and can be reversed in the case of antibiotics. So the motor deficits or the protection with antibiotics can be explained by an increase in the expression of tyrosine hydroxylase and dopamine content. And in terms of neuroinflammation, in 6-hydroxydopamine produces a neuroinflammatory sort of a profile by increasing the expression of inflammatory markers, COX-2, IL-1B, TNF-alpha, which are then inhibited in the presence of antibiotics. So we think that altering the gut microbiota, decreasing the population and changing the diversity protects dopamine neurons from dying in this model of dopamine loss. Again, what is the mechanism? And we have several sort of possibilities here, and we are looking at some of these possibilities. I'm going to show you a couple. Sorry, I need to drink. Very dry. I'm going to give you a couple of examples. Potential mechanisms that may be sort of explaining these results. One, it's metabolites that are produced by bacteria. And we realized that there were some bacterial species that produce short-chain fatty acids that were downregulated in the antibiotic-treated group. So one of the possibilities is short-chain fatty acids. And the second one, it's bacteria that were overexpressed in the antibiotic-treated group. So I'm going to show you at the end some preliminary experiments suggesting that there are some species that might have a role in protecting dopamine neurons from degenerating. So I'm going to go through this data rather quick. This is a short-chain fatty acid that were given orally to the animals. We provided a mixture of butyric acid, propionate, and acetate. And as you can see here, the effect of antibiotics in the motor sort of approach were reversed by the addition of short-chain fatty acids. The increase in dopamine by TH expression that we see with antibiotics was also reversed when we gave short-chain fatty acids. And finally, the inflammatory markers that were sort of downregulated in the presence of antibiotics were also partially reversed by short-chain fatty acids. So given this cocktail of molecules, we basically were able to reverse the effect, that protective effect that we saw by the effect of antibiotics. And now we are looking at the mechanism by which short-chain fatty acid might be doing this. There are two possibilities. GPCR, there are a number of GPCRs that are activated by short-chain fatty acids, and then there is the histone modification. We're trying to test out which short-chain fatty acid is doing this, and our preliminary data suggests that there is a specific GPCR that might be involved in the actions of these short-chain fatty acids. The second example is basically bacteria that are sort of differentially expressed, and they might have a role in the effect of antibiotics in protecting dopamine neurons by looking at the changes in the composition of bacteria. We found a similar player compared to the previous talk, Akkermansia mucinifila, which is a bacteria that is involved in mucin regulation, intestine barrier protection, immune system development and maintenance, so pro-anti-inflammatory properties. So it seems to be a good microorganism. So again, we did the same experiment in which we provide this microorganism, and this is a different motor sort of approach. It's amphetamine-induced rotations. You can see that in 6-hydroxydopamine treated animals, which is unilateral, you see contralateral rotations, and this is abolished when animals are given this microorganism by oral gavage. The anti-inflammatory markers that were upregulated in the presence of the toxin 6-hydroxydopamine, they are now downregulated when you give the microorganism. And finally, in the presence of this microorganism, we see an increase in tyrosine hydroxylase expression, also in dopamine content, that explains sort of the phenotype that we see. So we think that we have a couple of leads, we have a couple of mechanisms, one metabolite, one species. Again, we also found 13 bacterial species that are differentially regulated, and we are testing them one by one. These are preliminary experiments because we need to repeat all these sort of results with different tasks in different models to make sure that what we see is consistent. In summary, antibiotic treatment attenuates the 6-hydroxydopamine-induced motor deficits, dopamine loss in the basal ganglia, in the search and expression of pro-inflammatory markers, COX-2, IL-1B, and TNF-alpha, and it acts in this case as a protective mechanism of dopamine loss. The short-chain fatty acid administration reverses many of the effects that we see with the antibiotic treatment, and the microorganism that we identified, Akkermansia administration, reversed the effect of 6-hydroxydopamine. So the take-home message is that there is still a complex interplay between the gut microbiota, the immune system, and in this case of Parkinson's disease, dopamine neuron vulnerability. The big question in the field is why these neurons degenerate, and we think that we have a sort of a new clue in terms of trying to understand potential mechanism from the gut to the brain. But it gives us an opportunity to identify novel therapeutics for Parkinson's disease. And with that, I'm just going to thank my lab, particularly Dimitri Koutsumis, who was responsible for most of this work, my collaborators and funding agencies. Thank you very much.
Thank you, Professor Torres. So please come to the speaker to here. So it's time for discussion. And Professor Katsan talk about the importance of Mediterranean diet on the several neurodegenerative disease. And then Professor Reynard talk about the depletion of the gut microbiota worsen the SOD1 transgenic mice, but Dr. Torres said depletion of the gut microbiota actually improved, right? So it's kind of opposite result. So I think there's a lot of questions.
Hi, that was an excellent session. Thank you. This is for Alana. I really appreciate the work you do, and I think you made a really good point about in our society nowadays, it's hard for people with all the temptation to maintain a healthy diet. Even a Mediterranean diet can be hard. So with the evidence being so clear related to the impact of weight loss and low calories, I'm wondering if you could comment on this recent phase about the Ozempics and the agonists to kind of prevent overeating, and whether you think pharmaceutical agents are important even for these neurodegenerative diseases.
Yeah, it's a really important question, and the short answer is that yes, I do. I have recommended them to some of my own patients who, I have many patients who have been overweight their entire lives and really have done a great job in terms of trying. But as we all know, what happens when you carry excess weight is your body is working against you, and it becomes very hard to lose. And especially for women who are perimenopausal or have gone through the menopause transition, it can be very, very challenging. And so I do think there is a role for these medications. And one of my colleagues at Johns Hopkins, Ellen Mowry, is particularly interested in the role of these GLP-1 directed medications like Ozempic, and we think that there's actually a potential role for neuroprotection in these agents that goes above and beyond their ability to help with weight loss. And so I think that is really, really interesting topic. They have some nice preliminary data in animal models from Peter Calabresi's lab, and I hope that the trial gets funded. It's out there, and I think it's going to happen. So I hope we'll be able to get some data. But yes, I do think it's important, and I think it actually addresses multiple pieces of the mechanisms here that we're interested in.
Any question?
Hello. Yes. So thank you for a wonderful session. Again, Sergio Baranzini, UCSF. I have a question for actually Gonzalo and Iran regarding Akkermansia. So Akkermansia notably we all say that there's hundreds or even thousands of species living in the human gut. Yet Akkermansia seems to grab the headlines more often than most. So it's probably a common microbe, and there's most reports will associate Akkermansia with a beneficial effect, although there's also others that go in the opposite direction. One of the interesting things about Akkermansia is that, of course, like the name suggests, so Akkermansia muciniphila, that species, like the name suggests, likes mucin. So it degrades mucin, which makes other components of the microbiome getting closer to the epithelial cells and perhaps even facilitate some low-grade microbial translocation, which might be a secondary effect of the presence of this bug. Do you have any insights on what the mechanism might be, because why Akkermansia is overrepresented in the literature, and whether this degradation of mucin could have anything to do with its purport action?
Yeah, it's a good question. You know, we didn't choose Akkermansia in a way. Akkermansia chose us, so you know it is what it is. But I think that one of the reasons that Akkermansia, I would say two possible reasons may explain this overrepresentation. One would be the fact that Akkermansia per se, of the many different commensals that we study unbiasedly, is a very metabolically active commensal. So it has quite amazing machinery to generate many metabolic pathways, which generate many different flavors of small molecules that are at least potentially bioactive. So in a way, it could do many things. From a technical standpoint, since many of these studies are being done in very well-controlled SPF facilities with very controlled configurations of microbiomes in these vivaria, in which Akkermansia is often there, it kind of gives it a competitive advantage under these experimental settings to do what it may be doing. So I'm more careful in saying that Akkermansia is, you know, the silver bullet bug that you know should be put in water, but rather it may teach us about concepts and conceptual capacities and functions of the microbiome. Now we increasingly are trying to diversify our toolbox by complementing these very well-controlled SPF experiments with, for example, wilding mice, which are mice featuring the same genetics, for example, C57 black mice, but they carry a wild mouse microbiome. We physically hunt mice in the wild, in the forest, and take their microbiome and basically FMT them into germ-free C57 black mice. And these sort of colonies are much more reproducible in corroborating human phenotypes as compared to these very clean SPF mice. So this is just one example of the expanding toolkit that enables us to study more commensals than Akkermansia. These wild microbiomes are much more diverse, and to bring it closer to the human setting. But Akkermansia teaches us incredibly important lessons on mechanisms. And by not focusing, at least in our lab, by not focusing on the commensal, but actually striving to identify the molecule, we kind of are able to bypass this huge inter-individual, interspecies variability. And once you have a molecule, you know, you're back to biochemistry and to classical microbiology, and your ability to reproduce is much greater.
I agree with that. And just to add to that answer, we found 13 species that were differentially regulated, and we started with this one sort of because we were a bit biased because of what has been reported in terms of the beneficial role of these bacteria, even in models of Parkinson's disease. So we wanted to sort of almost use it as a control, and it worked very well. But we have a number of different species that are acting even, you know, just like this one in our model. We're trying to understand how do you go from changing the bacterial composition to protecting dopamine neurons in the brain and using these bacteria as a tool to get there. What we're also doing is when we feed the animals with these microorganisms, we see what else changes. And a lot of things change. So whether or not this particular bacteria is a masterpiece or is one of many, we still don't know.
Any other? Oh, okay.
Margaret Fonestock from McMaster University in Canada. That was an excellent session, and I thank all of you for those really wonderful talks. I have a question for Dr. Torres, which is buying into the gut first theory of Parkinson's disease. What is the origin of the alpha-synuclein in the gut, and how does the microbiome contribute to its aggregation? Does it contribute to the aggregation and fibrillization of that alpha-synuclein?
Nervous system. This is what it has been. That is sort of it sort of aggregates in the gut, and perhaps also in epithelial cells. But its enteric nervous system seems to be the place where it has been shown, and I think it's sort of a matter of intense investigation. What is the role of the microbiota in terms of shaping or regulating aggregation of alpha-synuclein? So it's still sort of under investigation. But again, I think that I'm not favoring one over the other because there is evidence for both. You can see the alpha-synuclein in the brain, and it will show up in the gut. If you it will travel and it will go to the gut. If you put it in the gut, it will go to the brain. There is a bi-directional communication between the two systems.
I have a question both for Ilana first and then for Aaron. The question to Ilana, linking to the previous session on pollution. When you think of diets, there's of course also a lot of stuff that we get with the diet that is maybe not intended to be there, right? I'm talking about these PFAS that are everywhere now, but maybe also these highly processed foods, other stuff. Can you comment on that and how that might impact, also our disease risks? Completely different question to Aaron. I was actually intrigued by your observation of this sexual dimorphism in the gut microbiome composition, and can you comment on that? Where that might origin and what the consequences might be?
Sure. Thank you. It's an excellent question. Yes, there are a lot of things in our food supply that, in the water and the food supply that don't belong there. I do think that these are important. In our interventional studies that we've done, we have encouraged people to be careful and provided education in terms of food sources. It's easier when it comes to processed foods and educating people at how to avoid eating processed foods, right? Mostly talking about foods that are like ultra processed, right? So we're very happy for someone to buy a bag of frozen vegetables if that works well for them, but not so happy for them to buy other things that come in the freezer section, right? So that part of it is easier. I think the part that's harder is all of these forever chemicals and things like that are in the food supplies that even if you buy organic and you do all of the things that are on the list, it's still not a guarantee that those things are not in the food supply. We know that they are. And so I think the first thing that we need to do, and this is not routinely done in the US, is there should be testing of what's in the food supply, right? So there was recently an article in the paper about a family farm in Vermont. There was one in Vermont, one in Maine that was shut down. This is an organic farm. It's been organic farm for a long time because of tests that Organic Valley, which is a company in the United States, did on the dairy products that were coming from that farm. And this was done because, again, Sergio's point earlier about in the United States, some things are state regulated. So that's like the one state in the US that has mandatory testing, but lots of other places don't. And so they had no idea, by the way, this farm, because again, they've been an organic farm for a long time. However, forever chemicals are forever chemicals. And so before that farm was organic many, many years ago, and there was this widespread practice of spreading manure over the entire farm, well, guess what? That's all still there in the ground. And so when the cows are eating the grass that comes up, so, these things are everywhere. I do think we should do better in terms of measuring them. It's hard to do without infrastructure and support for those things. But I think at least in our studies, those are things that we should be looking at.
Before I answer your question, like a good politician, I'll add to her question, to the previous speaker. I think that pollution, for example, is a very intriguing potential influencer on multifactorial disease through different potential mechanisms, including the microbiome, at least theoretically. But it's very hard to quantify it, and this is why we try to avoid these very complex but important matters. But we did try to address it, at least to some extent, recently by collaborating with a Chinese partner in Guangzhou, China, and doing a very, I think, cute or cool study in which we directly compared a large population, because these are kind of Chinese numbers, so large numbers of people of the same ethnicity and actually the same village that migrated massively within the last 20 years into Guangzhou, which is now a huge city, and measuring them and measuring their many family members that remained in the rural environment. So you have two populations genetically identical, basically, and in many cases identical in other lifestyle measures, but different probably in their food consumption and in their exposure to pollution. And the differences between the two populations were unimaginable, including the fact, for example, that IBD, which was the focus of this study, was very prevalent in the urban population. And despite doing hundreds and hundreds of samplings, we were not able to find one IBD case in the village. Same people, basically. Whether it's pollution, whether it's only pollution, whether it's many other confounders, I don't know, but it just tells you that these factors, although soft in measurement, are probably much more important than we realize. With respect to males, females, it's a great question. To be honest, we have not explored this per se. Others have. We ran into this observation as we were doing these experiments, because we try to model both genders in each of our projects, and usually we don't see this marked difference. Here we did see this huge difference, which at least in the short term was not driven by testosterone, because castration didn't do it. But one thing to take into
female hormones.
Absolutely. So one thing, this does not exclude the hormonal theory, and with all due respect to many legends, the biggest difference is hormones between males and females. But one important microbiome feature, which we increasingly learn about, is that the microbiome may be regarded as a buffer for many environmental changes. So in other words, if we were to react to every little spike in every little lifestyle-related measure that would come upon us, everything would be messy, and we would probably all die from inflammatory reactions. And the microbiome actually serves in many cases as a buffer that resists and absorbs these transient changes, making it a very stable kind of factor that resists change in many cases. So the fact that you castrate or you change the hormones abruptly does not necessarily mean that the microbiome of a male configuration changes into a female configuration. It actually features what we call a metabolic memory, which is very long-lasting and can explain in totally other contexts how people that have been trying to lose weight and successfully lose weight rebound and yo-yo back into obesity. And we have shown in many different contexts that this is driven by the microbiome maintaining its disrupted configuration and resistant the change despite successful dieting, and then predisposing to an exaggerated weight regain. So this very big stability of the microbiome could also generate persistent male-female differences. But that's just speculation at this point.
One of the proposed pathophysiological mechanism, which is very common to most of the neurodegenerative diseases, is the innate immunity with the role of microglia and macrophages. So, and one of the explanations has been exactly the role of microbiome in regulating this type of activation. So the question to all of you is, should then we expect that there is also some common type of microbiome changes that underline all this type of pathology? Of course, then you may have some overlap with something specific based on the different mechanisms of aggregation which are specific of the disease. I was a bit surprised not to see emerging such a mechanism. Is there any reason?
I can try and take it. First of all, yeah, the innate immune microbiome connections are immense. We've been studying them forever. They're very specific and very diverse and mediated by direct contact or by metabolites and by many other mechanisms. So it's a whole big messy field that has huge impacts, including probably in neuronal disease. Specifically in ALS, in the models we've tested, at least quite superficially, we didn't see an immune response, but that doesn't mean that in Alzheimer's it doesn't happen. With respect to common denominator microbiome changes, I would say that, at the beginning, when the field started, it was kind of a romantic notion that we would find, the bad microbiome and we'll cure all disease. I don't think this is realistic. Although just a week ago, Liping Zhang from Rutgers has published a wonderful Cell paper in which, in a very high level, he showed that there are common denominator functional microbiome changes that can be characterized across different human diseases. But these are high-level changes, and if you go deeper and more extensive, you find the disease-specific differences that drive different manifestations of disease beneath them. So in a way, he has kind of fulfilled your question, but in a very high-level kind of way.
There has to be some specificity as well, depending on what is the neuronal population that is affected in all these different sort of neurodegenerative disorders. One of the things that we're observing now is when we selectively, for instance, modulate or alter a neuronal population, say dopamine neurons with 6-hydroxydopamine locally applied, we see dramatic changes in the gut microbiota and in the peripheral immune system. So these are sort of a central effects from the brain to the periphery. So the whole thing is so dynamic, sort of that probably you're going to have perhaps some sort of a global common denominator, but a lot of specificity depending also the brain circuit that is being altered.
I think the only thing I would add to that is that I think even though there are differences in terms of the different diseases, I think it is a good point that there are some of these common mechanisms, as I talked about at the beginning of my talk. And so I think we can still use our lifestyle factors in part to help us manipulate the microbiota to kind of get to some of the same places in terms of managing these disorders.
Any questions? Okay, you are the last one.
Thank you. Yeah, Carly Tanner from UCSF. Thanks. Great talks. Really appreciated it. I'm curious to know your thoughts about the rest of the microbiome. So not the GI microbiome, but the nasal mucosa, which is very interesting to us in Parkinson's, since olfactory mucosa or olfactory bulb is one of the first areas affected, and we can argue about brain or body first, but certainly that's a common finding. And skin, where we have a very large surface area also covered with, as I understand it, the microbiome. So how does that figure in rather than just the focus on the gut? How do you think about that?
You're absolutely right that there are different microbial ecosystems at any different bodily niche which communicates with the world, including the ones that you've highlighted, also the genitourinary tract and so on and so forth. And in each of them, I think the fascinating thing is that the microbial functional framework has co-evolved with the niche to supply critical functions that are specific for that niche. So for example, the vaginal microbiome is uniquely equipped to protect in very acidic environments, but also to consume a lot of glycogen that is supplied by the host. So this symbiosis is very niche specific and very fascinating. It's very hard to study these other microbiomes. It seems that the skin is, you think that the skin is covered with microbes, but in reality, and we have projects on all of them. Just to give us the skin as an example, when you actually measure, the skin microbiome is a much lower biomass than you would think, and most of the microbes actually hide into the basis of the hair crypts. So fascinating, difficult to study. You need to control for confounders, contaminations, and so on and so forth. Nonetheless, once people start to dive into these different niches, they discover new molecules, new interactions, new networks, new disease susceptibilities that are specific to these organs. So there's an ocean of discovery that awaits us.
Any comment? No.
I totally agree. Fascinating. The size, accessibility is an issue, but they are also sort of a fascinating sort of communities waiting to be discovered.
Okay, so time is over. So I will close session 3. I would like to thank all the speakers.
I just wanted to point out one more thing, which was that if you want to take a look at the work that we've been doing in our group, please make sure you search by my last name, which is Cat Sand. I think that was an error when you tried to pull our publication. So you'll have to look that way and not by Sand, or else you'll just pull up anything that was misclassified.
Okay, thank you very much.
see, it's more. Does he? Yeah, regularly. I know. I know. I know. Ma perché so... Boh. Oh, that's mine. Thank you, thank you.
So you know the two
I learned, yes, and I'm so glad because I would have.
And the guys say the left, of course.
Of
The
course.
left is to go back.
Exactly.
No, it's the left.
No, that's right. Because I asked because somebody was having trouble.
pare che vada. Io da stamattina che sono qua, no, non qui nel senso che vedo. Dimmi tu quando vuoi che cominciamo. Wait to start. Okay, so we will start with the session number 4. First of all, I would like to thank Professor Comi and Fondazione Prada for inviting me to this exciting conference. This session is dedicated to sleep, and I'm very happy because, sleep, I think that is one of the most important aspects in our life, and also according to the theme of the conference. We have 3 talks. The first one is on the role of sleep in dementia prevention. The second one on the lymphatic system and neurodegenerative disorders. The title of the third talk is The Burden of Wake and the Reasons for Sleep. And I would like to introduce the first speaker, Professor Cristina Jaffe. Professor Cristina Jaffe is a professor of psychiatry, neurology, and epidemiology, and director of the Center for Population Brain Health at the University of California, San Francisco, United States. She published a large number of papers, and I would like just to remember the publication in a JAMA on 2011. It was in a very interesting prospective study that showed that the elevated oxygen desaturation, greater than 15 events per hour, but no sleep fragmentation, was associated with increased risk for developing MCI and dementia. And also, I wrote an editorial as comment of this paper, and I would like to thank you because you published the paper and I published the editorial. And in my editorial, I said, no medication are known to prevent progression from MCI to Alzheimer's disease. So treating at least patients with CPAP for sleep disorder breathing is a prevention strategy that may be worth testing. This was my editorial, and it was just a little provocative against, the possible medication for this kind of problem. So please, Professor Christie.
Thank you very much. Thank you, Professor Comi and the organizers. It's really a wonderful conference, and we hope the sleep team can live up to the prior sessions because it's really been a wonderful day. We also have a challenge. This is, I think, nap time. 4 o'clock in the afternoon, it's dark, we have jet lag, so I'll try and make this very exciting. Okay. So what I'm going to do is talk a little bit, set the stage a little bit. My colleagues are going to talk a little bit more about the pathophysiology and some of the mechanisms, but I will refer to them a little bit, and then mostly talk about observational data, and then a little bit about trials, because I think still trials are the causal gold standard. One important thing to know is that when we age, sleep quality decreases. And this is true for pretty much all of the different measures, whether it's duration, how long it takes you to fall asleep, whether you're sleeping more deeply in stages 3 or 4, or REM, napping, circadian rhythms, etc. And sleep apnea, as we heard, is very, very common. So this is important. As we age, this is something that becomes more and more important, and it may have a overlap with a lot of different diseases. Again, I'm not going to talk a lot about this, but I think really one of the most exciting things we've seen in neuroscience in the last 15 years or so has been this issue of what happens when we sleep. We spend over a third of our lives in sleep. Why? What are we doing? Well, we think it's a time of quiescence. So we're not as active in terms of synapse, of activity, and there's a quiescent phase, but it's also a time of being able to clear toxic proteins, in particular, in this case, amyloid and tau, which is what these models show. And I think, again, we'll hear a bit more about that with lymphatic clearance, et cetera. So this has led to this idea that there's something about sleep or poor sleep, which is a setting for greater neurodegeneration, in particular Alzheimer's, but I think this could be applied to a lot of different neurodegenerative diseases, and which is one of the great things about this conference. We hear about a lot of overlap. So during this time of sleep, it's quiescent, clearing of the proteins, and if this is disrupted, you have greater accumulation of these proteins, hence greater neurodegeneration of Alzheimer's or whatever protein it might be. The other thing that's quite interesting, and I think we'll hear about this as well, is that there's certain neurons that might be particularly susceptible to tau and amyloid, and others, in particular in the brainstem. And this brings up the question of, is there a bidirectional relationship, which I actually think there is, and I won't have time to really get into. But it may be a very early prodrome. We've heard about this in terms of Parkinson's a little bit, and I think it's true as well with Alzheimer's and greater sleepiness and napping, which we may touch on a little bit. So let's turn to people now and some of the studies. We've been interested in this for quite a while, and we were some of the first to actually use objective measures, so actigraph, polysomnography, et cetera. I'll talk a little bit more about that, but people use subjective. It's easy to ask people, how did you sleep? That's easy. It takes a second, but the problem is it's not very good. It doesn't really correlate well to objective measures, and there are all kinds of reasons why people may say that they didn't sleep well. So it's really important to use objective measures. In this case, we did some work a while ago showing that older adults, these are non-demented adults, normal cognition, those who had less efficient sleep or they took longer time to fall asleep, they had greater risk of MCI and dementia in this kind of almost a dose effect, if you will, based on quartiles. And similarly, we then looked to see whether the stages of sleep were important, and indeed they are. So if people are spending less time in deep sleep or greater time in stage 1, which is the lighter sleep, or if they have less time in REM sleep, these both were associated with worse cognitive performance. So it's not just how well you sleep, it's also the level of your sleeping and the stages. We also think circadian rhythms are important. As you know, this is sort of a diurnal a clock, if you will, and we think that people who have shifts in that diurnal cycle are in increased risk for Alzheimer's and other dementias. And this is correlated nicely by Eric Musiak's work, showing that there's actually greater accumulation of tau and A beta, or lower A beta, higher tau, with this fragmented circadian rhythms. Again, suggesting there's something about this dysregulation that increases risk of neurodegeneration. And then, as we had a nice prelude, we think sleep disorder breathing is also very important. We were curious whether sleep disorder breathing was associated with dementia because you're disrupted in your sleep, but you also have hypoxia. And we found it was primarily driven by hypoxia. Which again is correlated now nicely with some work showing that your natural log of AHI, that's a measure of sleep apnea, or your hypopnea index, that changes your CSF A beta. So a lot of really good mechanistic data showing these correlations with greater protein accumulation or levels, biomarkers, and these associated kind of measures of sleep. So I think we can say in the last 10 years that there's a beautiful body of work now establishing that all these different parameters are linked with cognitive aging and risk of dementia. But I think there's still a lot of questions, and I want to talk a little bit about that. One question is, how do these sleep parameters work together? You know, if you can't just measure one thing and not the other, you can measure sleep apnea, but maybe you have great sleep duration, or maybe you have, you know, messed up circadian rhythms, but your efficiency is good. How do you put them together? Also, what about sleep at earlier life stages? We've mostly been focusing on older life. We know that midlife in particular might be a vulnerable time, particularly with women during the menopause transition, which is a whole other subject. But I think there's a lot of questions we don't know. And finally, we really haven't heard a lot about race ethnicity, and there's some important differences why this may be relevant. So we think sleep is multidimensional, right? So all of these different parameters happen at the same night: your duration, your timing, your efficiency, what you do in the day. And Dan Bussi has done some really nice work showing that these things can cluster. And Clémence Cavaillé, who's a postdoc with us, very talented postdoc, she's been doing some work taking these clusters. So she used sort of machine learning to identify these clusters of different parameters. And what she found was there were 3 clusters, really, really interesting. There was the most predominant cluster was actually active, healthy sleepers. They were pretty good at efficiency and circadian rhythm, and in the day they're awake. And then there's fragmented poor sleepers, which was a big chunk. They have bad efficiency, they're fragmented, they're waking up, their circadian rhythms are shifted. And then there were the nappers. The nappers were sleeping in the day, but their efficiency was okay. And then what she did was she looked at this in terms, and this is not yet published, she looked at these clusters and she found that the actual poor sleepers were at greater risk of having dementia. So really interesting putting these things all together, and I think that's going to be very important. People have tended to, you know, split these things, and I think we need to put them together a little more, particularly as we think about interventions. Okay, what about the life course? This is a really nice picture. It shows you what happens. You know, when we're babies, we sleep a lot, just like little kitties. And then in midlife, we don't sleep as much for all kinds of reasons. I think we're working, we're taking care of kids, etc. And then as we age, the sleep duration increases, but might shift in other ways. So what about cognition and sleep and brain health earlier in life? Yu Lang, who's a very talented faculty with us, she did a really nice Mendelian randomization study where she tried to look at, in the UK Biobank, she used AD genetic risk scores, polygenetic risk score, or GR genetic risk score, and she was able to find people without dementia but had this high genetic risk score. In midlife, she found that those people actually had almost 2 hours less of sleep duration. Really kind of incredible. So very big effect. These people were sleeping less, and we think that this is a really nice causal evidence that sleep is connected to Alzheimer's disease, because in midlife, nobody had Alzheimer's, et cetera, but they were genetically prone. So sleep duration might be used as an early marker for AD, particularly in midlife. We've also done some work more recently, or couple of different studies looking at midlife. This is from the cardio study, mean age of about 50, 55. And we found that different sleep quality was associated with cognitive function and also white matter integrity. So when we looked at people with sleep duration, we found that there was actually greater white matter deposition, but also less integrity in terms of DTI measures. So again, suggesting that something could be going on as early as midlife. And then Clémence Cavaillé actually just, this paper I think is coming out maybe today, in fact. She, again, looked in midlife to see the people, if you focus on the pink bar, these are the people who actually had poor sleep at 2 time points over 5 years, from 50 to 55 on average. And what you can see is they really were very different, and the outcome here is a brain aging score. So we used machine learning to develop sort of predicted age vis-a-vis brain MRI, and then was able to use sort of the brain atrophy pattern to predict accelerated brain aging. And what she found was even in midlife that this poor sleep in a variety of different parameters was associated with accelerated aging by about 2 years. This is some work we have just started. We just finished enrolling. And this has to do with the diversity that I mentioned. So we really haven't paid much attention to race and ethnic differences. There are a lot of very important social determinants of health when it comes to sleep. We heard a lot about pollution, but we didn't hear that much about noise pollution, light pollution, but they're correlated. And so there are lots of reasons why there might be race ethnic differences along with other vascular neurodegenerative factors. So we received a grant from the NIH a few years ago. We were a bit disrupted by COVID, but nonetheless, we were successful in enrolling about 1,000 people. And they were a third non-Hispanic white, a third Mexican American, and a third African American or Black participants. And now we're just actually having fun where we're just starting to look at the data. Everybody had an actigraph and a watch pat, which is a sort of a poor man's polysomnography. And they also had a bunch of subjective sleep data. So we're just starting to look at this. And this is some work that's not published yet, but we're finding really striking race and ethnic differences with much poorer sleep, pretty much no matter which parameter you look at in the Mexican American and Black participants. And this was true for the usual suspects, but also the sleep architecture pattern. So really interesting. And now what we want to do is try and see how this translates into biomarkers and imaging and also cognitive function and decline over time. From Meredith Brasky's lab in USC, they also have been helping us look at tau PET and amyloid PET, and so this is again some very preliminary work looking at sleep apnea and the amount of hypopnea index that I mentioned, apnea-hypopnea index. And what Victoria Tennant, who's a graduate student, has found is that the greater the apnea-hypopnea index, the greater sleep apnea, if you will, the greater tau accumulation in 2 of the 3 regions. That was the parietal tau and the cingulate. So really interesting. There's been very little work on tau. There's some work on amyloid, but I think it's going to be really interesting to tease some of these out. And finally, from the same study, Dormier, I've neglected to tell you the name of the cohort, it's Dormier. We are looking at sort of classic AD signature cortical thickness, that they're using the AD ROI, region of interest, and showing that sleep quality is associated with this. So worse sleep quality, more atrophy, and better sleep quality, more deep sleep, REM, et cetera, less atrophy. So again, really intriguing. It's just baseline cross-sectional. We're just starting to dig into this, but I think it's going to be really exciting to look at these race ethnic differences and also to see whether the correlation with biomarkers and imaging are similar. So I just want to spend a moment talking about trials, because again, I think the gold standard for causality is trials. CPAP therapy, we heard about this. Why haven't there been more studies of CPAP? You know, a lot of CPAP has been around for a long time. Sleep apnea is very common. 60 to 70% of older adults have sleep apnea. How come we're not looking at this more? Well, first of all, nobody likes wearing their CPAP, right? So the amount of non-adherence with CPAP is quite high. Nonetheless, there was a small preliminary trial of CPAP in AD patients a long time ago and showed a benefit for cognition, but it was preliminary. It wasn't controlled, so unclear. Then there was a large RCT called the APPLE study, and it had negative results for all kinds of outcomes, including cognition. Turned out that there was low adherence even in that trial. There were a lot of questions about the trial. You know, I don't know, but they didn't find anything. There are actually 2 trials that are just starting. One is called the ReShape trial in Australia by Sharon Naismith, and then the other is just starting in the U.S. by Katie Stone. So I think we're going to hear more about that, which is, I think, very important. There have been a couple other trials, but mostly small. Often they don't have good control groups. CBT, cognitive behavioral therapy, light therapy. So I think the jury's still really out on this. But I think we're ready to understand this much more. And I think the field is really ready to do more with trials, again, across all neurodegenerative diseases. I think the time is now. We did a trial that we published last year where we actually did risk reduction. We enrolled older adults at risk for AD, but they did not have dementia. And we targeted several different risk factors. One of them was sleep. And we actually asked people, what do you want to work on, and how do you want to work on it? So it was sort of personalized in a sense. And one of the things that actually moved, this was a two-year trial. At the end of the trial, we found actually a statistically significant benefit over the placebo group, the control group, and cognition. And as I mentioned, one of the main drivers of this was sleep quality. So people were asked to either do sleep hygiene, they did CBT, they did all kinds of different things. Some of them went to their doctor and got CPAP. We let it up to them to decide what they wanted to work on, how they wanted to work on it. The point is that we were able to show their sleep got much better, and this was one of the factors that drove the cognitive composite results. So I think it's very exciting. Finally, in terms of other trial strategies, of course, there's been huge advances in the pharma of sleep, in particular orexin receptor antagonists that are now used much more to treat insomnia. And this is a very small trial from Brandon Lucy, where they actually looked at placebo and then 2 different doses of an orexin receptor antagonist, and found that actually the higher dose in particular was associated with less amyloid and tau accumulation. So again, very exciting. I think we're going to see a lot more about this in the future. So I just would like to conclude by saying I think sleep has a lot of potential for dementia prevention. In fact, I would say it has a lot of potential for neurodegenerative prevention in general. The preponderance of observational data really suggests this very interesting relationship. I did not get into the bidirectional effect, but I think it's very important as well as a prodrome, as well as a risk factor. Monique, we can talk about that. I actually think they're different. And there's emerging evidence that this sleep is important earlier in life too. So midlife might be a really important time to be focusing on. We need greater studies in diverse populations, and really I think we need much more RCTs, randomized clinical trials, to really see whether if we improve sleep, however you do it, drugs or CBT or CPAP, whether you can actually move the needle and maybe reduce risk of developing dementia. So I'll end, and thank you very much.
Thank you, Christy. We have the discussion at the end. Now I would like to introduce Marios Politis. Marios is a professor of neurology at the University of Exeter, UK, and the talk of Professor Politis is on the lymphatic system. I think that the lymphatic system is a very, very interesting argument, because we know that we have several papers that suggest that lymphatic system play a key role in preserving brain healthy, especially with the maintaining homeostasis by clearing neurotoxic proteins. And sleep is important. You will explain why it's so important, which part of sleep is so important, and also there are other things that are very important, not just sleep, but also other aspects. Thank you. Please.
Absolutely. Thank you. Thank you very much, Mr. Chairman. Would like to thank Professor Comi and the Foundation for this absolutely excellent meeting. Have been very much intrigued by the talks. I hope I can stand myself on that forum. And indeed, today I'm going to speak to you about the lymphatic system in neurodegeneration, basically putting a few examples from Alzheimer's and Parkinson's disease. There's so much going on this topic. It's one of the sexiest ones, I think, the last few years. So really, I'm gonna just scratch the surface here, just the tip of the iceberg. Apologize also for my voice. I'm recovering from a cold, so I hope you can understand me. Right, so one of the things to describe the glymphatic system is that basically mimics what actually human civilization has done to remove the waste, dispose the waste. And this is one of my favorite pictures from Cairo, that the Zabalins collect the city's waste. However, as with that something that can go wrong, you can end up something like this. So the glymphatic system is precisely on that type of direction of being able to remove waste from the body, as the different other systems that we know much before that, we know that they do, like the liver, the kidney, and the lymphatic system, that they eliminate waste products of tissues or metabolism. So in terms of the brain, what we know is that every day the adult brain produces 7.1 grams of protein, that they are eliminated and they must be replaced with new ones. So this brain fluid surrounding the outer surface of the brain sinks this waste and then removes that from the kidney and the liver. Now, what is the most interesting on that is that 90% of this process takes place during sleep. So that's why sleep is very important, and that's how it's connected with this clearance of the glymphatic system. So all of these proteins that we know that they are pathological when they come into accumulations at the toxic levels are actually healthy normal proteins produced on a daily basis, but then worn out and cleared. And for the two most known neurodegenerative disorders, such as Alzheimer's and Parkinson's, there's the amyloid and the tau on the Alzheimer's side that make the plaques and the tangles when they're not properly removed from the brain, and the Lewy bodies composed of alpha-synuclein on the Parkinson disease. And those look something like that. And in addition, there are others like TDP43 for ALS or Huntington here for Huntington. There is a lot to say here because some of those, they are located extracellularly, some others intracellularly, some others on both sides, and there is a scientific argument on the community about whether the glymphatic system could be relevant to also the intracellular proteins as to the extracellular, but I leave that outside this talk today. Now, if we try to make some architecture about how this glymphatic system works, it's basically an exchange between the cerebrospinal fluid and the interstitial fluid. So from the cerebrospinal fluid, it's coming through the perivascular space. This is pumped from the end feet of the astrocytes, entering the periarterial space, then to the extracellular space, which is whatever we see on the middle, clears the proteins and whatever needs to be worn out from there, passes through the channels, the water channels, which the aquaporin 4 channels, very, very important, and then goes back to the periphery to be eliminated from the lymphatic system and then the kidneys and the liver. Okay. Now, from the animal work, it has been shown, like some years now ago, that, as I said before, this function mainly takes place during the night. That you have an enlargement of the extracellular space during the night, so the clearance can become much more efficacious and better. And then they have tried experiments by knocking out the aquaporin 4, which is the water channels that the fluid is passing, to show that the glymphatic system and the clearance actually is not working well at all on mice that they are aquaporin 4 knockout mice. And then further to that, additional animal studies have shown that this works better in younger animals versus older animals, And actually, when you are missing this aquaporin 4 water channels and the clearance cannot take place properly, you have an increase of a retention of misfolded proteins like amyloid. So a big relevance for disorders like Alzheimer's disease. So what about targets and what about in humans as well? So obvious targets are the CSF flow. Why is that? Because we know that as people getting older, you have less production of a fluid, but even more importantly, the pressure of a fluid that will eventually go and clear your waste, it's reduced. Second is the astrocytes and the ENFit, because are the ones pumping the flow of the glyphatic clearance. Of course, the protein aggregates, where every waste is there to be cleaned. And very, very importantly, also the aquaporin 4 channels, which is the water channels that the clearance is passing. So today I'm just going to speak briefly about the astrocytes and aquaporin 4, and I'll leave the rest for another time. So starting with the astrocytes, the astroglia, we have ways to actually calculate, to measure that in humans with the PET imaging. And how we're doing that? When you have a change from a non-reactive astrocyte to reactive astrocyte, you have a thickening of the filaments, enlargement of the nuclei. Most importantly, you have like an upregulation of GFAP, the glial fibrillary acidic protein, which we express the site to be a sites, and that you can label with the BU 99008 PET imaging. So we've done a study a few years back to show that on patients with early Parkinson's disease, you have an increase of reactive astrocytes, but then as the disease progresses, you start having loss of its function. And this is true for cortical levels, as you can see here, cortical areas, but also for subcortical areas like the striatum and elsewhere. Now, clinically, what that mean? And you can see also here the image as well, right? You can see the upregulation of the signal and the loss of the signal of the reactive astrocytes. The clinical correlations of these changes, was to say that the astrocyte function is lost over time. So the later you go on the disease, the function is going down. But also an association with the disease burden of the patients, and importantly, with worse cognitive impairment. So in a way, that means that as the disease progresses, at least in Parkinson's disease, this astrocyte situation here and the potential function that they're having is impaired, and is impaired in both ways, because in early disease you have like the inflammatory response, and then in the late stage you have like a decay, so you're actually losing functional astrocytes. Now, if we move to aquaporin 4 on the other side, this is ongoing work of histopathology. That we're actually looking on the aquaporin 4 in gray and white matter in controls Alzheimer's and Parkinson's disease, and this is just preliminary data to show that we start saying that on Alzheimer's patients there is a significant loss of this aquaporin 4 sites on the gray matter. This is very early days because we are planning to add a lot more samples on it, so it will be interesting to see whether these results remain and also extend on patients with Parkinson's disease. Here you can see some representative aquaporin 4 staining in control versus Alzheimer's disease in gray matter. This is basically mostly Bragg stage 5 patients. And a think the most interesting is the one that follows, which is the colocalization of amyloid beta and accoporin 4. So basically, the sites in Alzheimer's disease where you see the loss of accoporin 4 sites, it's also the same places where the amyloid beta has increased toxicity. So actually supporting fully the hypothesis about the clearance of amyloid through the lymphatic system also in human tissue. Another study we published a few years back, which I think again supports the whole theory, is the potential coding of particular SNPs on the accoporin 4 gene that could determine how well these water channels work. And at least from the samples we have seen, we have identified one SNP as this RS15 and so on, that potential predeterminant of high amyloid retention on the brain, and on the other hand, another one, RS72 and so on, that potential has like a protective role. So that's some work that we're following up also on Parkinson's disease, but also doing some extra on Alzheimer's disease to see whether there is indeed some genetic modification that actually can predetermine of how these accoporin 4 channels are working in humans. Now, all the other line, and we heard a lot about that on the previous talk that was truly excellent, of this function is actually the quality and how the sleep is. And I don't want to repeat much of what we said before, but we say that sleep fragmentation and actually how deep somebody's sleeping has very much to do with the lymphatic flow and the clearance. And the deeper the sleep, the better the clearance. And obviously, the less fragmented the sleep, again, the better the clearance. And there is also a difference as we become older. So currently in the UK, we're doing a very large study where we're collecting data from participants for both Parkinson's and Alzheimer's disease, of clinical measures with actigraphy, very much online digital tools, but also laboratory analysis and DNA. Now we are expanding also to imaging. Today I'm going to show you just a few stuff on sleep and the stratification on patients with Parkinson's disease, because I think it's interesting. So from the 4 main measures here of actigraphy, of total sleep time, sleep latency, sleep efficiency, and the wakefulness after sleep onset, I'm not going to speak a lot about how we end up there, but we end up to show that the sleep efficiency and the wakefulness after sleep onset are potentially the 2 best measures to stratify Parkinson's disease in terms of burden, disease burden, and also cognitive scores. So in terms of sleep efficiency here, if you see like the difference between good and bad sleepers, we'll see that other on the disease duration, the bad sleepers have been worse on non-motor scores, have been worse on motor scores, of total disease burden, of stage of Parkinson's disease, of cognitive ability, and non-motor symptoms scale as well. And the p-values are quite high. Now looking on wakefulness after sleep onset, doing the same stratification is more or less the same, like what we see with sleep efficiency. I think potentially the only difference is the non-motor sleep scale. Now when we combine both together, basically everything that has to do like with the motor and the non-motor burden and the cognitive scores of Parkinson's disease can differentiate between the two. And even if we covariate for disease duration, because somebody may argue that what we say is that the people that they have advanced disease is because they have, that's why they have like this difference. Again, the p-values remain for motor, non-motor scores and cognition. So I think this is very interesting and exciting about how we're going forward. But even further, what we start saying here is that these bad sleepers that they are stratified because of these two measures that we're just getting for the polysomnography of poor, that I like very much what was said before, which is the actigraphy, can actually correlate with levels of aquaporin 4. So that connects back to the glyphatic system, and we have a lot of ongoing work happening on that. So as a closure, the complex combination of what underlines sleep problems and the connection with the glyphatics obviously starts with the sleep itself. There are a lot of components that actually relate to lifestyle, like the sedentary lifestyle, the substance abuse, the obesity, things that people can change. But eventually, the process leads again to the same aggregates of misfolded proteins that will trigger the neuroinflammation, that you're gonna have like different parts of the brain that they're gonna be affected, with aquaporin 4 water channels be something very critical on this pathway that will lead to neurodegeneration and dementia. And with that, I'd like to thank you for your attention and apologize again for my voice. Thank you very much.
We have the discussion at the end. Now, the third talk by Professor Chiara Cirelli. Chiara Cirelli, she's a professor of psychiatry, and she looked very young, but she's a long career, on the sleep field. Because I would like just to remember that the first paper published by Chiara with Professor Tononi and Professor Pompeiano, she said that probably it was the medical thesis, the publication related to the medical thesis. Effects of local pontine injection of noradrenergic agents on the synchronized sleep of the cat, published in 1991 in Progress in Brain Research. But I would like also to mention one of the last paper published by Chiara. It's this wonderful review published in Neuron this year. Is a review on consciousness and sleep. Very, very, very important review. And Chiara said very clear that sleep is universal, essential biological process. It is also an invaluable window on consciousness. Please, Chiara.
Thank you very much. I also want to thank the foundation, Prada Foundation, Professor Comi, and the organizing committee for allowing me to present our work today. My take-home message will really be that sleep has an essential function related to maintaining synaptic homeostasis and therefore synaptic health across our lifespan, and that might very well be related to a fundamental mechanism through which sleep reduces the risk for neurodegeneration. But my talk today will really be to try to convince you about this essential function. And perhaps if you are convinced, then we can do the studies to really prove the causal link with neurodegeneration. We know that the link, we have heard the very nice talks before mine. So we know that there is a link between poor sleep, especially chronic poor sleep, and neurodegeneration. But we still have many questions to address. Most specifically, of course, that we don't know whether the link is causal because we have poor understanding of the underlying mechanisms. There are many of them that have been discussed, and for me it's useful to look at this diagram taken from a recent review, pinpointing to the 8 fundamental cellular hallmarks of that are shared across neurodegenerative diseases. And the top 4 are the most common ones. Of course, the first one being neuronal cell death and pathological protein aggregation. And from that point of view, we heard, of course, that sleep could be important in two ways. One is because it can promote the clearance of byproducts, but the other one is also that these byproducts like beta amyloid and tau are byproducts of neuronal activity. And overall, there is less neuronal activity on average in sleep than in wake. So another mechanism is through inflammation. There is a lot of evidence that poor sleep is associated with inflammation, and that is not only systemic inflammation, but is also brain inflammation. There are several studies, I'm just showing you an example from our lab, in which we could show that 5 days of chronic sleep restriction in mice leads to an increased number of activated microglia in the mouse cortex, as you see in the center. And then on the right, you see that actually we could show that this microglia is literally eating presynaptic components. But really, what I want to focus is the fourth hallmark that is shared across all neurodegenerative diseases, from Alzheimer's to Parkinson to Huntington disease. And in this review, the authors pinpoint to the fundamental fact that this synaptic dysfunction is a very early sign of neurodegeneration that happens much earlier than neuronal cell death. So I'm going to tell you about this hypothesis that really says that sleep is important to maintain synaptic health. First, I want to recognize that this work is done in collaboration with Giulio Tononi, now at the Wisconsin Institute for Sleep and Consciousness. The work is funded by NIH and the DoD, and I have no conflict of interest to declare. So our work is really basic, is trying to understand why we need to sleep. We know sleep is very important, is universal, is very tightly regulated. There are many ideas about why sleep is important. And we think if you want to really understand those ideas, each idea has to account for the fundamental feature of sleep that distinguishes sleep from any other behavioral state. And that feature is partial sensory motor disconnection, which is shown beautifully here by Rousseau. So by definition, when we are asleep, we lose the ability to promptly respond to potentially a very dangerous situation. And we spend a third of our life in this potentially very risky situation. So our reasoning is the following, that there must be, whatever sleep does, it must require the brain to go offline. If that were not the case, evolution would have found a way to carry out the same essential function during wake when we are not in such a risky situation. And that function, we think, is indeed to maintain synaptic homeostasis. So this hypothesis, SHY for short, is very simple. It just says that when we are awake, we are always learning something new, because there is ongoing learning. Learning, by definition, means that our brain has to adapt to the environment that is ever-changing. And the result of this process, at the end of the day, is a net increase in synaptic strength in many brain circuits. The job of sleep is that then to rebalance the synaptic strength to a sustainable level so that the next day we can learn again. Now, in 20 minutes, I don't have the time to tell you that this process during sleep, we call it actually synaptic down selection, meaning that is comprehensive, but yet is selective, because it has to preserve, of course, what we learn. And after 20 years, we know now quite a lot in terms of the molecular and electrophysiological mechanisms that allow to tag some synapses, protect them from the downscaling, and instead allow the broad weakening. But again, I will be happy to discuss this later. So this is all about synapses. I don't have to convince you that those are very important for the brain functioning, and there are many. This number, 100 trillion, is the estimated number just for the human neocortex. Most synapses in the mammalian brain look like this. They are axospinous glutamatergic synapses. So there is the axon, the presynapse, contacting a spine head, the postsynapse. And this is how they look like in electron microscopy image. So I'm going briefly to mention the rationale for this hypothesis, the evidence, and then the implication. Again, I'm not going to then cover the mechanisms. So as I said, we are always learning something new. And so at the end of the day, we have overall synaptic strengthening because we know most, although not all forms of learning are mediated by strengthening the connection, by synaptic potentiation. These are just some examples, both procedural and declarative memories are mediated in this way. So that's good. We strengthen our synapses. The problem is that this cannot be maintained in the long run, simply because synaptic activity is very expensive. It accounts for the bulk of the brain's energy budget, 70% or so. So we can't just keep going up day after day. So we need to renormalize. This is very well accepted, the concept, even in computer network like the one shown here, but there are many, many studies like this. If you only implement rules of learning, you end up very quickly in runaway potentiation, saturation of all synapses, and of course the network becomes unstable and you can no longer learn. So you need to implement rules of weakening. But many people think that perhaps this process of renormalization can happen at any given time. So every second or minute, we are potentiating some synapses and weakening others. Instead, really, the idea of this hypothesis, the core claim, is that the balance is maintained across the 24-hour cycle. But there is a time, the wake period, right now, hopefully, when we are learning and therefore strengthening synapses. And therefore, we have, at the end of the wake day, a net increase in synaptic strength. Also because all the arousal systems, the noradrenergic, histaminergic, orexinergic, cholinergic system, dopaminergic system, they are all much more active in wake than in sleep, and that promotes learning. So yesterday, today, I've learned new people. I have so many new experiences. I'm laying down many memory traces during the day. Then the concept is that when I go to sleep, all the arousal systems are much quieter, and that actually promotes synaptic depression. Crucially, as I mentioned before, the brain is disconnected, so I am no longer in need to adapt to the environment. And yet, the brain is very active. Neurons are firing extensively and synchronously during sleep, and that actually is the perfect time for this comprehensive sampling of synaptic strength to allow then the down selection. So that's the general idea. The core way to test the idea is to measure overall synaptic strength at the end of the day and at the end of the night for us, at the end of sleep, to see whether indeed there is an imbalance in synaptic strength. And this is what we have been trying to do for 20 years across species, because we think if this is an essential function, it should be true in flies as well as in rodents and in humans. And we have been using many measures because there is no single measure. I'm not going to talk about all of them, of course. I will skip all the electrophysiology, but we have a lot of evidence for minis, for instance. I will just show you some examples for molecular markers and ultrastructural markers. So in general, of course, if synapses get stronger, they have more synaptic components, both in the pre and in the post synapse. And so we can just quantify the amount of these proteins. In flies, for instance, we have been using pre-synaptic markers, specifically BRP levels. BRP is an element of the active zone and is basically present in all synapses in the fly brain. And what you see here on the left is basically a fly brain after a night of sleep and after a night of sleep deprivation. And you see the overall expression of this marker is very much increased after waking in most brain regions. On the right, you see another experiment in which we look specifically at some neurons and we counted the branches, the dendritic branches in these neurons, and counted the size and the number of the synapses. And what we found is that both markers are increased if the fly is exposed to an enriched environment. And then when the fly goes to sleep, these markers are decreased, both of them. But after the enrichment, if the fly instead is forced to stay awake, those markers stay high, which is very important because it says that after we have learned something, really to allow this process of renormalization to happen, you need the sleep. It's not just the passage of time. Now, in rodents, we use postsynaptic markers because they're more established, basically the expression of glutamatergic AMPA receptors, the number of these receptors that get inserted in the post-synapse increases with synaptic strengthening, the phosphorylation level of this receptor increases, and instead, when you want to weaken synapses, you have to remove those receptors. And basically what we have done, the first study was published in 2008, and then since then many studies from independent labs have confirmed this fundamental fact across species and in many brain regions. That is basically that if you extract synaptic proteins from cortex, the entire forebrain, the hippocampus, after 6 or 7 hours of sleep in a mouse or in a rat, relative to 6 or 7 hours of spontaneous wake or short periods of sleep deprivation, you see after wake a 30-40% increase in the expression of these markers. Now, the other approach that we have been using is ultrastructural measures, because in general, there is a very strong correlation. If synapses get stronger, literally they should grow in size. And so if Shy is correct, it should be that after sleep, they literally shrink. Of course, synapses are very small, so you need electron microscopy. This is our serial block phase scanning electron microscope that we use in the lab. So we acquire stacks of images from the mouse brain, and then we reconstruct pieces of the dendrites. And this is very time consuming because this is still done all manually. So every study that we did takes at least 3 or 4 years. So we reconstruct the dendrites, the axonal boutons, and what we really care about is the red area that you see, which is the axon-spine interface. So it's the direct area of contact between pre and post synapse, which is an established measure of synaptic strength. And so until now, we have done 3 studies in cortex, in the CA1 region of the hippocampus, and in the cerebellum, and specifically the parallel fiber to Purkinje cell synapses. And we have compared again few hours of sleep relative to few hours of spontaneous or forced wake. And every time we reconstruct thousands of synapses, so that's why it takes so long. And this is the end result. In all cases, we see that the end result of sleep is a synaptic weakening. In cortex, it is because the majority of synapses, 80% in primary cortex, decrease in size after sleep relative to after waking. In the hippocampus, it actually decreases in size, and in some cases, even the number of synapses decreases. And in the cerebellum, very interestingly, these are the same animals, just different regions. It is instead the number of synapses that decreases, but the end result is the same. Now, this is another study, completely independent study done at UCL by Jason Reel's lab. They took advantage of the zebrafish, where you can image all the synapses in single neurons in the animal. And they found, indeed, that after sleep, most neurons, but not all neurons, have reduced number and size of synapses. They also found that this weakening happens especially at the beginning of sleep and in the first hours when we have a lot of deep sleep. Now, what is the benefit of all this? Well, you can imagine at the cellular level, of course, if you end up with many synapses being weakened, you save energy. And of course, you move your brain away from saturation, so you are ready to learn again. But we also have evidence that this process can promote memory consolidation. Some people find intriguing that you can do so through synaptic weakening. So we have a lot of evidence that sleep helps in consolidating procedural and declarative memory. But we have evidence that memory strengthening can happen through synaptic weakening. And I'm going to show you how we did this. This is a repeated two-photon imaging study in which we can literally follow in the same animal. This is motor learning. And then we look at the synapses in motor cortex. And in these animals, we can literally follow the singles, each synapse, and measure the strengths using these molecular markers, the GLUE1 expression. Before learning this complex will task, immediately after learning, just 1 hour, and then we follow some animals after learning are allowed to sleep for 6 hours, others are instead sleep deprived. And this is what we find. So 0 is just after learning. As expected, some synapses are max, so basically they have grown a lot because of the learning. But those are the minorities, only 10%. The other synapses do not change much, and their synaptic strength is quite low. Now, what is interesting is what happens after the 7 hours. So after, if the animal is awake, your left, nothing changes. The max stays strong. The other synapses also don't change their synaptic strength. But instead, if the animal is allowed to sleep, the max synapses still are strong. Those are the protected synapses because of this synaptic tagging that I just alluded to. But the majority of synapses, 90% instead, are weakened by the sleep process. So at the end of sleep, the signal-to-noise ratio is increased, but not because the signal increases, it's because the noise of the other synapses decreases. And we could also show that the extent to which these other synapses are weakened correlates with better performance the next day. So what I've really told you is that we really need the sleep to be able to learn and be plastic the next day. And so, in short, the sleep is really the price the brain pays for plasticity. Now, it should follow then also the more we use our brain, the more we need to sleep. The higher is sleep need and sleep pressure. And indeed, we have a lot of evidence. I don't have time to go through this, but basically in flies, on the left, you can see that if you force fly to spend their day in a very enriched environment, then they sleep the next day, that's the blue curve, much longer, both during the day and during the night. Instead, if you then move these flies in a very impoverished environment, then they sleep less. And this is very reversible if you move the environment. And there is a lot of other evidence in these papers that I've shown you that basically the extent to which flies sleep longer is directly correlated to the extent to which these synaptic markers like BRP are induced during wake. In flies, we use sleep duration as really our measure of sleep need. But in humans, we have better measures, and specifically slow wave activity. So in non-REM sleep, the amplitude, especially, and the number of the slow waves is very high at the beginning of sleep in the first hours. When we need the sleep pressure is very high. And then it goes down, as shown here, in all regions, frontal, parietal, occipital regions, slow wave activity is high in the first hours, and then it goes down. We have known this for decades, and that's how we measure sleep need and also sleep depth. And we can show in animals first, we did this study, for instance, shows that the extent to which, if I keep wake duration the same, but I just enrich the experience for the animal, the more the animal learns and explores during those periods, the higher then is slow wave activity when it goes to sleep. And actually, that correlation holds also between slow wave activity and BDNF induction during wake. And BDNF is perhaps the gene that has been most strongly related to synaptic potentiation. We can do similar experiments, actually more refined in humans, using high-density EEG, to show that actually it's not just the overall brain, but if you, during wake, engage a specific circuit and use that circuit to learn, that is the circuit that then during sleep needs especially sleep. And so in this study, The subjects learn this rotation task that was known to engage right parietal cortex. Then when they go to sleep, the entire brain is asleep. So there are slow waves everywhere, but the red area in the right parietal cortex is the one that has the highest level of slow wave activity. And then it could also be shown here that the next day, there is this correlation between how much slow wave activity increased during that area and how better the performance was. So I told you slow wave activity is a very established marker of sleep need and sleep death. And now we have a lot of evidence that in fact, the fact that it is high during at the beginning of sleep and then it goes down is because it reflects synaptic strength. At the beginning of sleep, slow waves are big and their slope is steeper because neurons fire more synchronously. So their firing is more coupled, and so they're able to undergo this bistability on-off in a more synchronous way. By the end of sleep, because of this broad weakening, then the synchrony, the coupling decreases, and that explains the decrease in slow wave activity. And there is a lot of evidence. You can see this in computer models in which indeed you can show that the high synchrony is really reflecting stronger synaptic connection. So I hope I made the case that sleep has at least one very important function that is true every day of our life. I didn't have time to go to the early development, but we assume that in early development is even more important, of course, because plasticity is even higher. This is happening so far. We find evidence for this process across the species and also across brain regions. Also, I don't have time, but I will be very happy to discuss this also based on what was presented before, to show some evidence that we now have results showing that what really matters in sleep seems to be non-REM sleep and specifically slow wave sleep that at least in the adult brain mediates this synaptic weakening. And slow wave sleep, as was shown before, is actually the one that decreases the most with aging. I end here. Thank you.
Thank you very much. Please, Mario and Christine, would you like to sit down for the questions? Okay, so questions for the audience, please.
Hi, thank you very much all for the really interesting, fascinating talks about sleep. I'm going to sleep after this. No, jokes apart. I just had a curiosity. Since we're talking about protective effects of sleeps and why this is so important and everything that happens during sleep, and you've mentioned slow wave sleeps, what do you think, what's your opinion in terms of interventions on meditation? So more research is growing in terms of understanding what kind of waves meditation sort of like stimulates. And so is this a possible intervention to upgrade our level of clearance and protection? Thank you.
Short answer, I don't know. It depends also on what you mean by meditation, meaning for people who are learning to meditate. I'm told, I'm not a meditator, that that's an incredibly intense exercise. And many report that they need to sleep a lot during this period. And so from that point of view, meditation would look like to me really an exercise in learning. Once you are a very experienced meditator, whether meditating in itself can substitute for sleep or enhance the effects of sleep, I think the question is still very open. There are several studies that I am aware of, but I don't think there is a clear answer.
Would you like to add something? Because
yeah, I mean, in my point of view, yeah, the answer to the issue is probably a non-pharmacological one, which is a good point to start, because we should have at least some things that we can do without necessarily using drugs. So what we're trying to achieve here is we're trying to achieve like a high quality sleep at a point that somebody is sleeping deep, where the functions of plasticity or lymphatic clearance can take place. So the question is how you get there. I don't think you get there by just doing one thing, but potentially a combination of things. So we know that fighting obesity could improve sleep. Doing exercise could improve sleep. Not abusing substances could improve sleep. Being on a healthy environment without pollution, or somewhere perhaps outside, like very close to motorways. So the question is, can we find the formula here that by putting these components together could lead even aged people that they have more difficulty to reach to that good quality sleep to do that? So I think we need more non-pharmacological research, and we should be able to find good suggestions, and potentially mediation could be one of those to help get there.
Please, the other question.
Yeah, Carly Tanner, you said so. Thanks. Really fascinating session. I have two separate, unrelated questions. The first is for Professor Polides, and my question is whether in your study of Parkinson's you were able to take into account dream enactment or actual diagnosis of REM sleep behavior disorder in addition to the other sleep architecture parameters. I'll ask my next question and then people can answer. The second is for Professor Yaffe. And Christine, in your Dormier study, it seems there are 3 different reasons that people could have disrupted or poor quality sleep. One is purely environmental. You have to work 2 jobs and take care of children, and there's noise and light pollution, and you just have chronic sleep deprivation. Another is sort of peripheral. You have lung disease or heart disease, and you can't get effective sleep. And then the third is that you actually have a CNS reason that's already in process that could disrupt your sleep. And I wonder, in your study, it seems like an ideal way to start to look at that. And do you agree, and have you done that?
We start with Mario.
Yes. No, thank you. Your question is excellent. It's actually something we're doing because we're collecting this type of data, and we want to answer a few questions with that. First of all, is the daytime sleepiness connected with our hypothesis around the night sleep and the glymphatic system? Secondly, can it define these good to bad sleepers that we're trying to use as a stratification of Parkinson's disease severity? And thirdly, would that also link with potential fluid imaging markers of glymphatic system? So your question is, we're actually trying to look it on 3 different directions. The problem is I don't have the answer today for any of the 3 questions because we're just collecting data, but you are spot on, and thank you very much for mentioning that.
Christine?
Thank you for the question. I couldn't agree more that we need to try and understand some of the drivers of sleep quality, but also the race ethnic differences. We just finished the data collection, so we're going to look at this, and we're hoping to make it longitudinal as well, but we certainly are measuring comorbidities and environmental factors, et cetera, and social determinants of health. So, yes. I actually have a quick question. I was really struck by the last talk, and I was wondering whether you have any thoughts of the purpose of dreaming, or what dreaming might reflect, because it seems to me that maybe dreaming is sort of a reflection of the synaptic strengthening.
I would argue that, well, we don't have any evidence for that, and basically, dreaming may have a function, may not have a function. I'm totally open also to the idea that might not have a function per se. The most, it's challenging until we don't find correlates at the presumably electrophysiological level that define dreaming in a very precise way so that then we can do also animal studies. We are stuck with the fact that dreaming can only be studied in humans and is only based, still is based on report after waking up. So our lab has actually done, I think, the first study proving that there are correlates, electrophysiological correlates, but that study has to be replicated and has to be taken on by more people so that people can be convinced that then you can actually study dreams even in animal models.
Please, Giancarlo. Professor, sorry. Giancarlo, okay, please.
A question for Professor Politis. Very nice talk about aquaporin 4. It's an intriguing protein, intriguing target. I'm just wondering, when you show this data about aquaporin, is it referred to the total aquaporin? Because I guess that you know better than me that you have also the extended form, and there are papers claiming that actually is the extended form being active at the podocytes and being mislocalized in diseases. So I'm wondering if you're also taking into account the ratio between the normal aquaporin and the extended form, and if you have some evidences, like other groups have, that extended is more important than the normal in the pathology.
No, thank you. Excellent point, and I couldn't agree with you more. You're absolutely correct. So our preliminary data, because this is just preliminary unpublished data, is on total aquaporin 4. So we're looking forward to actually look on that deeper and make the separation to see if there's a potential agreement with other groups or not. So we just wait to find out. But thank you for your comment.
Giancarlo.
Well, a question to Chiara. I mean, you said the sleep is the time of reorganization of the system, where we try to use our brain plasticity to change. So we change every day and we reorganize every day. So 2 points. Is there any way to establish which is brain reserve testing this type of capacity? First point. And the second one, which is a bit, of course, related. How long, how long is the time we have to spend to destroy or vice versa, to protect that, because these are the two faces of the same aspect.
Thank you very much for the questions. So apparently, so the reserve in terms of avoiding synaptic saturation, I didn't have the time to go to that, but basically we have evidence both in animals than in humans that it doesn't take long. So 1 night of sleep, if you try to induce new learning in an animal, it would be by electrical inducing, synaptic potentiation with a very precise protocol. In humans would be through TMS. In a rat, 5-6 hours of sleep deprivation are already enough to basically cut to almost non-significant levels your ability to induce potentiation. So you can do that in a mouse or a rat if you have slept before. If you had been awake, sleep deprived for 6-7 hours, no luck. Humans, 1 night of sleep deprivation, you're using the same TMS protocol to produce kind of LTP-like or LTD-like processes. LTP-like fails in humans after a night of sleep deprivation, while it works after a night of sleep. So, the reserve, at least for the cortex, because that's what is being tested in these experiments, is not very big. How long it takes? In animals,
So in the zebrafish, and based also on our study, I would say that it takes few hours. What counts is really the deep sleep at the beginning, so it might be 2-3 hours. It's probably not 8 hours, at least in an adult brain. It might change in a young brain, and it might also change depending on where we look. This evidence really comes mainly from cortical structures.
Thank you. Other question?
Yeah, first, thanks to all the speakers, because this was really very fascinating and interesting. I've actually one question to Christine, and that is, you say that this polygenic risk score for Alzheimer's disease was associated with sleep deprivation. And so my question there is, does that not suggest that it's actually that poor sleep quality is a consequence of your genes and not the other way around in this discussion of causality, right? And then I have another question for Professor Politis, and that's actually more triggered, well, by the topic, but also that I saw that you are in this neuroimaging group. There are these suggestions on how we might image the function of the lymphatic system. Of course, there's the more advanced ways to do it with contrast agents, but also more recently that we could have this diffusion, this DTI ALPS, or basically, or even also in a resting state fMRI bolt signature. Are you aware, and what do you think of these imaging methods? Do they make sense at all or not? So two totally different questions, but
I'll go first. So good question. We actually did look in that study at the other way, which is whether the sleep genetic risk score had any effect on AD development, or it was all-cause dementia, and it wasn't so much. But the problem is that the polygenic risk score for sleep isn't as good. So it's a very good question, and I guess we won't know for sure. But it seems that they're pretty separate genetic risks anyway.
Yeah. So how we can image the lymphatic system. So so two main ways. One is with PET imaging, the other with MRI. Difference is obviously PET nanomolar sensitivity at the molecular level. MRI a bit more generic, even if it's structural functional. Now, what happens though is to develop ligands specific for targets on the PET is not the most straightforward process, takes years, not necessarily that easy. So from the targets I show, we do have like a couple of good ligands for the astrocytes, so at least we can see like how they are behaving, like the one I saw, the BU0099. Of course, it's labeled to carbon-11, which means you need a cyclotron on site, so not something that you can produce massively and transport. I mean, on animals, they have used inulin. Inulin, theoretically, you can label with carbon-11 and you can use it for humans. But again, it's a very difficult and very expensive process. We have made some efforts in the UK, so let's say if that's going to work. And then you have like more like global measures like FTG, or then you can look on the synapses with SV2A ligands like UCBJ and so on. On the MRI side, yeah, DTI ALPS has got a lot of attention. Yeah, it's a relatively good but generic measure, so lacks specificity, but on the other hand, can give you information. But there's also development of other techniques, as you said, with resting state and potential additions through spectroscopy. Yeah, there is quite a bit of more work to be done on that aspect, and currently I'm just summarizing very few of that are out there. I hope I'm not forgetting something very important, but yeah, thank you.
Other question?
What? Very nice talk. Sorry, microphone is in my hand. So Simon Chen from University College London. I have two questions for Professor Yaffe. And the first one is I'm quite interested in the sleep apnea. So I know there are two types of the sleep apnea. One is central sleep apnea, one is obstructive. So which type of sleep apnea is more associated with Alzheimer's disease? A related question is, in people with Alzheimer's disease, which type is dominated? And the second one is a bit stupid, because I see a lot of evidence from your slides. Sleep is a risk factor for dementia, but why it is not among those 14 risk factors in the Lancet Commission? I suppose you must support to include it, but why the evidence probably, is it because there are less quality or objective sleeping data in those cohorts, or yeah, thank you.
Yes. So can you hear it? Yeah. So the first question about sleep apnea, there's two types, central versus obstructive. It's very hard to, in these kind of studies where we're just measuring that apnea, hypopnea, it's hard to know which one it is, but most is obstructive. So I couldn't tell you whether there's a differential effect. My understanding is, at least 90-95% is obstructive. And that's what works with CPAP. But it's a good question, and I don't really know the answer. In terms of the Lancet Commission, I don't know whether Dr. Livingston is here, but I think she'll be here tomorrow. With all due respect, I think that it is basically a summary of a bunch of experts, like any experts, you're not perfect, and it's not always based on objective evidence. So I've asked her. I don't know why sleep's not included. It's a puzzle to me. It's a puzzle to a lot of other people. So we could ask her tomorrow. But just like in the Lancet Commission, some things are focused on midlife and not late life, like hearing loss. That doesn't make sense to me. I think hearing loss is really more an age thing. So there's a lot of questions, I think, and the Lancet Commission is, a very comprehensive and wonderful effort, but it's hardly perfect, and it's not always clear how they get their evidence, frankly.
I add something about the problem of sleep apnea. I think that obviously we are talking about saturation. You have to consider that you have the more oxygen desaturation. Central apnea. The majority of paper has not been specified exactly which kind of apnea. To consider the possible role, I think that if you think about the possible role of the desaturation, I think that we have to think about the obstructive rather than central apnea, because in central apnea you have a low desaturation. Okay. Other question?
A very fast question. Beautiful session. Beside a very quick question, beside decreasing the burden of abnormal protein in neurodegenerative disease, do you think that the sleep synaptic hypothesis can explain some engagement of the anti-inflammatory action? This is for Chiara.
Directly, meaning in terms of reducing the astrocyte inflammation. So we have some evidence that, astrocytes are responsive to what synapses do. And so in sleep, in the electron microscopy studies that we did, we also have evidence that when synapses shrink, astrocytic processes also retract from the they are no longer so close to the synapses, which, by the way, is one possible way through which actually sleep then promotes the clearance, because literally this retraction increases the empty extracellular space. So that could be another way, because astrocytes do reflect synaptic activity in a very direct way, at least the astrocytic distal peripheral processes.
Thank you, Chiara. Other question?
Okay. Marco Rasile, Humanitas University. So first of all, thanks to the speakers for the wonderful talks. And my question is about sex. So are there differences in the sleep architecture between males and females, or even, you know, at the molecular level in the process of sleep? And if so, how much of the sex bias in neurodegenerative disease can we, can be accounted in these differences?
For me, I can briefly, for what we have seen at the very basic level in terms of ultrastructural measure, molecular measures, there is no difference. The process seems to be, although, you know, our numbers are low, but we couldn't see any difference.
For me, I have absolutely no idea, but if I have to hypothesize, there is so much more higher prevalence in females of a cognitive decline. So if you look at from every possible direction of how prevalent is cognitive decline, you will see that females have higher prevalence. Somebody will argue is because they live longer. Yeah, probably that's the reason. But I think it's worth examining if there's some difference as well that could be related to that. I have thought about it, but I have no idea. I've never done any experiment, or I don't know anybody who has done on that. But I think it's a very interesting question.
So, okay. We're starting to look at that question in Dormier. In the past, I would say that most studies haven't found much sex difference in terms of looking at an interaction, so the similar associations in terms of sleep quality and risk of neurodegeneration syndromes. So I don't think there's anything clear. We are finding in Dormier actually that men seem to be having worse profiles, particularly Black men. We're just starting to dig into that, so that would maybe be against where you were going, but you know, certainly during the perimenopause transition, that's a whole other topic that you know, people are getting very interested in, and women have a lot of subjective and probably objective sleep problems, but you know, we don't even know really, you know, much at all about menopause. So you know, I think there's a lot more to be looked at, but it's a great question.
Please.
I want to refer back to the question of sleep as a risk factor for dementia. So there's a lot of complexity, I think, because it's not clear to what, at least to me, to what extent it is modifiable risk factor. You know, in theory, you can change your diet. I wish I could sleep beautifully and deeply, you know, for 7 hours or 8 hours every night. But I know there is some sleep hygiene, but I don't know how far it goes. And I think you hinted in the morning, in your talk, Christina, that sleeping pills are not, there is no proof that those are the answer. So I would like to hear your opinion on this.
Yes, that's why I tried to end my talk a little bit with the trials, because I agree with you. I think, you know, all of this evidence, whatever it is in terms of whatever risk factor, and I'll come back to the Lancet Commission, actually, they don't really weight trials over observational studies, which should be, you know, in a hierarchy of evidence. So, yeah, I mean, we don't have a lot of trials, so I think that's kind of where I tried to end, saying it's time for us to do more trials to see. There are a number of CPAP trials now, so I think that will be helpful, that they're ongoing. That's not what you were getting at. That's you know, a sleep. Well, it's CPAP. Yeah. Sure. Sure.
But you are
Yeah.
talking.
But there's no evidence that CPAP actually helps cognition or biomarkers. So we have to at least start there. That's an easy one, although it's hard to get people to use CPAP. I think there's a lot. CBT works very well for insomnia. So I think that would be a very, tractable kind of thing to study. I don't know why it hasn't been studied well. Some of these medications I think are really prime. So I think we'll see a lot more in the next 5 years.
The interventional would be go out, explore and learn, because there is quite a lot of evidence, at least in adult brains, not in aged brains. Actually, we have one evidence that is exactly the same in aged brains, that really sleep need, so this slow wave activity measure is a measure also how easily basically you go to sleep. So if you have very high sleep pressure, then you are able to sleep well and deeply for some hours. And all the evidence that I've shown is basically that, well, if you try to exercise your brain during wake, that can be a good start. It can be many.
And also exercise your body, by the way. Yep.
Sleeping well to me is a reflection of physical and mental health. So there is a bit of circularity here.
Yeah. Well, physical health, actually, there is quite some evidence that physical exercise per se does not affect, sleep in a very prominent way. Mental health, I totally agree, but I'm not sure it's circular. It's circular because indeed this balance has to be maintained across the 24 hours. So I think to have good sleep, you have to have a good wake day.
I think that the problem is a good problem, because I would like just to remember the paper that you published. Participants who reported taking sleep medication greater than 5 for a month versus less 1 for a month were significantly more likely to develop dementia. This is a crucial point, What I had to do? I had to take medication just to sleep well, or is much better to take, because this is a big problem. But unfortunately, it's very difficult to answer to this question, because probably when you take a lot of medication, probably you do not solve the problem of insomnia. You continue to have insomnia. And for this reason, I think also that the paper that clearly said, okay, medication are risk factor for dementia. I don't believe it. Because the problem is that probably if you continue to take medication, you have always insomnia. And the problem is that insomnia may play a major role in provoking dementia respect to the medication. This is a very big problem. But this is not just a problem, because we have another problem. This is for Christine. You said that we have to collect more data. It's true. Because I would like just to remember a problem concerning circadian disorders. When you think that sleep delayed phase syndrome may be at risk for developing dementia, but you have to consider that usually sleep delayed phase syndrome patients have a problem of sleep deprivation. So this means that we are not to think about the problem of sleep delayed phase syndrome per se, but is mediated by the problem of sleep deprivation. This is just one problem that we have.
Yes, I do wholeheartedly agree. I thought you were going to get at napping, which is the whole, that's another question. Is it better to nap or not nap? A lot of people want to do a power nap. There's not a lot of data on napping. We did one study, which I think was really interesting, where we showed that napping, older adults who napped, and it was had to be a chunk of time, actually had greater risk of developing dementia. But then what we did was we stratified by who they all had actigraph during that week, and we were able to show that if you had a bad night's sleep and you napped, it was not negative. But if you had good sleep and you're napping, that was the risk factor. So getting at this, you shouldn't be tired in the day if you had a good night's sleep. So we think it's something, either, metabolically, maybe you're sick, you have something else going on, or maybe it's a prodrome, or maybe it's, locus coeruleus wakefulness neurons, who knows? But I think that's really interesting to think about, if you're tired and napping all the time and you've been sleeping okay, then there's something wrong.
Yes, it's true. Another, the last thing, you published a paper, you said snoring was associated with a lower risk of all cause of dementia. So we have to explain, because we said sleep disorder breathing is a cause of dementia, but at the same time you publish this data. I know the solution, but it's just provocative for the
First of all, I'm being picked on by somebody who's done too much homework. I did not take the lead with that study, so I was sort of an innocent bystander. But it was a perplexing result.
Okay, so I would like to thank you, the audience, and the final message is that sleep is crucial for preventing diseases, including neurodegenerative disorders. Thank you so much for the attendance.
Okay, so after this very lively debate, and I hope you're all awake, we are approaching to the last part of this beautiful day, and it's a pleasure for me to introduce Stanley Durleman, who will talk about AI for prevention of neurodegenerative diseases. Just a few words on how AI could be used to prevent such disorders. First, could be a tool for secondary prevention, allowing to identify patients at a prodromal stage of neurodegenerative disorders in order to treat them before clinical diagnosis at a stage where lesions are hopefully still partially reversible. AI can generate progression models, combining data from imaging, wet biomarkers, polygenic risk scores, prodromal signs, and so on, to evaluate the risk and define the timeline to overt disease so that the treatment is started or intervention is started in due course. This would be a great step forward, but in the longer term, I think AI could help spotting individuals at high risk in the general population, moving from secondary to primary prevention. Other tools, of course, would be required, such as the analysis of the individual care pathways with EHR, information about our daily life captured through patterns of our messages, habits, or behavior, including those obtained by many companion apps. So that's the future, but I think Stanley will explain that much better than I do. And a few words about Stanley. He graduated from the most prestigious engineering school in France called École Polytechnique. He specialized in neuroimaging during his PhD and postdoc at the University of Utah, and joined the Paris Brain Institute just at its creation as a team leader, and he used machine learning to develop predictive models of disease progression for Alzheimer's, Parkinson's, ALS, Huntington's, and maybe I forget others. These models allow to accurately predict disease progression up to 4 years in the future, and are the basis of Dr. Nemo, a startup that he has recently launched. Dr. Nemo allows the screening and profiling of individuals at risk for AD and PD. Stanley's work has been launched with starting ERC grant. He has also obtained the INRIA Prize for Young Investigators of the French Academy of Science and the Sanofi IDEA Prize. Just want to add one important information. The name of his team at the Paris Brain Institute is Aramis. Does that sound like familiar? Aramis is one of the three musketeers in the novel of Alexandre Dumas, a choice that really demonstrates that Stanley is committed to fight neurodegenerative disease, even with his sword. Stanley, the floor is yours.
Thank you very much, Alexi. I think you said everything. We can just stop there and have a good dinner. Or maybe I will detail a bit, but truly thank you very much for this nice introduction. I'm not sure I deserve it. Also, I would like to start by acknowledging that I am not a physician, nor a biologist, as you said, just a mathematician and engineer by background, so please excuse me. And I feel very honored to give this lecture in front of you. I would like to start by recalling about this new situation that the approval of 3 new drugs for Alzheimer's disease has raised in the field of Alzheimer's disease. So you know that 3 drugs approved, 2 on the market and 1 withdrawn. I am well aware of all the controversy around this trial, and the purpose of this talk is not to discuss this controversy. What I can safely say, I think, is that now we have at least drugs that could clear amyloid plaques in the brain. There is very strong evidence of this. Another evidence is that, according to several independent trials, this clearance of the plaques slow down cognitive decline in a significant but modest manner in early Alzheimer's disease patients. So my view on this is that the best expectation we might have is to treat patients earlier in the disease course. Ideally, even maybe pre-symptomatic or in the prodromal phase of the disease in participants at risk, where we can clear the amyloid plaques, so acting on the key mechanism of the disease before the onset of the symptoms, with the hope that it will delay the onset of these symptoms. Of course, this has still to be shown, and we don't have clear evidence of that. Also, there is a clear rationale that the risk-to-benefit ratio might be better when treating earlier. So in my view, this new situation creates a momentum where I hope that we'll have a re-engagement of all the field in running clinical trials for at least secondary prevention. And I think the Alzheimer's Association was not wrong when it states that no, the main challenge in this field is not to care patients, is to recruit participants for trial, to generate the evidence supporting the use of this and the next generation of drugs. And for me, it looks like we are in the cancer area maybe 20 years ago, where we have a first line of treatment that is not super effective, but that combined with different other therapeutic lines and with personalized way of treating patients, we might, years after years, gain years against the disease. Running clinical trials is extremely difficult. I think this problem is overlooked, but I think nowadays, I think the main bottleneck we face for the emergence of new treatments. So 85% of trials fail to recruit participants. Okay, that's true for across all therapeutic areas, and I think this problem is even more acute if you think of making a prevention trial in Alzheimer's disease. Then you need to find patients before they have symptoms or 2 important symptoms, and these patients you don't find them. Why? Because of the diagnostic wandering. People surface in the healthcare system only at the mild to severe stage of the disease. So finding early stage individual, even at-risk individual, is absolutely extremely difficult to achieve today. 99% of trials fail to show efficacy. So there is a lot of reason for that. One reason I think, again, not is overlooked, is that we fail sometimes to recruit the right participants for the right trial. So I think or at least the problem we would like to address here, is to mitigate all that risk when you design a trial. The risk that you have not the right trial population, that you cannot assess the outcome of the trial in the right way. And that, of course, has important consequences, not only on cost, but also on the success of the trial. So our vision is to build like a data platform, to act before and after the trial, to have a better control over the trial population, and to better control the risk that this population poses for the success and the cost of the trial. So it comes with two flavors. So in the left-hand side, we are trying to screen for these individuals even before they surface in the healthcare system. And we would like to collect real-world data to identify and profile the right trial candidates. On the right-hand side is more AI-generated data that we can use post-trial to better assess the outcome by better controlling the heterogeneity of the trial population when on the right-hand side we have not done the best possible job. So I will detail these two aspects, starting from the right-hand side and finishing with the left-hand side. So over the years, I've developed this technology called disease course map, which basically can be phrased nowadays as an AI-generated models for disease progression. So to give you a bit of a flavor of this, think about the growth curve. So you know how this growth curves works. If you have a kid that is 9 months old and it weighs 9 kilos, and you report the dots, and you know this kid is within the typical range of variation in a reference population. So basically what we want to do is do the same thing, but not for development, but for aging or disease progression, which actually it's quite difficult. One main reason is that here we use age as a marker of development, but age, of course, is not a good marker of disease progression. You might start disease at 70 years old, another can start at 80 years old. 10 years difference for the same disease stage. These growth curves are descriptive by nature, okay? If you have kids, you know that the fact that your kid is there does not tell you anything about what will be the weight of these kids in, say, a year from now. And here we have the growth curve for the weight, but we have this for the age. So if you have two curves, we can make the body mass index and go back to one single measurement. But here we are thinking of using multiple measurements for patients. So we need, as we say in statistics, to model the joint distribution of all this data. All this data varies when the disease progresses. So I won't go into the details, but what we did essentially is to find a way to describe the difference between a reference model and a progression that is seen on a particular individual. So here, let's assume these two curves, the blue and the red, are it's a model of progression. Okay, I don't explain now how we have it. Just assume for a second we have kind of a model that describes how two biomarkers evolve from the most normal stage at 0 to the most abnormal state at 1. And that the dots corresponds to the data of a patient, where I measure the different two measurements at different time points. So there is a trajectory that is predicted by the model and the trajectories that we observe in the patient. And all the game is to understand what is in which sense these two trajectories are different. So we can decompose this into a series of different parameters. One is a time shift that tells you, okay, this patient is earlier onset than what the model predicts. It progresses slower than the model. And basically the dynamics of the red and the blue are different in the model and in the patient. So yeah, there is a core building blocks is to be able to analyze differences into trajectories of change. So of course, how we built a model, so it's not given beforehand. So we use longitudinal data sets where we have multiple patients seen at multiple time points. And at the end, we built this model to be the most typical representation of the disease progression in this reference population. And we have all the parameters that explains that patient A is different from B, is different from C because of different disease age at onset, because different pace of progression, because of different disease presentation. So at the end of the day, it looks like this. So you have a model with different different curves, and there's different parameters that explain you in the reference population how this model change. Okay, it's not a population, just a population model. It can varies according to different individuals. So we change age at onset, pace of progression, and the presentation of the disease at a given age. That was a very simplistic view with different curves to show the onset of the different here cognitive domain derived from the MMSE. We can play this game with way more complex data, and this is a model where we look at how the cortex becomes thinner and thinner during disease progression. So red means very thick and blue means very thin. That is synchronized with the FDG PET variations. So this is the glucose consumption in the brain that also decreases, and you can see here in the hippocampal area that the FDG SUVR is really getting down. That's a surface of the hippocampus. So you see how the atrophy of the brain induces a change in the shape of the hippocampus, and all that is synchronized with a progressive onset of the different symptoms, starting with memory, then concentration, praxis, and language. There are different parameters I don't play with here that allows to adapt all this for different individuals. So, for instance, you know that memory is usually, in the vast majority of cases, the first symptom to onset. But for some patients, that might be concentration or attention, and then the model can adjust for that and adjust the different areas that are targeted by neuronal loss. So far, these results are more descriptive. Okay, I can describe in a reference population how the different data change over time and how this varies across different individuals in different dimensions. As I said in the beginning, I don't want only this model to be descriptive, but I want them to be predictive of the future of the patient progression. That's actually quite easy to do, indeed, once we have done this modeling. So take again a very simplistic example. We have one patient, we have seen it twice at 70 years old and 71. At 72, we have two measurements, so let's say amyloid PET and MMSE. We normalize the scale and we report the data on this graph. We do the same for the data at 71, so you see you can have missing data, that's not really an issue here. And then, because we have learned how all the possible disease trajectory in the reference population, we can predict what is the most likely trajectory for this patient. And so we compute these different plane curves here that depicts how the patient will change over time. And then it's just a reading exercise. If you want to know what the patient would be at 75, you read these data points, you convert back this to the native scales, and then you predict that this patient will have 90 centiloid of amyloid load, whereas he was 70 at 70 years old. And the SMMSE was 29 and 27 at 70, 71, and you predict it will be 18 at 75. So that's a way we can forecast the disease progression from historical data of the patient. It works here with two visits. You can work with only one. You can work, of course, the more you have, the more precise the prediction. So, of course, it's not enough to claim you can predict. You have to assess that. So we used 5 different data sets coming from different geographies, different countries, amounting for a total of more than 5,600 patients. We built a simple model mixing neuropsychological assessments, imaging biomarkers, and CSF biomarkers. So we built the model, we did our job. And then we trained the model only on ADNI participants, so American participants. And we assessed, okay, on all the different data sets, to which extent we can predict the progression of these different endpoints. All in one, we have made sometimes nearly 100,000 different forecast tasks to evaluate the performance of the model, which I think is one of the most extensive validation of such approach. Long story short, here, for instance, when predicting the ADAS-Cog 13 items, so we make an mean absolute error of 6 points when predicting the ADAS-Cog. This is the result of deep learning methods, so recurrent neural nets, that the usual neural net architecture that is used, for instance, nowadays in ChatGPT or alike. That's more standard approaches that are being used. So we see that in all cases, we manage to have the best performing prediction. And that is for in a very specific context of use and for a specific types of person. And I think the most important result in that one is to see how this performance changes when you change the person to which you predict. And so, again, I won't want into the details, but if you have only one visit instead of two, then of course you decrease the performance. If you have more visits, then you increase the performance. That's expected. I think the most important aspect here is that we have even better performance on Japanese and European participants, whereas the model has been trained only on American participants. And generalizing AI models across different ethnicities and different geographies is something which is really hard to achieve. And here we are very pleased to see that the model is very robust when you change its context of use. So that is two pointers for the two main publications for relating this for these results. But you know, so I was at that point, and I went to a famous neurologist at the Peter Hospital. So I won't say the name for Alexis, but I think you know him. And I presented him this result, and he said, "Well, it's a fantastic job. What you do is great, but what can I do with that? The only thing I can say to my patients is that it can get worse." So it's for me, it's useless. It was quite disappointing for me. But he gave me also a good piece of advice. He said me, like, look, go and see the pharma companies. Probably they will find good application for that. And that was a good piece of advice. Yeah, I also built a model for different diseases. And so I start working on this, on the way we assess outcome in trials. And I understand that this model was a good way to control for the heterogeneity in the trial population, and so to have more precise estimate of the outcome, which is something which is highly needed when running a trial in neurodegenerative diseases. So I don't explain you how a trial works. Very simplistic view again. So we have an inclusion-exclusion criteria. So we have a population to select. We randomize into treated and placebo arm. And then we compute, okay, what is the amount of change in the treated arm? What is the amount of change in the placebo arm? The difference between the two curves come from the biology. Okay, that's dependent on the drug. There is little we can do about that for a given population. The confidence interval here is the part we can play, and we can try to improve. The larger the confidence interval, because you have a large heterogeneity population, then you will fail to show that this effect is significant. If you better control the heterogeneity, you reduce the variance, and then you can show that your effect is actually significant. That's as simple as that. And the main way we use to correct for heterogeneity in a trial is to use covariates. Okay, so usually you include age, for instance, because you think that the drug response depends on the age. You can use sex, of course, because you think that male and female respond differently to the drug. And all that is to try to reduce the variance of the outcome. And here what we want to do is to go one step further and to add another type of covariates that we call prognostic covariates. Prognostic covariates are predictions that you do by combining the trial data that you have at baseline with a model that is trained on historical observation. So that's a smart way to use the knowledge that you gain from the observational data to better inform the trial data. Okay, so you bring new information, you bring new data in a way that makes sense from a statistical point of view, and that can be accepted by regulators. So again, if you do a trial the way you do it usually, so you have a baseline, there is follow-up of the patient, so you measure the outcome at the endpoints at different time points. Oops, sorry. And then the outcome is the follow-up minus the baseline, and you correct for the covariates, so age, sex, value of the endpoint at baseline, and so on and so forth. So what we proposed here is to use the baseline data to create what we call now a digital twin of these trial participants. And we predict then with our model what is the progression of these trial participants without any intervention, so following the natural disease history. And from that, we derive prognosis score. So for instance, the predicted change from baseline, so with the predicted primary outcome that would happen without any intervention. We can have different types of prognosis scores that we can derive from this predicted progression. And then we add this covariate here in the list of the usual covariates. So you see here the trick is that the change that we make in the usual clinical trial setting is very minimal. Of course, there is a big black box in the middle, that is the modeling that I have explained. But when you take that as a component, then to implement that into the current workflow of the trial is really simple, and it makes it very appealing for the people running actually the trials. And this, on top of that, is now accepted by the two main agencies, so FDA and EMA. So they have issued what we call qualification opinion. It was back in 2022 and 2023, so it's quite recent that now this approach can be implemented in real clinical trials. We have done so different simulation first to see how these methods could really improve the power, as we say, of the trials. So there are different ways you think of a power. Okay, it's increase your risk, your chance, sorry, of having a positive result when the drug is truly effective. But you can also think of the number of patients you need to demonstrate the effect, so the effect of the sample size. And so here in simulation, if you have, for instance, in a particular trial that we simulate here, if you have no particular way of correcting for the heterogeneity, you need nearly 900 participants per arm, which is what we found currently in the phase 3 trials. And then we can decrease this number from 38 to 50% in simulations. Okay. But simulations are always great, you know. Real life is always more complicated. So we have worked also with a pharma company that has run recently a phase 2 study in PD. And then there was the study the result has been published, and the primary outcome was a 2.58 point difference in the MDS UPDRS part 2 and 3 in a year. Okay, this effect was not significant, and it was actually negative. Okay, so treated participants get worse than the placebo, but the fact that it's negative here does not play any role in this exercise. So what we do is we train our model to predict the progression of the patient. So here you have just 5 examples of participants' data. So we use only the baseline to predict the progression of these different individuals. So you see how this game is difficult in practice, and you see how heterogeneous is the population also that has been included into this trial. So in the real trial, so they used 4 different covariates trying to reduce the heterogeneity. Okay, that actually allows them to reduce the width of the confidence interval, so from 7.55 to 7.38. Adding our prognostic covariates on top of this allows us to reduce even more the width of the confidence interval up to 7.1. So you might think this is a tiny difference, but sometimes this tiny difference is what makes a difference between a success and a failure. Another way to think of it, as I said, is to say, well, if now you would like to do a phase 3 trial after that, so of course they didn't do it because the effect was negative, but I assume they were planning for the phase 3, you can compute the number of participants you would need in this phase 3. Using the usual covariates of the pharma companies allows them to reduce by 5.5% the sample size compared to using no covariates. Okay? And using, in top of that, our prognostic covariates allows us to reduce the sample size by 15%. So it's a 10% increase in the sample size reduction. Again, 10% is in the low end of what we have in simulation, but still, I mean, that's where you start thinking twice of implementing that, because 10% reduction on the cost in the phase 3 is something which is quite significant. So just to conclude on that part, so adding these prognostic covariates allows us to use the information for the natural disease story to complement the trial data, and all in one, it reduces the variance of the outcome, which has two different consequences: to have shorter confidence interval when you analyze the data of the trial, and to reduce the sample size when you plan future trial. And so this has been shown on real data of past trials, and also on simulation. And we are currently working with another company to analyze the phase 2 data that will be released at the end of this year. So this is getting to be really implemented in real practice. So that was all the use case on using kind of AI and machine learning to better assess trial outcomes. But as I said, that's just one side of the problem. Okay, another side of the problem is how do you find the right trial participant, and how you can include participants at earlier and earlier disease stage compared to what we do today. And that's where we ended up having this concept of digital memory clinics, so which is today just a website if you look at it, and where we are building a healthcare journey for each visitor of this website. So we have orientation questionnaires to answer the first questions that people ask when they come here. I am right to worry about my memory because I just have an event in my life, and I wonder whether I need to go and see a doctor. We had a network of general practitioners that do memory consultation that, at least in France, that does not exist yet. So to have just one consultation in primary care dedicated to memory problems. We also have written reviews of the medical situation based on different data that the patient provides. We are deploying a memory self-test. And also, of course, we are always asking the visitors if they would be interested to participate in clinical trials and studies. And so this patient journey is very modular. And so based on each step, we recommend the next step for the patient. And so we have really something which is tailored to the needs of each person. And we make sure that all the data that has been collected are within a single medical file of each patient. And that's the key, because then that's what we will use to identify the good trial candidates and to profile them and to refer them to the trial sites. So currently, at this time, we have between 3,000 and 4,000 visitors each month. So we collect nearly 1,000 assessment of risk factors each month. So it's a cohort that is renewed every month. Each month, we have 200 persons that declare interested in trials. And we have 40 assessment of cognitive function in consultation. And this is just the beginning of what we are trying to gather. So it's a real world, decentralized cohort, if you wish. That is, yeah, as I said, so renewed every time. Of course, it's not yet enough. It's just the beginning to have enough data to make AI modeling on that. So we used electronic health record from other sources to train model for assessing the risk of the participants. So here I highlight just one single result, and that would be my last results. So that's insurance claim data in primary care. So we used, so we look at all the persons in these data sets, this database, who turned 65 years old in 2010, okay? We have the medical history of all these persons, and we are trying to predict the risk to develop dementia in the future. And then, so we can use this ROC curve here. So at 10 years, to predict that a person which is 75 years old now, in 10 years, we have an AUC of 62%. Of course, it's a very difficult task. Only things that we have is past prescription and past diagnosis. That's the only thing that we have here. But you see that the detection rate, so at 5% false positive rate, so at 2 years, for instance, is 38%. What it means? It means that if I want to run a trial with completely asymptomatic persons that are at risk to develop dementia in 2 years, I can have increase the prevalence up to 38%, which is of course way higher than randomly picking the trial participant in the general population. And that's also 2 pointers of the different publications we have made on this analysis. So I think it's time to conclude. So what I wanted to show you tonight is to say that so artificial intelligence, I think it's an enabler for prevention strategies for neurodegenerative diseases. And I don't see actually other strategies to implement in practice efficient prevention clinical trials. This came with 2 flavors. So I show in primary prevention. So the main bottleneck here is to identify the individual at risk in the general population. That can be done with smart ways by screening participants, collecting real-world data, and assessing the different risks of the participants. And that is the prerequisite to implement and assess personalized primary care, primary prevention measures. In a secondary prevention setting, so when you have for person that with well-established risk, for instance, positive biomarkers, not yet a cognitive decline, we can identify the good person to include into a trial and to decide when is the best time to intervene. Whether this is for drug or for non-drug intervention, again, this is a prerequisite to implement and assess personalized therapeutic schemes. So here I focused on precision clinical trials because I think that's the first step we need to tackle. And only when we will be able to generate strong evidence that these therapeutic strategies work, then it will naturally develop the precision neurology that is needed to see new treatments on the market for caring a large amount of people. Thank you for your attention.
Thank you, Stanley. For a mathematician, I think we are lucky. We didn't have too much equations. So I think it's late, but we still have 5 minutes for discussion. So do not hesitate. I see already a question. You too.
Congratulations for this brilliant talk. Can we push this approach to the extreme and think that in the future we can avoid randomized clinical trials and give the drug and compare the patient with the projected digital patient untreated?
Yeah, of course. That's what we would like to achieve in the long term. I don't think it's very realistic, at least in the short, mid-term, just because the models are not perfect. And so, of course, your prediction, you cannot trust it 100%. So you would need anyway the placebo to assess your model bias and your model uncertainty and to make a fair assessment of the effects. Yeah, avoiding randomization would require perfect forecast of disease progression, and I think it's out of reach given the data that we have and the the variation that we have on these measurements. Because MMSE, I mean, you take it twice and you don't have the same results. Take an imaging, 10% difference in the volume of the hippocampus. So even the data that we have, the measurement that we have are not precise enough to have accurate, fully accurate prediction.
So we should improve the neurologists.
As well. That's part of the...
I don't know if I really fully understood, but my impression is that it depends from how careful was the estimation of the data that you have used to predict the model, how long was the observation, and how complex. For example, if you combine together some body fluid plus the brain atrophy evolution plus some other type of functional tests, then of course you can really approach. How could you establish where you have enough collected data that your curve have an enough narrow confidence that may allow you then to generalize what you expect? Because otherwise you're in the same condition where we have now a plan for a given trial, and then we fail because we have much less event than those we have expected.
Yes, so we need to distinguish the two phases. So there's one phase where we train the model, so the model try to capture as much information as possible. So for that we use the most extensive data set that we have. So it's ADNI in Alzheimer's, it's BMI in Parkinson, plus other different data set of the same type. And we have the standard measurements that we have on that with all the pros and cons. So as I said, it's imaging biomarkers, fluid biomarkers, neuropsychological assessments, basically. We don't work on improving those endpoints. I mean, we take what is currently the best practices in the routine, okay? There are other groups that are trying to find better biomarkers than those ones, but we limit ourselves to the standard ones. So when we train the model, so we do the most that we can, okay? And that's where I evaluated then how accurate can be the prediction. And you have seen, I mean, I make a 6 points error in predicting the ADAS-Cog, for instance, which is the best I can do given the data that I have now. And then there is the second phase where you take the data from the trial, and then you use the model to predict the evolution of these participants. And then again, what we have is what we have. So we make this type of we have this type of uncertainty in the model prediction, which is not perfect. But what I've shown, at least empirically, that when you use that information, then you can still reduce the variance of the outcome. So we switch from 5% to 15% reduction of variance in the assessment of outcome. Would I have better model? I can reach maybe 20 or 30%. That would be possible, but that would need more extensive data and probably better endpoint.
Can take a last quick one.
You mentioned the false positive rate, but what about false negative rate?
Yeah, so actually, I have shown the whole ROC curve, so you can read it the way you want. So that's the standard way. So to have this, to have the detection rate for a 5% false positive rate, that is useful for having precision trials, because that's what you want to do. Is you want to have a population that is the most enriched in the participant at risk, okay? And no matter if you leave interesting potential participants outside. And I think your question relates more into a public health issue, where now we are different. You have the whole population, and you want to track or to monitor a subset of the population where you you want to have the people at risk, and then you are afraid of leaving at risk an individual outside of this monitoring approach. And so that's, yeah, that comes with a different percentage, and so I need to go back to the publication because I don't have the exact answer to your question, if this is your question.
Okay, so thank you very much. It's time to close. If you have other questions, come to see Stanley is here. And I wish you an excellent evening. Bye-bye.